Namaskar and a very warm welcome to everyone present over here. We welcome you on the day 2 of this endoscopic ultrasound and update 2021. Yesterday was a very insightful day with a lot of intense discussions and engaging live demonstrations. Today again, we have a lineup of live demonstrations and a lot of discussions and speakers lined up for you. To start the day, we'll have our first topic that will be endoscopic ultrasound guided biliary drainage. May I request the chairpersons to come on the stage, please. The first chairperson would be Dr. Amit Bhasin, Dr. Pankaj Kumar, and Dr. Piyush Ranjan to kindly come on the stage, please. May I request the moderators for the session, please. Dr. Dinesh Garg and Dr. Ajay Bhalla. The first speaker of the day would be Dr. Vinay Dheer. May I request Dr. Vinay Dheer to kindly come on the stage, please. Dr. Vinay Dheer is online? Okay.
Hi, good morning. Can you hear me?
Any questions coming from the audience, it will come in the chat box. Those who need to take.
Good morning, everyone. I think we'll start with our first session. Welcome everyone for the US Update 2021 organized by Max. And what we're going to start today will be a lecture which will be online by a leading endocrinologist, Dr. Vinay Dheer. Dr. Dheer doesn't require any introduction. He's been the pioneer in doing endoscopic ultrasound, and in fact he has been my teacher. He has learned this technique years ago, and he's been practicing for years and years. I don't recall anyone else who had already started using EUS in practice other than Dr. Dheer. And what he's going to talk about is EUS guided biliary drainage. You know, ERCPs are something which although done regularly, have a small window where the technical failure. There is a failure rate of close to 5 to 7%. And BD was considered always a rescue measure. It was considered a rescue measure for ERCPs. But PTBD has a morbidity of almost 1/3 of the patient having some problem, 33%. So EUS guided biliary drainage is now being considered as a suitable alternative, which probably has lesser amount of side effects. Of course, it requires the skill, but probably it will be the first line of rescue whenever ERCP fails. And to talk about EUS guided biliary drainage, we have Professor Vinay Dheer, Dr. Vinay Dheer, who will be talking about it. Dr. Vinay Dheer, you are online. Sir, good morning. Good morning to you.
Good morning, Ajay. Can you hear me? Can you see me?
Yes, sir. Yes, sir. Very much so.
Okay, thank you for that kind introduction. Nice to see you on stage. You are looking very handsome and smart.
Thank you.
Thanks to the other chairpersons also. Thanks to Vikas and his team for this kind introduction. I would have loved to come, but I'm very scared of COVID. So I told him last moment I'm not coming because of this Omicron scare. So coming to our topic, EUS guided biliary drainage, I have changed the topic a bit. I have changed it to how to perform EUS guided biliary drainage. I think that is more practical. So I published my first article on EUS BD exactly a decade ago. That is 2011. And I distinctly remember at that time, most of my friends, experts and other friends did not believe in this technique. They thought that it is unnecessary and it's not really required. But over the years, the perception has changed. And today, I'm very happy that in our country alone, I know of at least 100 people who are performing EUS BD, and internationally it is accepted as an alternative technique for biliary drainage in patients with failed ERCP. So the concept of ERCP as the sole technique for endoscopic biliary drainage has undergone an evolution. Now you have ERCP, the mainstay for biliary drainage, but you also have EUS guided biliary drainage and then enteroscopy assisted biliary drainage in patients with altered anatomy. So biliary drainage, endoscopic biliary drainage is not ERCP alone. ERCP remains the mainstay, but there are other ancillary techniques, and EUS guided biliary drainage is one of them. So how to do it? For this is primarily aimed at beginners, those who are doing EUS, who are doing EUS FNA and who want to branch out into EUS BD. None of us endoscopists like to refer our cases, although we have brilliant interventional radiologists who do great job. But it involves a problem. You have failed in occasional cases doing your ERCP, and then you have to tell the patient that you have failed, and then you have to call the radiologist and you have to take another informed consent for another procedure. Some of your interventional radiologists will do it in 2 stages, an external drain followed by an internal drain. So it leads to a lot of patient discomfort, and it would be ideal if you have EUS BD at your center, and if your ERCP fails, unfortunately, you just change the scope and perform the biliary drainage by EUS guided approach. So what is needed for a successful EUS BD is a good indication, a right indication, the right procedure. There are multiple procedures, as I will tell. The right accessories you need at your place. Some of them are ERCP, some of them are unique accessories, the right kind of stent. And most important thing is the right training, which I know is difficult to get anywhere because the number of cases are less even at the expert centers, but we will discuss about it later. So what are the right indications for EUS BD patients who have failed ERCP? You have attempted an ERCP and you have failed it. So what is a failed ERCP? The definition varies. Most common cause of a failed ERCP is failed cannulation. So patients with duodenal stenosis and post-surgical anatomy, obviously ERCP will be impossible or very difficult. But patients where you can reach the papilla also, in about 3 to 15% of cases, you are not able to cannulate for various reasons. So these are the cases where you can think of EUSBD. Now, some literature mentions a second attempt at ERCP after you fail once. I think it's a waste of patients' money and your time. A second attempt, my personal feeling is, should not be done. If you have failed for about 10 minutes to cannulate, the selective bile duct cannulation is not possible, you should consider it a failed cannulation and move on accordingly. Otherwise, you can have complications like pancreatitis. Duodenal stenosis, of course, you can dilate the stenosis and go in and do an ERCP in some cases, but in majority of cases, you go for alternative methods. And then, of course, post-surgical anatomy is a difficult thing. If you have expertise of enteroscopy, you may try an enteroscopy assisted ERCP. Otherwise, USBD is a faster and easier technique to perform biliary drainage. So this slide is a little scary, but it just shows a number of EUS guided interventions that have come across in the last 2 decades. Basically, broadly, there are 2 main procedures. One is an access procedure called the rendezvous. Rendezvous is a procedure where you use EUS only to pass a guide wire, antegrade, from the bile duct across the papilla into the duodenum. And then you do ERCP. So this is a hybrid procedure, not only EUS guided. This is rendezvous is a hybrid procedure which involves both EUS and ERCP. And then, of course, you have EUS guided biliary drainage. There are 2 main types of biliary drainages. One is where you use papilla as the exit. So transpapillary drainage, like we do in ERCP. That is called the antegrade drainage. And the other is a transluminal drainage, where you create an anastomosis between the biliary system and the stomach or the duodenum. So choledochoduodenostomy or hepaticogastrostomy. And then there is a third very nice procedure called gallbladder drainage, EUS guided gallbladder drainage, which we will not discuss today. So these are the variety of procedures available to us, and that is the beauty of EUSBD. You do not need papilla to access the biliary system. You can access the biliary system at multiple places. So let's look at hepaticogastrostomy very briefly. As the name suggests, you make an anastomosis between the left intrahepatic biliary system and the proximal stomach. So this is a dilated left intrahepatic biliary system, and you're using a 19 gauge EUS needle to puncture, aspirate, confirm that you are in the biliary system, use Doppler so that you know you're not going through major vessels. Once you are into the biliary system, you pass a wire, and then over the wire you pass a dilator, which can be a cystotome or a balloon, and finally you place a stent. There are special stents available for hepaticogastrostomy, but you can use ERCP stents, partially covered stents also, or plastic stents also. So this is hepaticogastrostomy. It's usually done 2 to 3 centimeters below G junction. And the critical part, which is very important, is you should learn to leave at least 3 centimeters to 4 centimeters of the stent in the stomach. Why? Because there is no tumor to hold this stent. And if you leave it very close to the stomach wall, it can migrate inwards. If it migrates inwards, you can have a leak, a bile leak in the peritoneal cavity. So these stents we will discuss later have a cover. You can see this is a covered stent, have a cover which prevents bile leak. So this is hepaticogastrostomy in brief. Antegrade procedure is similar to hepaticogastrostomy. The only thing is you learn to pass the wire across the hilum through the bile duct across the papilla, just like how our interventional radiology colleagues do for their PTBD. So this is a post-Whipple's patient, a very old video of mine. You puncture here, you have to pass the wire all the way across the papilla. In this case, it's an anastomosis, post-Whipple's case. Once you pass the wire, you use a dilator. We use a 6 French cystotome standard accessory at our place. And once you have dilated the area, change the wire to a stiff wire and then place a stent. The advantage of antegrade procedure is you can use uncovered metal stents because they are cheaper. And of course, you can also put plastic stents for benign indications or if the patient cannot afford. So it works out cheaper to use the old ERCP stents compared to the EUS specific stents. But if money is not a problem, of course, you use EUS specific stents. So this is antegrade procedure, a very, very good procedure, my favorite procedure in most of the indications. What about choledochoduodenostomy? You are here creating an anastomosis between the duodenum and the bile duct. So the duodenum and the bile duct are very close together. The most important thing here is to remember that your scope should be in long position, in such a position that your accessories easily go towards the hilum. If you have a bent scope position, the accessories may go like at 90 degrees and you may find it difficult to pass the accessories up. So scope position is critical here. Once you have a good scope position, the procedure is very easy. It will not take more than 3 to 5 minutes. Same thing, pass a wire across. If actually dilatation is not needed in these cases, because duodenal wall is very thin, but you can dilate with a 6 French cystotome and then place a stent above. Choledochoduodenum, I think one of the easiest procedures amongst all the EUS BD, provided you have a good scope position. Rendezvous is half EUS, half ERCP. So here again, the scope position is critical. Your job is just to pass a wire across the papilla and then put an ERCP scope by the side. So here we are puncturing the bile duct. This is again a very old video of mine. Scope position I will show you on fluoro is critical because here in comparison to choledochoduodenostomy, you see here the scope position is completely different. It's looking down towards the papilla so that the wire passage can be easy towards the papilla. This may not be possible in all cases, but the idea is to keep a scope position where your needle is looking down. So semi-long or long, some people do it in short scope position also, but the scope is then, it flips out pretty easily into the stomach. Once you have passed the wire across the papilla, you leave the wire in place, remove the echoendoscope, pass the ERCP scope by the side of the wire. You see the wire exiting from the papilla. Try cannulating by the side. You will succeed in 80% of cases. If you don't succeed cannulating by the side, then you pick up the wire with a snare, bring it out into the biopsy channel of the ERCP scope. And once it has come out, you thread your sphincterotome, cannulate, and complete your ERCP. Very, very useful. Right now, nowadays, we are using rendezvous only for those occasional benign cases where we fail. And we are using it now without contrast, purely based on our EUS assessment. So these are the two modifications we have done in rendezvous technique. What about the stents? Very, very important. So you can use the stents borrowed from the ERCP. Advantage is they are cheaper. The plastic stents, fully covered stent, partially covered stent. Uncovered stents you can use for antegrade procedure, but for transluminal procedures, you need some sort of cover to prevent bile leak. Then you have EUS specific stents, the lumen opposing metal stents, the biflange metal stent. Nagi stent is generally not indicated because it is too soft. So lumen opposing metal stents are thought to be better. And then for hepaticogastrostomy, you have the tubular stents. You see here 70% cover. Here you can see the cover here. So there are different kinds of anchoring mechanisms in different stents. All of them are good. So lumen opposing metal stents you can use for choledochoduodenostomy. There are special small diameter stents, 6 millimeters and 8 millimeter stents, because the larger stents allow food to go into the bile duct. So don't use the 15 mm and 20 mm lamps here. You use the 6 or 8 lamps for choledochordiornostomy, and only use them if the bile duct is sufficiently dilated, at least more than 12 to 13 millimeters. Otherwise, you will find it difficult to place a lamp. It can puncture the opposite wall. It is good idea when you're using the lamps to first do it over a guide wire. Then it will be easier. Don't do the hot technique in your first few procedures. The hot stents are a great advantage because you don't need a wire. You see here, you have a cautery at the tip, so you can directly puncture into the bile duct. Do it only once you have experience of a few cases with a wire. This saves time. It's a very fast technique. You can finish it in practically 1 minute. So this is a beautiful idea for the future. You want to do a biliary drainage and you can finish it off in less than a minute. So let's see what happens in future. Some specific plastic stents are not available in India, but this is Professor Ito's creation for hepaticogastrostomy. I have used it in several cases. Great stent, very good material, stiff. It has a tip you can see here and multiple flanges. And these are useful for benign cases where you need to go in again and again. So briefly, the choice of stent for rendezvous, you can use the standard ERCP stents. There is no problem because you're going through the papilla. For CDS, if the bile duct diameter is smaller, use a short covered metal stent, a 4 centimeter or a 6 centimeter. If the bile duct diameter is more, you can use both. You can use a covered metal as well as a short, small lamps. For hepaticogastrostomy, you can use plastic stents, and of course, I showed you the tubular stents. And for antegrade, you can use uncovered metal stent. So these stents you should have at your place. Plastic stents, the initial literature showed a lot of complication. You see, this is from my Japanese friend because they would perforate. But I suspect these were done very early when the technique was not perfected. And so they had problems. So the general recommendation is not to place plastic stents because it can cause either a perforation or bile duct leak. However, you know, in India, the situation is peculiar. Some of our patients can't afford and they don't have insurance. So sometimes you have to use a plastic stent because your ERCP has failed. We have tried it in a limited number of patients and we haven't encountered any biliary leak or perforation. So it's too early to say anything, but my personal belief is if you have expertise, what we do, of course, is use a double pigtail, not a straight stent. And other steps are practically the same. So maybe we will have data after some time, but I believe plastic stents are not so bad as it has been shown in the literature. Scope positions I touched briefly are extremely important. When you're learning EUS BD, it's just like ERCP, how you put your scope in front of the papilla and practice getting good scope positions. You have to do the same because there are different positions. This is a segment 2 radical, the position is very different. A segment 3 radical, the position is very different. You will have live demonstrations, I'm sure today experts will tell you. For choledochordiornostomy, I told you it's a long position. So different positions, this is a rendezvous. Learn all the scope positions. So you will need at least 50 procedures before you feel comfortable with all these positions. Spend some time before you puncture. Look at the scope position under fluoro, see it is ideal, then only puncture. Briefly about the procedure, I'm sure you will have lots of live procedures. So you have, this is segment 2, this is segment 3. We puncture usually segment 3. So 19 gauge needle, this is the blue mark. So first do Doppler, find out that there is no major vessel here. And then the trajectory of the needle, you learn this by doing EUS FNAs and FNBs. The trajectory has to be understood. Use a fluoro first to see that your needle is looking towards the papilla and not towards the hilum, not the other way around. If it goes in this direction, then you will never be able to pass a wire. So once you have confirmed all those things, puncture, aspirate bile. Once you have confirmed, inject contrast. Now here, if you see, this is not a great position. I'm puncturing here. The wire will go preferentially in this direction. So I need an expert wire manipulation where I need to pass the wire from here up like this, and then again turn it here, and then this is the stenosis. So one way is you can improve this position. How do you improve the position? Push your scope a little more down so that the needle becomes straight in this axis. The other thing is learn wire manipulation. It's not very difficult. You can do it yourself or teach your assistant to use a J-tipped Terimo to manipulate the wire at 90-degree angles also. It's not very difficult. I will show you in the next. I will miss this one. This is the guide wire passage. See the same case, the wire is going here. See this? So it will bring it back. Small 5 millimeters, 1 centimeter increments of wire. Don't push too much wire because it will shear. So rotate it between your thumb and index finger so that it looks upwards, and then gently in small increments, keep rotating till you get the desired direction. See here, now it is rotating. See this? Now it is rotating so that you can reach here. Once you reach the obstruction, you coil it and then use a cystotome. The cystotome helps because it will stabilize the wire. So cystotome is being passed. Remember the angles. This is like playing soccer. The angles are very important. So you have one angle here, one angle here. And see, this is a very acute angle. At that time, you and your assistant have to learn to cooperate and see that the scope doesn't go back. Once you are here with your cystotome, your wire is stable and you can easily pass it beyond. There is no problem in passing the wire. You see how it is going? It went pretty straightforward into the duodenum. And then, of course, you can do the other procedure, other techniques. Use a stiff wire once the Terimo has done its job. So we are in the duodenum. So this is a very important and very exciting part to learn. You can also use a Visigline O25, very, very good wire. Now in SEMS placement, once you have dilated, is pretty easy. Now you see here, we are using a stent. See the angle here? It's a very tight angle. And when you push here, your scope will tend to go back. So you have to be very gentle and your assistant has to keep the wire tight. Once you cross this angle, then there is no problem. Then you are easy. Once you are into the duodenum, inject contrast, see that you are in the duodenum, assess where the papilla is like to be. This is our intervention radiologists have taught us. So this is probably the papilla here. See this? So keep about 1 centimeter outside and then deploy the stent. This is important because if you put too much of the stent in the duodenum, it will hit the opposite wall and it will not work well. The advantage of using uncovered biliary stent of ERCP is that if you're not happy with the position, you can close the stent till a certain position and then again redeploy it. So this is how you do the stent placement. Some of my Japanese friends again place a plastic stent here between the stomach and the left system. Once they have deployed this stent, we don't use this technique because we haven't experienced much bile leak. So this is some of the technical things, technical details. Now, if you have a benign stricture, you see nicely dilated radical, post-hepaticojejunostomy. I'm going fast forward. See here, this is a hepaticojejunostomy. You pass the wire across, use a balloon, a hurricane balloon to dilate. You can also use other dilators. Once you have dilated it, I'm passing a plastic stent across to, this is the Itoi stent which I talked to you about. And then I can go in again and again every 2 to 3 months by the side of the stent and keep dilating it or placing stents into it. So this is an exciting possibility for benign strictures. You know, these are very, very difficult clinical problems. If your ERCP has only partially succeeded in managing a Hyler block, which happens in type 3 blocks, you use EUSBD for the left system. See here, there are two metal stents already, but the patient is still in cholangitis because the left system is still dilated. It is not draining. So you go inside and place a hepaticogastrostomy, and the pus and the bile comes out. The patient gets relieved pretty fast. So this is also evolving as a good technique where you use ERCP in conjunction with EUSBD for complex Hyler blocks. We need more data, but this is an exciting prospect. And of course, this is, I think, one of my oldest videos, 2008, patient of C-head pancreas, duodenal stenosis, as well as obstructive jaundice, take a biopsy, do a choledochoduodenostomy, and then place an enteral stent. Of course, nowadays we are doing GJ, we are not doing so much of enteral stent, but this is a great technique where in a single setting you have palliated both the biliary system and the enteral system. I talked about training. Cases are less everywhere, so models are very important. We have been working on the models for last 8-9 years, and we have created various different models for EUSBD. This is our latest model. We call it Magic Box. It will be in a journal very soon. So this is a multi-purpose model, easy to create. I don't hold any copyright, so please create it if you want. A pseudocyst, a biopsy, a GJ, you can do an antegrade procedure, you can do a pancreatic duct rendezvous or a pancreatic duct stenting. Multiple procedures just in one simple box can be carried anywhere. You can use fluoro, no need, there is a camera. So if you don't want to use fluoro, you want to show it in conferences, show it in conferences. So this is our latest innovation, and I hope it will be useful for training. This is my last slide. Expertise has to be gained. It is important that you should be good in your ERCPs before you try EUSBD. Don't use it as an excuse for a poor ERCP technique. So expert centers. As I told you in the beginning, I don't like to refer my patients to my radiology colleagues. So at my place, now probably in a year, we will have 1 or 2 PTBDs. Everything else is replaced by EUSBD. And I'm sure it will happen at most expert endoscopy centers. We use it as a first-line option for duodenal stenosis and post-surgical anatomy. We don't waste time using enteroscopes. It takes time. You may not succeed always. Then, of course, you need to be good at EUSRV because rarely, especially in benign indication, very rarely you may not be able to cannulate. So a rendezvous is a very fast and efficient method. Using EUSBD without ERCP, although there are 3 randomized trials which show that it is as good as ERCP for distal malignant blocks, I would say we wait for better data because ERCP is there for 5 decades. So ERCP remains the gold standard. Only when ERCP fails, utilize EUSBD. Thank you very much for listening out to me.
I think that was a fantastic presentation. And since Dr. Geer is online, we would open this house for some questions. For the others, we will follow a discussion which should be later. So any questions for Dr. Geer? It's open house, and yes, please.
What stents can you use for
Dr. Geer, the question is, what are the kind of stents which can be used for EUS guided hepaticogastrostomy? Hepaticogastrostomy.
Now, these are typically tubular stents. So if you have EUS specific stents, very good. Try a stent which is at least 8 centimeters in length, at least. Preferably 10 also is good. The longer the length, the better. The cover should be minimum 70%. So it should be minimum 70% cover. So you have a variety of stents available in the market. You have Geobor, you have the Bona, and many of my friends also use the ERCP partially covered stents, which is okay, no problem with that. Some of my colleagues have also used plastic stents. I would say it is okay as long as you do not dilate too much and the patient cannot afford. So the first choice should always be partially covered metal stents. If you do not have it, if you do not can't refer it somewhere else, you have to drain, then you may use a plastic stent also. It is okay.
We have our team of chairpersons. Dr. Piyush, any questions from your side? Dr. Amit, Dr. Pankaj?
Dr. Veer, how do you think that in lower end malignant blocks, EUS guided bile duct drainage replacing routine ERCPs, as you said that in most of your antral stents you like to do GJ. So by the same logic, do you think routinely one should be shifting to EUS guided stenting rather than going through the papilla to prevent the tumor ingrowth?
Yes, it's a very attractive hypothesis, very, very attractive idea, Piyush. It might happen, may happen in future as things develop. But currently, I would say the data, I look at all the randomized trials with a lot of respect, but when I look at the data, none of them have shown superiority of EUSBD. Probably the Korean trial said that there is less pancreatitis, but the ERCP success rate in Korean trial was very low. So I would not buy a success rate of 76% with ERCP. That means the center is probably not doing good ERCPs. And that's what I said in my lecture. Do not replace it as an excuse for a poor ERCP technique. So I love EUSBD. I'm a great proponent of EUSBD, but I would say please, because ERCP is still being taught, there is expertise is widely available. I would still say ERCP should be tried first. Maybe 10 years down the line, this will change, but currently ERCP remains the procedure of choice, except as I said, if you have duodenal stenosis or if you have post-surgical anatomy, then by all means go first for EUSBD, no problems.
What about patency? Does it increase the patency of the stent?
So there are a few trials which have more than 100 patients. Most of the trials are small, unfortunately. And the stent patency is comparable to ERCP. So as I said, because these cases are less everywhere, the data, the publications have only 50, 60, 65 patients. You do not have a study which has 500 or 600 or 1,000 patients as yet. So we are not very clear. But one thing is there, that it is not inferior to ERCP. It appears to be more or less the same. Whether it is superior, we need a very large randomized study to see whether it is superior to the stents placed via ERCP.
Yes, I think I'll ask a question, sir. There was a thing about CO2 insufflation being used. It's essential. Is it essential when you're doing a hepaticogastroscopy?
Yes.
Is it important to use? And
yes, Ajay, I think it's a very, very important question. I think any interventional procedure where you are going through walls or a long intervention procedure where you're not even going through the walls, I think CO2 is a good idea because here at least you're puncturing. So you know that something will escape. So CO2 is a good idea. CO2 is a must. You should have CO2.
yeah, Dr.
Dr. Vinay, good morning, Dr. Vikas here. Excellent lecture as usual. My question is regarding ERCP. The most feared complication is the acute pancreatitis, and there are certain high risk factors like young female and nearly normal LFT and small stone. These are the patients who had high risk of acute pancreatitis. Do you think in these patients primary ES rendezvous can be tried in spite of despite of ERCP?
So again, there is no data on this. It's a very, very good idea You know, there are certain patients who are at a high risk of pancreatitis. I would love to have a trial to see whether rendezvous reduces. My personal feeling is rendezvous is a very good procedure. It's safe, very low rate of complications, provided you are good at keeping a scope position and passing the wire. It's a little cumbersome for most, so people don't use it. But my personal impression is it's a great procedure in patients where you deem cannulation to be difficult. So we don't spend much time. As I said in my unit, 10 minutes is the upper limit of attempting a cannulation. After that, we don't attempt because then you have pancreatitis. The more you poke at the papilla, the more pancreatitis it is. So already the benchmarks are shifting, and we are shifting to alternative procedures, either a pre-cut or a rendezvous pretty early. When I was learning ERCP, we would try for 1 hour, 1.5 hours without any fear. But now we know better that we are risking pancreatitis in our patients if we poke for a longer time. So because that's a great idea, let's do a randomized trial and together and see whether this group of patients benefit by a rendezvous first. It's a great idea.
Yeah, there's another question from the house.
Good morning, sir. Excellent presentation as always. My question is how to determine the position of papilla while placing antegrade stent on fluoroscopy.
That's a very, very good question. Hi, how are you?
Thanks, sir.
Nice to see you. How to determine is once your cystotome is in the duodenum, you inject contrast, look at the duodenal folds, and you see where the cystotome is crossing the duodenal wall. That is where the papilla is. So you have contrast in duodenum,
Yes, sir.
and your cystotome is going through that contrast. So where the cystotome is entering the contrast is the position of the papilla.
Thank you, sir.
So one more question. Sir, how much complication do you encounter in your experience? And is the most of the complication itself tackled with the endoscopy theater itself, or we have to do something else?
So what I have learned is you are good with your ERCP, your USBD complications will be less. In our experience, we haven't had very severe complications, but we have had bile leaks. We have had problems where the stents have migrated, and we have had to call interventional radiology colleagues to intervene. We haven't had. We have had some bleeding. One bleeding happened 2 days back also, but not so significant, severe. But if you look at the literature, the procedure is considered to have more complications than ERCP. And I believe it is so because it is still in the development phase. As time goes by, as experience increases. So when you do your first 30, 40 procedures, obviously your complication rate will be higher. But you have to play it safe. Don't be very aggressive in the initial procedures. Perforations and bile leaks. These are the two major complications that need to be avoided. Minor bile leaks, you don't have to worry. Major bile leaks, which require intervention, are the ones which. So initial bile leaks mostly happened with hepaticogastrostomies when the stents were not manufactured with the appropriate cover. So the stents would slip and patients would have bile leak. Now that problem has become very, very less. So if you see recent publications, you would not see much bile leak. So my estimation is you should have single-digit adverse event rate with EUSBD once you have done about 40 to 50 cases.
So how the EU started specific plastic stent are different than daily plastic stents?
Yes. So plastic stents, literature is not there. The literature scares you about plastic stents. What I would say is, if your patient can afford, go by the literature, please place a metal stent. However, if you are in a situation where your patient is non-affording and you are in not a position to shift the patient to a higher center or somewhere, please, because a drainage is required, place a plastic stent. Just dilate less. Don't dilate too much. Then there will be leaks. So 6 French cystotome is the maximum that you are permitted. You can place a plastic stent. Place pigtail stents. Don't place straight stents because they will migrate easily. So keep them in your armamentarium. Don't use them as your first option.
One final question, sir, for you, and then we'll close the session. Yes, please.
Versus H.
Various positions, scope positions of RV versus HDS.
I couldn't hear the question. Can you repeat, Ajay?
Asking that can you show the various positions for RV, for US guided choledochostomy and choledochogastrostomy.
HDS, RV, HDS, and CD.
Yeah.
Hi, how are you? Nice to see you. So the positions for liver, where you are trying to pass the wire from the stomach, are different depending on what you are using B2 or you are using a B3 radical. As I showed in my slide, a B2 radical is very good for RV because it is very straight. However, in case your wire doesn't pass and you have to place a hepaticogastrostomy as a salvage procedure, your stent will come in the esophagus, which may not be ideal. So try a B3 position always. For a B3 position, you have to push your scope down just beyond the G junction, turn clockwise and tip up. And then look under fluoro that your scope is looking towards the hilum. So that is a position for both HGS and for rendezvous. For choledochoduodenostomy versus rendezvous in the duodenum, the position is exactly opposite. For choledochoduodenostomy, your scope has to be in long position and has to be looking towards the hilum, not towards the papilla. And for rendezvous, you have to use a position where the scope is looking down towards the papilla. So you have to push your scope into the bulb, use a little up and clockwise rotation like you do for ERCP, but in the bulb, so that your scope is looking down towards the papilla. Take the needle out a little bit, see the trajectory of needle. Is it down towards the papilla or up towards the hilum? If it is up towards the hilum, it's a wrong position for rendezvous. Don't do it. If it is down, yes, then you can puncture.
Thank you so much, Dr. Uday, for an excellent talk. I think he deserves a round of applause from all of us here. Thank you so much, sir. Thank you. And we'll move on to the next session now. Thank you.
Thank you.
The next speaker is Dr. Sound. I think he doesn't need introduction as a part of the organizing committee and he's also known as an artist with the scope. So the topic is EUS and pancreatic fluid collections. And I would request all the subsequent speakers to please stick to the time because we are already late in the session and the questions can be taken at the end of the session because we have some dedicated time for the question and answer.
Thank you, sir. The topic has been assigned today is US and management of pancreatic fluid collections. I will be talking about pancreatic fluid collections associated with acute pancreatitis. EUS is just a part of the management of acute pancreatitis, and pancreatitis is a dynamic disease with various facets. And my talk outline would therefore initially just talk about pancreatic fluid collections associated with acute pancreatitis in general, and then I would like to move on to the role of EUS. The technique of drainage itself has been beautifully demonstrated already yesterday, and we have a couple of cases lined up today also. So I will not be dealing much with the technique of cystogastrostomy, and I would like to look at the role of EUS in the management of acute pancreatitis in general. So just to recollect, the nomenclature, the revised Atlanta classification for acute pancreatic fluid collections have made it very easy to classify these collections. 85% of our patients have acute pancreatitis, which is interstitial without any necrosis. When the collections are less than 4 weeks old, the term is acute pancreatic fluid collections. And when they're more than 4 weeks, they're termed as pseudocyst. The pseudocyst has no solid material, and both these collections can be sterile or infected. 15% of patients have necrosis and are termed as acute necrotizing pancreatitis. And when the collections are less than 4 weeks, they're termed as acute necrotic collections. And when it's more than 4 weeks and the world of pancreatic necrosis, the world of pancreatic necrosis is a mature encapsulated necrotic collection with a well-defined wall. Any of these collections can either be sterile or infected. This is just a pictorial representation. The pancreatic duct and the parenchyma is intact, and when there's fluid less than 4 weeks old, then it's acute pancreatic fluid collections, and when it is walled off, it's termed the pseudocyst. When there's variable amount of pancreatic or peripancreatic necrosis in the collection, then it's acute necrotic collections, and when it is more than 4 weeks old, it's termed as walled off pancreatic necrosis. So a small slide about the genesis of these collections. So generally small collections are due to inflammatory exudate during the acute process, and it's also due to a vascular leak and possibly due to leak of pancreatic secretion, especially from the smaller ducts. But when we have a large collection, it's generally because of a pancreatic ductal leak in necrotizing pancreatitis, and mostly interventions are required in these collections, which are large, as smaller collections, as we know, themselves resolve. So in the management of pancreatic fluid collections, the how, when, and why, then the indications for intervention, the timing of intervention, and the type of intervention is what I will be dealing in the next few slides. So indications for drainage, I think the audience is well aware of all this. The major indication for drainage that we face in our clinical practice is, of course, suspicion of infected pancreatic necrosis. And the other indications that we see are ongoing organ failure for several weeks after the onset of acute pancreatitis, but there is no infection. Still, the collection will need to be drained. When patients have sterile necrosis, that it's causing gastric aorta obstruction or any kind of intestinal or biliary obstruction with pressure effect, it may drainage. And sterile necrosis with persistent symptoms like intractable pain in patients with walled off necrosis may also need drainage. And of course, the disconnected pancreatic duct syndrome, which I will be dealing later, which causing persistent recurrent symptomatic collections also will require drainage. And all drainage is preferably done when they're walled off, that is, when they have a wall around them between 3 and 4 weeks. So the timing of intervention, preferably it's after 3 weeks of onset and when the collections are walled off. What happens if you intervene very early? There's a lot of adherent and partially liquefied debris. Therefore, it's prudent to wait till the debris becomes organized. And interventions of any kind within the first few weeks may be associated with very grave adverse events. And therefore, the drainage should be reserved for infected necrosis. Early drainage should be reserved for infected necrosis only in clinically deteriorating patients with acute pancreatitis, because as all of us know that the waiting is one of the hardest part, especially when patients are not improving within the first 3 weeks, when there's a lot of fluid collection in the abdomen. It's very difficult to wait, and therefore early drainage should only be reserved for patients with infected necrosis who are not improving at all in the first 3 weeks. So this is the latest trial from MEGM. This is called the Pointer trial, which looked at early drainage versus waiting till the collections have been walled off. So they drained the collections within 24 hours of diagnosis of infected pancreatic necrosis, and in some patients they waited till the wall was formed. And 103 patients were included, and there was no superiority of immediate drainage over postponed drainage, especially in regards to complications occurring in these patients. And in patients with delayed drainage, they saw lesser interventions were needed. And they also noticed that patients in the delayed drainage group, about 40% of the patients did not require a drainage at all. So if you wait enough, there may be 30 to 40% of the patients who may escape any kind of interventions and may resolve just with antibiotics and a small catheter drainage. And therefore, the trial concluded that the early drainage is not superior to delayed drainage, and whenever possible, it's of course prudent to wait till the wall is formed. So in the last few decades, there's been a paradigm shift in managing infected pancreatic necrosis. In the early years, it was all surgery. But as time has progressed, it's been shown in several studies that the more minimally invasive you are in pancreatitis, the patients will have better outcomes. And the reasons
for the paradigm shift in the last decades, of course, has been improved techniques, especially radiological techniques, pigtail drainage. Now, progress in endoscopic interventions. We have different kinds of interventions for draining and also for removal of infected necrosis endoscopically, which have been developed in the last few decades. And this has been confirmed that minimal approach and conservative approaches to be better than surgery in several studies. And now it's clear that the minimal intervention is what will lead to better outcomes in patients with acute pancreatitis. So dealing with acute pancreatitis needs a multidisciplinary team approach with an interventional radiologist, and at the other end of the spectrum, of course, ward debridement and surgical necrosectomy. And we, of course, come in between with the ability to drain these collections endoscopically and also perform necrosectomy endoscopically. Now, EOS in pancreatic fluid collections mainly has a therapeutic role. Diagnostic role could be just to assess whether they can be drained and the relationship with the pancreas, the amount of necrosis, and to look at the duct. But the real role of EOS, as we all know, is in therapeutics and acute pancreatitis. Endoscopic drainage is just a creation of a fistula between the Waldorf collection and the lumen of the gastrointestinal tract. So these collections that you can drain by EOS have to be at anatomically favorable locations. They should closely abut the stomach and the duodenum, and as I mentioned previously, should be preferably walled off. So the timeline of these procedures: the first endoscopic pseudocyst drainage was done in 1985. Soon the technique was applied to the drainage of Vaughan, and in 2000 endoscopic transmural necrosectomy was first reported. And after that, these drainage procedures have now become the treatment that is preferred to drain these collections whenever feasible. So earlier days, it used to be direct puncture of these cysts and drainage that was done. The bulge of the pseudocyst or the Waldorf collection was visualized just on a duodenoscope and punctured directly with a needle knife and drained. But EOS-guided procedures are now preferred wherever expertise is available, mainly because of its advantages. The puncture is possible even when the bulge is not visible. For example, tail collections sometimes may not cause a bulge over the stomach. The color Doppler especially helps us identify vessels in the walls, because one of the main problems with this drainage procedure is bleeding, and the adequate visualization of the necrotic debris, and therefore we can decide what stent to place if the procedure is done EOS guided. So this is a trial which looked at this direct drainage versus EOS drainage, and they found that the technical success was much more than when it was directly drained. When EOS was used, the technical success was almost 100%, and the complications were also less when EOS guided puncture was done, and therefore EOS guided puncture is always better than direct puncture. Now, coming to pseudocysts as such, when I say pseudocysts, it means the collections with clear content and no minimal necrotic debris. The technical success rate is almost 100%. We can drain most of these pseudocysts by using EOS. And there are studies which have compared the number of stents and the size of stent when they found similar or more or less the same outcome. And there are also studies which have compared endoscopic and surgical cystogastrostomies for drainage of pseudocysts. And most studies have found that an endoscopic drainage, when safely done, is the modality of choice when compared to surgical cystogastrostomy. Patients have shorter stay and less interventions needed when they're drained endoscopically. Now, moving on to Waldorf necrosis, of course, the success rates here with endoscopic drainage are lesser than that of pseudocysts, obviously because of the amount of necrotic debris in these collections, and they require further interventions even after they're drained. Further interventions can be placement of a nasocystic catheter and irrigation of these cavities, placement of multiple stents within the cavity, and necrosectomy, and development of novel metal stents have changed the management of endoscopic drainage of Vaughan, and also the advent of direct endoscopic necrosectomy have helped us manage Vaughan endoscopically. So how have the stents changed the management of Waldorf necrosis? Now we have various metal stents which have a wider mouth and lead to more
ensure easy drainage of necrotic material. We have the lumen opposing stents, the hot exhaust, and also the biflange metal stents. These are the stents that are there. They're generally fully covered stents, and some of these stents are now electrocautery enhanced, and therefore the stent can be delivered in a single step. So what are the advantages of these metal stents when they're used in one? Of course, the lumen, the caliber of the plastic stents is suboptimal and significant necrosis is present. The metal stents with a wider mouth may reduce the need for further necrosectomy or any other interventions. And when necrosectomy is required, metal stents offer a better passage. They have a wider mouth, and because they're in place, you can go in and out of the cavity multiple times. For doing a necrosectomy, one of the essential characters that are required in a stent is an anti-migratory property, and because during the necrosectomy a high degree of migration is seen, and luminal apposition therefore causes, luminal apposition is also one of the properties that these metal stents have, and during performing the procedure, less chances of leakage are seen with these stents. So various studies have compared these metal stents with plastic stents, and they found, this is a study from India in 2017, they found the clinical success and the need for direct necrosectomy salvage surgery was much lesser when metal stents were used when compared to multiple plastic stents. This is a study also from India published in GI Endoscopy in 2016, where they found a metal stent significantly improved the rates of outcome, that is resolution of the world of necrosis, with every intervention. They had 3 interventions where after placing the metal stent, if patients didn't improve, they declogged the stent, and if they still didn't improve, they irrigated the cavity with a nasocystic tube, and as a last resort, patients underwent direct endoscopic necrosectomy, and all in all, overall 96.5% of patients could be successfully treated with metal stents followed by some kind of an intervention. So this is the technique for EUS guided cystogastrectomy. So yesterday we saw how plastic stents are placed, and today we'll probably see how lamps are placed. So I thought this is the initial steps remain the same: puncture of the pseudocyst by a 19-gene needle, looping the wire in the cyst, followed by a cystotome puncture to increase the tract, the dilatation of the tract with a 6M Hurricane balloon, the placement of metal stents. And when a non-lamps is used, the stents have to be released partially first in the pseudocyst under US and the fluoroscopic guidance. The stent is pulled towards the cavity and then finally released. Now, the advent of the lumen opposing stents have changed a lot in drainage of pseudocyst. The lumen opposing stents have 2 parts. The first part is released within the pseudocyst, and the second part is released within the lumen. And this is done in a single step because of the electrocautery enhanced devices. So these are the initial studies which showed a high degree of success rates when LAMS was used for both pseudocyst and for one. And there are several studies which have fully covered stents with LAMS with plastic stents. And they found that in terms of necrosectomy and in terms of technical success, and also in terms of complete resolution of these collections, the metal stents and the LAMS are superior to just plastic stents. And when a LAMS was used, the number of procedures that were required for necrosectomy and for further interventions were lesser than when compared to fully covered stents and double the plastic stents. But there have been groups which have also suggested that there are no differences when either LAMS or plastic stents are used for the drainage of world of necrosis. And this is one of the recent studies published in that 2019. They found that except for the procedure duration, there were no difference in outcomes when either LAMS was used or plastic stents were used. Further, there are problems with LAMS. We all know that LAMS can cause delayed severe bleeding. This is because the LAMS is fixed, whereas the wall of the cavity collapses, and this LAMS, which is fixed in position, may abrade the cavity and may lead to severe bleeding. The difference with the plastic stent is when the wall collapses, the plastic stents are slowly pushed out, and therefore the chances of bleeding are less. So the studies have suggested that all lamps be removed at 3 weeks and replaced by plastic stents. But there have also been techniques where a plastic stent is left in situ within the lamps to keep the fifth wall from collapsing. And this technique may allow the lamps to be in situ for a long period of time. So I think I will just talk a little about disconnected pancreatic duct and then finally conclude. So one of the important problems that is faced after drainage of the initial pancreatic fluid collections is disconnected pancreatic duct syndrome. Around 50% of the patients with necrotizing pancreatitis have been reported to have this. The main pancreatic duct is completely disrupted, and therefore when the stent is in situ, the collections are drained, but when the stents are removed, they lead to persistent peripancreatic fluid collections. And therefore, it is important to look and assess whether patients have a disconnected pancreatic duct before final removal of the lamps or the metal stent. And this is a study which was published recently in 2020. They looked at patients with acute pancreatitis at 3 to 4 weeks after drainage of collections for the presence of this disconnected duct, and they found that they looked at 188 patients, and they looked at the status of pancreatic duct integrity in all these patients before removing the stent. They found intact duct in around 71. That's half of the patients, but half of the patients had a disconnected pancreatic duct. And in these patients who had a disconnected pancreatic duct, they used the lamps first, and after 3 weeks they exchanged it for plastic stents. But when they tried to exchange it for plastic stents, around 24 people out of this, they could not place the plastic stents once the lamps was removed. This is because when the lamps was removed, because the cavity of the collection collapsed and they could not place the stents. There is almost around 30% of the patients, they could not replace the plastic stents into the cavity. And in these patients in whom after removal of lamps, they could not place a plastic stent, the recurrence of collections was seen as almost 1/4 of the patients, that is 25% of the patients. So therefore, in patients with the probability of a disconnected duct, it is important to make sure that the lamps is removed and plastic stents are left probably for a lifetime. So what the choice of stent, of course, pseudocyst, you can use multiple plastic stents, whereas when you have a bone with significant necrotic debris, you have to consider the amount of necrosis that is there. The metal stents may be better. There are other considerations that you must take into account when deciding the stent, of course, the financial considerations, and also probably the presence of a disconnected pancreatic duct. So following the presence, the metal stent, some of the patients may not improve, but that's because even with the wider mouth, you can see that the lamps is obstructed by necrotic material, and these patients need to undergo a direct endoscopic necrosectomy, and then you can completely clean the cavity by using this technique. But direct endoscopic necrosectomy or any kind of procedure within these cavities, one thing that you should all be aware of is significant bleed. So this is one of the procedures that we were doing where the patient had a severe bleed at necrosectomy. The patient had to be taken for angiography, and we found a leak at the branch of the SME, and the leak was coiled, and the patient could then be finally discharged. So this is my last slide. So sometimes during the procedure also we may initially decide to place a plastic stent, but during the procedure we may have to consider lamps. So this is one of the procedures where after the puncture we noticed that there's a lot of hyperechoic flow that was there, which is basically we could see bleed. So you can see the bleed over here. So initially we thought of draining this collection with a plastic stent, but following the puncture, we could notice a bleed. So we had to shift to a lamps, and following the placement of the lamps, because the lamps will cause a lumen opposition and cause complete obliteration of have a pressure effect on the vessel and therefore prevent the bleeding. So finally, to conclude, endoscopic drainage of pancreatic fluid collections at the right anatomical location. Of course, today EUS guided drainage is the modality of choice, but we have to understand acute pancreatitis to be able to select the right patients and the right timing of intervention.
The choice of stent is always a big question and it depends on various variables. Of course, the amount of necrotic debris is the key factor probably in deciding which stent to use. And LAMS is very easy to deploy, very good to use, provides a huge caliber mouth for necrosectomy, but they can be associated with severe adverse events. And an early removal of the LAMS following 3 to 4 weeks of pseudocyst drainage is generally recommended, and they should be replaced by plastic stents. Nowadays, we place a plastic stent within the LAMS so that the risk of bleeding is reduced as to prevent cavities from collapsing into the LAMS. And the necrosectomy is required even with metal stents when we use metal stents in some of the patients. And what we must all be very aware of is the risk of bleeding. Thank you. Session. The speaker is Dr. Sandeep Patel. Sandeep, please. Oops. Good morning, everybody. At the outset, I would like to thank Vikas, my friend, and colleagues at Max for inviting me. I think all of us are looking forward for our physical meeting after a long time. And this is the right platform, and EOS has brought us together in Delhi. Although the fear of Omicron is there, and we saw 1% dropout. Vinay is the most scared person, I think. Anyway, Vinay is a friend, and he gave a fantastic lecture in the morning, and we all learned from him about his thoughts and ideas on EOS biliary drainage. Moving forward, I will be speaking on two topics together. This is EOS guided ablation of solid and cystic neoplasm and EOS guided gastrojejunostomy. So we'll divide the talk into two halves. The first will be EOS guided tumor ablation. I'm sure some of you must have heard this talk a few or several times over. But nevertheless, I will still do the formalities which is required. For those who haven't, it may be a first time, but let's move forward. This is why EOS guided tumor ablation. We have had several interventions by EOS, and EOS has really captured the endoscopy field. It's no longer an add-on of endoscopy, but it's a pillar on its own, which is providing stability to the endoscopy field. Endoscopy, colonoscopy, ERCP, and now EOS. So EOS for the tumor ablation, because it provides a good anatomic access, we have been doing FNAs for now more than 2.5, 3 decades by EOS. And because of this access, we can also now do something within the tumor itself, provided it's possible and not widespread metastasis. So local guided therapy can be provided by EOS, and we can accurately position our devices, both needles and several devices through the needles, and deliver these agents directly under real time. So you can actually see what's going on inside the tumor. So far, CT and other things, they put it, but they cannot see what's happening when you're burning the tumor. So it's feasible, safe, and very exciting. I'm sure this, if I can foresee, probably it find its place in the next 5 or 10 years as a part of algorithm and treatment of EOS guided ablation. Several people are working on this field world over, Europeans, Koreans, Indians, and also in US now. So it's currently an expanded indication of EOS intervention.
And we generally consider patients who are non-eligible for surgery, either because they're unfit for a reason or they're unwilling to take the surgery, which is indicated. So based on the mechanism of action, there are several ways by which you can ablate tumors, and based on the mechanism of action, you can label it into two broad categories: direct, that is local ablation, and indirect, where you do something by EOS and something happens later on, the tumor gets ablated gradually. It's all very gray at the moment. So in direct method, people have tried using alcohol as an ablation. This used to be one of the methods of ablation. If some of you would know, by endoscopy per se, if somebody had a esophageal cancer and a polypoid lesion was projecting, before metal stents came into picture, injecting just alcohol into this esophageal tumor used to open up the lumen. So that was one of the ways, and now this expansion has happened towards the EOS side. Radiofrequency ablation, which I'll be touching upon. Photodynamic therapy, which is one of the methods of treating several GI tumors, including Barrett's, esophageal cancers, biliary cancers, and also can be tried now, has been reported, although in a very short series, by EOS guided interventions. And so is a laser ablation, where you can take the laser probe through the needle and deliver energy at the tumor directly. So I'll be touching about only RFA in this group. Coming to the indirect method, where a second process affects later and causes an anti-tumor effect. And this includes placement of fiducials, which is a standard practice in the Western world. They're not easily available in India and hence not much in use, where you place these seeds of gold inside the margin of the tumor, and then under CT scan vision, you can actually run cone down and only focus on the area of the tumor and provide targeted radiation. It's called image-guided stereotactic radiation. And then brachytherapy, which is mainly reported from China, where they implant radioactive iodine seeds inside the tumor, and that gives low radiation and ablates the tumor. The third is the immunological method of treatment is stimulation of immunity, where you inject anti-tumor vaccines. This has been there from Ken Chang's group from US for more than 20 years now, but hasn't moved really dramatically forward, and it's probably stuck there only. And there have been some case series reported of direct injection of gemcitabine into the pancreatic cancers. This is from Mayo Clinic group. So these have been things which have been tried. So pancreas is one of the commonest areas where interventions are done for tumor ablation by EOS. Other areas where EOS have been tried for ablation is by solitary metastasis of liver or adrenal or lymph node, where you can do an RFA or an alcohol ablation. So I'll stick myself to the pancreatic solid tumors. And among these, the commonest group is pancreatic cancer, where it's a debatable area. It's still not a standard of care, but the potential area where it's being used more frequently is pancreatic neuroendocrine tumors, which you're finding more and more. I'm sure all of you in a clinical practice must have seen these tumors now being discovered more by when you do a cross-sectional imaging for something else, or they have a mast cell checkups or checkups for other reasons, and you find these tumors. And once you find a tumor, you cannot close your eyes. Both you and your patient are anxious to know what's going on and how to best manage it with the least downside to at least complications. Another area is the solid pseudopapillary epithelial neoplasm. So these are two areas where EOS has really made progress, especially neuroendocrine tumors. I would say this is the one area where it's been discovered more and it's been attacked more by EOS RFA. Adenocarcinomas, it's generally a systemic disease when even if it's a very small stage, and surgery is the gold standard, but it's possible only in less than 20% patients, and success rate also is not very phenomenal. So why not add on to the current standard of care by EOS RFA is the thought. So making it more a chronic disease than an acute or a semi-acute disease which takes a life away. Coming to the methods or the principles behind EOS RFA, in RFA, just like what we have learned from our intervention radiology colleagues, who they do RFA for hepatocellular cancer for more than 2 decades now, and it's with good results. And the same principle is now used here. The only difference between, or it looks only, but it's a major difference between liver and pancreas is that in liver you have a huge margin of safety. Even if you burn a normal liver parenchyma, nothing really happens. You just necrose, which after some time it shrinks, scars, and the liver regrows back. Whereas in pancreas, you don't have that much of a comfort zone available. So you have to stay within the tumor. You cannot burn a normal pancreas. And this because we can cause pancreatitis. If you burn a normal pancreas and cause pancreatitis, then this intervention will die off, or the patient will not come to you. And so that's why we have to be very, very safe. The margin of error is zero almost. So we provide high frequency alternating current, which gives local heat. So it's controlled heat burns the tumor. It causes coagulative necrosis. So it doesn't happen immediately. We burn, it causes some white bubbles which coalesce together, and then that causes liquefaction. So if you keep doing a CT at frequent intervals, you find a cystic area developing in the solid tumors, and that will then disappear over a period of time and the tumor shrinks. So it's minimally invasive, safe, and well tolerated. And based on the delivery mechanisms, it has divided basically the two categories of RFA also. Through the needle device, as the name suggests, that you pass a needle, FNA needle, you draw the stylet, or you pass a hollow needle, and through this hollow of the needle, you pass a guide wire kind of an RFA probe, which is one French. This is called a Habib probe, and that goes beyond the tip of the needle. So you have to very gently reach the edge of the tumor, pass this wire inside, and gradually pull back and keep exchanging. So the wire now projects beyond the tip of the needle, and then the needle gets withdrawn back. So then the exposed part is now within the tumor margins, and then you can burn and see it in the EOS. But the more commonly used method of ablation by EOS RFA is an FNA type needle. And as the name suggests, it exactly mimics or resembles the FNA needle that we use standard. It is either 18 gauge or 19 gauge, which is currently from the Taiwan company. And there are two different varieties of mono and bipolar. The name suggests monopolar means that you need a grounding pad, and a bipolar means that you have the two poles within the tip of the needle, where the current flows from one to other, burning the part or the tissue on the way. And some of these methods of RFA have a sophisticated internal cooling mechanism. What does it mean? So it's really very counterintuitive. That means you're burning the tumor, so it's providing heat. So needle will get heated up, and that heated needle in a tissue will cause charring, and that black scar will then deposit on the surface. And when this gets deposited, the heat doesn't get transmitted. So it becomes a good insulator. So we want heat to go. At the same time, we don't want the needle to get charred. So to prevent this charring, you give the heat, but you have an internal cooling mechanism through the hollow of the needle, which doesn't cause charring. So that's very counterintuitive, but it happens. So these are the three different devices which have been used. The EOS RFA probe, I'm sure you can see it there. So this is a FNA needle. You can use 22 gauge or a 19 gauge needle. And through this, a green wire kind thing comes out. This is one French. It's thinner than a guide wire actually. And it is coated all the while, entire length is coated by an insulator, but except for the last 1 to 2 centimeters, both different varieties are available, which is the uncoated part. And this is the one which has to be embedded within the tumor to provide heat there. This is the other one, which is from the Abbey. This has, I'll tell about it later in this next subsequent slides. But the most popular one is a StarMed. It's called USRA. StarMed and Taiwan companies are owned by two brothers, and that's why they're kind of together. And in this, again, I'll show subsequent slides. So further mechanisms, when I discuss further, this is tumor ablation is considered in pancreatic cancer because of dismal prognosis, because nothing else has been working so far. So why not try something new? But cystic neoplasm and NETs are much more commoner now with increased diagnosis, and they are associated with significant morbidity. and the EOS guided treatment provides a less aggressive method. When I say morbidity, the accepted morbidity by the surgical group is 50%. And that's very high percentage wise, and the accepted mortality is 5%. So we can't have that much of acceptance. And if we can reduce this drastically, which we can, I believe we can do by EOS, then I think EOS has definitely got a place in it. I will show this cartoon video of how EOS RF is, and this is a tumor. You focus the tumor in the EOS view, pass this device. This is the RFA device from StarMed. Position in such a way that the tip or the uncoated part is within the needle, and then deliver energy by the external generator. And you can see the bubbles happening there. It doesn't disappear like from this, but this is just a cartoon. This is a slightly old publication, 2014, where the level EOS intervention and level of evidence have been discussed. And EOS tumor regulation at that time was very poor level of evidence for interventions. So it's only in the case study, but people who have worked now, I think now this, whenever the next publication comes, it will probably be in 2A or 2B more publications. We don't have our RCTs as yet because these numbers are less and only very few people are doing it. So there are publications both for pancreatic cancers. So now I'll just show you, this is the wire which comes out, and 20 millimeter part is exposed, even the shorter length available now. And the generator that is used is exactly the same that is used by the radiology colleagues for RCC, for HCC. So if you have in the hospital, the intervention radiologists are using it, you can use this same generator to burn this tumor. This was an earlier publications long time back, and this is a solid tumor where the needle is passed inside. So first you do an FLA kind of method. Place the tip of the needle in the far end of the lesion. Then you pass this guide wire inside. And once you're on the tip of the needle, then you withdraw it backwards. So much so, if sometimes fluoroscopy is available, it may help you to see whether the uncoated part and the coated part can be differentiated there, so that the uncoated part should only be in the tumor and not in the normal pancreas, because that's when it can cause pancreatitis. So this is a fluoroscopy equivalent of the same. Since it is a guide wire kind of a thing, it will not be straight, it can have a little contours. You can also do a cystic ablation where you can coil it inside and then burn. This was a hybrid thumb probe which I was mentioning. This is the other device from Arby. It has a sophisticated internal cooling mechanism, and they use carbon dioxide to ablate the liquid carbon dioxide. The only problem, one major problem with this is that it is a very stiff device. The outer sheet is 11G, which is 3.1, it will fit in very tightly in the channel, and the needle when it comes out is 14G. So unlike your 19 gauge needle, this is much more thicker. The second major problem is that the length is very long. This is from this part to this part is 25 millimeters long. So it has one electrode here, a second electrode here, so it's a bipolar device that heat moves from one to other, so it burns like an oval shape. But it needs a tumor which has to be at least 25 millimeter or more, which means you need to have a big tumor. And so what do you do for a smaller tumor? So they're currently working to make it smaller, and we'll have to wait for it till it comes out. But we had some experience in pancreatic cancer. This is a pancreatic cancer close to the splenic vessels. You can position such a way that the proximal limb is within the tumor, and so the entire length can be seen. You can measure it. This is a proximal mark, and this is a central point. So when the heat comes from one pole to the other pole, these white kind of bubbles will appear. The beauty of RFA is that not only you burn at the same time, there is some effect also happens with passage of time. There's a penumbra of the burn. Penumbra is the same time that you see it at the time of heating, but the latter part also has some conduction effect and get burnt out. This is one patient of ours who had a large mass in the pancreatic proximal body. He underwent, you can see it here now, much carefully. And obviously, this is locally advanced disease, so we could not do any surgical option. So he underwent RFA along with the standard chemoradiotherapy. And 4 months later, this patient came back and there was no tumor there. This is the area where the tumor was located. This is the duct, which is the pancreatic duct is dilated, but the tumor is missing. So that much of an objective improvement in the size one can see, and this has been shown in one other publication which came from Italy, where they downgrade the tumor and could subsequently operate a fair proportion of the patients who had undergone RFA. So that's a possibility. This was a publication I was talking about, where they downgrade the tumor and subject to surgery. So our only experience for hybrid thumb probe has been limited, because now they have withdrawn this device because of the size. So technical success was in all because of this adversity of the device by size and the sharpness of the tip. It caused a scope leak in one. It improved survival to some extent. So, but it's not a foolproof mechanism. So we need to do more work on this device. This is a third device, which is the most popular and widely available all over the world now. It comes in 19G is now preferred size, because that's a standard FNM that we use for interventions. And it comes by the tip of this, the uncoated part or the non-insulated part can have various lengths available. So you can choose the needle according to the size of the tumor. And how do you choose? That the size of the uncoated part should be shorter than the largest diameter of the tumor. It's very simple. The logical part is that the entire uncoated part should be within the domains of the tumor and not outside it, to prevent any kind of burning of the normal parenchyma. It has a separate generator, and we can adjust the wattage also. The common wattage used is 30 now. We can actually have from as less as 1 or 2 to as much as 50 or even more. This is how the tip looks like. This is a normal sheet, like an FNMOD sheet. The yellow part or the golden part is the insulated tip, and the terminal steel is the uncoated part where the energy is given. So this much part only has to be within the domains of the tumor. So this was the earlier experience that we published several years ago of using it in pancreatic cancer. We found it to be ease of use, that it is safe and feasible. And let me show you in the pancreatic cancer, we can burn or punch several holes in the tumor. This is a tumor margin. You can go in the entire length and keep burning 1 centimeter by centimeter and keep pulling back. So in one trajectory, you can burn 2 or 3 areas depending on your the size of the tumor. And then you can do a fanning technique or a repuncture in different directions and torquing, so that as many holes you can burn in the tumor, the more is better for the patient. So this is an example of a patient who had a cancer with a metal stent inside the tumor, and after RFA, this is how it looks like. The tumor has coalesced and disappeared, but this is a systemic disease, and that will cause a reoccurrence at a different site. So this was our experience with pancreatic tumor now with the RFA, and we have several indications. This is the pancreatic cancer that we have used. And publications have also come from other parts of the world. This is an Italian publication where of series of 10 patients where they found it to be feasible and safe. So then we move forward from pancreatic cancer to neuroendocrine tumor, which is a much more common and where the money lies. So we started first with insuloma, which are the functional tumors. And you can show it here. This is a neuroendocrine tumor, very close to the pancreatic duct, very vascular, as all neuroendocrine tumors are. This is the length that we measure, almost about 10. So we have to select a size which is 10 or less of the probe, and then we burn our way in. So first we puncture. See that everything is inside. You can see this is a length in, and then provide the heat generation. You see these white bubbles appearing. It generally takes about 15 to 30 seconds for it to burn at one specific area. See, the PD is so close by. The publications have come also from other centers. This is a Korean center where there are 10 patients, 7 PNETs, 2 SPEN and 1 insuloma, and they had complete radiological response in 70% with minor adverse events. This is from the French group, which did a multi-center study of 30 patients, both cystic and solid neoplasms. The PNETs were 14 and 12 patients, and out of which 12 resolved. 3 had a delayed response, which I meant by the penumbra effect. And the complication rate was seen only in the first few cases, and once the operators became accustomed to the device and the heat, then the complication rate reduced. This is our own experience of insulinoma, and we had 10 patients with 13 lesions, 9 had single and 1 had 4 lesions. We had RFA maximum in 1 session, but 2 patients required more than 1 session. We place a prophylactic pancreatic stent in lesions which are very close to the pancreatic duct. In the previous RFA that I showed in the video, the stent could not be placed by an ERCP, which is done 1 or 2 days before. But our aim is always to place the PD stent if the lesion of the marginal lesion is less than 5 millimeters or so to the pancreatic duct. We have now follow-up of more than 7-8 years now in all patients who have had the first ones. There is a quick biochemical resolution. So within first 12 to 24 hours, the sugar's value come back to normal, where hypoglycemic symptoms almost disappear. And also you find the C-peptide and the insulin levels drop down very rapidly, and they're also sustained. So at 1 year, we did the checkup also, and the insulin levels were normal. And none of them had the reoccurrence of the biochemical symptoms or the symptoms of hypoglycemia later on. We expanded the indication to the non-functioning neuroendocrine tumor. This is a slightly older slide. We have now experience of more than 10 now. And here we don't have a hormonal marker or sugar as a marker for the symptom relief. So we now follow them objectively by the image only, that it's not increasing. Having discussed about RFA, now the complications have to be aware. I told you about pancreatitis because it's very close to the pancreatic parenchyma, normal parenchyma. And the way to prevent pancreatitis is what we have learned from preventing our post-ERCP pancreatitis. That is placing a prophylactic pancreatic duct stent, using plenty of fluids in the perioperative peri-procedure time, and also using indomethacin suppository. GI bleed and perforation can occur. This is another lesion very close to the PD. Yeah. Okay. Yeah. So this is a pancreatic duct stent that can be seen here. There's a tumor here. This is a bleed which occurred after RFA, but fortunately it stopped on its own after a few minutes of observation. So some device injuries can occur because of the friction. So RFA is safe and effective, and I can stop here. Should I do the next talk or should I leave it out? Yeah, please continue with the next. Oh, okay. So ESGJ is actually not ESGJ. The correct term is ES gastroenterostomy, because you don't know if you want to judge or it's the duodenum itself. And these are some of the things which I'll cover. What is ESGE? How is it done, and is it safe? And what is the role with surgery? So this is how this is a normal GJ, surgical GJ, and this is what an ESGJ or GE looks like. So I'll skip how to do. So there are several methods of doing ES gastroenterostomy, and these are some of the methods which have been described. You either do a freehand puncture, which is a very popular method, where you inject saline contrast and a coloring agent in the proximal segment of the duodenum, and then use an antiperistaltic agent, Buscopan, or similar agent, a glucagon, and then you puncture from the stomach and place a hot Axios device. But before this, there have been several other methods to make it a little more safer, by placing a balloon inside or placing a guide wire inside, and over that you pass and also using an endoscope, which same endoscope which can go deep inside to watch what's going on. But this is my preferred method of draining, where you have 2 balloons placed around the DJ flexure using a special E-pass balloon or double balloon catheter, which we hope to show today. And then intervening segment is filled with saline, contrast, and a coloring agent with about 100 to 100 cc. And the 2 balloons are meant to anchor the jejunal limb, so that the limb does not, because this is a free floating loop sometimes, and it can, and as we puncture it, this moves away, it causes perforation, and the treatment then is mainly surgical. So the freehand gastroenterostomy is that you fill this with coloring agent beyond the stricture, and then you make a puncture here. And this, I'll skip this. I think to save time, I'll come straight to the double balloon method. And this is the cartoon which the stricture is here. You place the 2 balloons and then make a pseudocyst kind of appearance, and then puncture away in. And this stent then gradually expands on its own to the diameter that is intended to be 16 or 20 millimeters, 14 or 20. This was this E-pass balloon or double balloon was discovered by Takao Ito, my friend, and he has shared some of these devices with us. We are part of a multi-center study now, randomized trial, where we're comparing enteral stent versus GJ to see which is for the long duration of patency. LAMPS I will skip because this is not a standard method. So the steps that we use here is, this is a patient who had a pancreatic head cancer, had a biliary stent and an enteral stent, which again got blocked. This was our first patient actually. So through the enteral stent, we passed a guide wire and a cannula behind, and then we passed this device, fill the distal loop beyond the DJ flexure, and then pass the double balloon. So first balloon, the forward balloon is then inflated with about 40 cc of contrast and saline, and then the proximal balloon is inflated. So between the distance between the 2 balloons is 20 centimeters, and there are side holes in this catheter which can then fill this area with contrast and saline, as you can see it here. And this time we pass the EUA scope. And once we see that distended loop, this is a distended loop of proximal jejunum. And this kind of a distension is what we need. Although a little bit of ascites here, but nevertheless we can still do it. So Jahangir has published a paper recently in EIO on even presence of ascites does not hinder with EOS GJ. So you can see the catheter inside on EOS that tells us this is exactly the place that you want. The reason why so much effort is made to make it safe, because freehand technique looks very elegant if done correctly, but if there is any mishap which can occur even with expert hands, then you can cause complication. These complications are major complications. So once you are comfortable, then the final puncture is made with the axios, hot axios. And then the procedure is exactly the same like we do for drainage of the world of pancreatic necrosis. So the effort is 90% of the effort goes to make it safe by placing this E-pass balloon, which takes about 20-25 minutes of the entire procedure. And the last part is only about a minute or two. And this is the gastric end of the balloon of the stent, which is being finally deployed. And the moment you see the coloring agent on endoscopy view is coming into the stomach like this blue color, that means you have accurately placed your stent. You will also cross-check the fluoroscopy when the contrast comes into the stomach. So these are the final positions. Few days later, you can do an oral contrast study and see the contrast is going distally. So technical success is now improving as we are doing more and more of this procedure. And in India especially, we are improving because now we are getting a hang of axios, because axios were not available till about 1.5 years back, 2 years back. And now it's fully available, the hot axios. So it's a high risk, high reward procedure. If you do well, everything looks very nice and clear, and the surgeons are happy, and you are excited, and you sleep well. But in case there is a mishap and there is a perforation, which can occur either at the gastric side or it can occur at gastric and the jejunal side. So gastric side we can always close by a clip, clip, but the jejunal side is more difficult, and that requires surgery. So there is experience now gaining all over the world now, and in Western world they're doing mainly with the freehand technique, and they have mastered this technique quite well. It's found to be equally efficacious and safe as a surgical GJ, and also been used in benign obstructions and both benign in comparison, and they've been found to be superior to the enteral stent because they provide more stent potency and they're not going to the tumor, so stent will not get clogged. And there are few small things. The issues with GJ is that the anatomy is normally like this and all, but sometimes you can have a Daniel anatomy like this or like this, or it's a malrotation. So that anatomy actually can make your procedure difficult, and this is what can happen if you're doing a freehand technique where you can actually burn the stomach, go through the peritoneum, but you're not able to go into jejunum. And this stenting, when you deploy the stent in the outside the jejunal limb, and that you can always close now with the gastric and with the ASCO. But this end, if it gets perforated and the stent is mal-deployed, then surgery is so these are several things which can happen: the complete mal-deployment or the partial mal-deployment. So in conclusions are that from a technical failure, leakage, hemoperitoneal, and stent occlusion. So in the last slide is an exciting endoscopic technique to create anastomosis within stomach on the proximal small bowel. Cautery enhanced lamps has made the life easy. Not any metal stent. Do not use a non-cautery enhanced or a simple bifline stent. E-pass balloon adds safety. There are technical issues currently, and it has a learning curve, but it is safe in expert hands. Thank you very much for your kind attention.
Thank you, Dr. Sandeep.
Covering such an extensive topic in a short time.
Thank you.
And I think we'll move to the last talk of this session. Something very common which in therapeutic indications of EUS, that is the use of EUS in celiac plexus neurolysis. And we have a young endocrinologist, Dr. Saurabh Bukhewa, who will be talking about it. Then endoscopic guided CPN as well as pancreatic ductal drainage. Dr.
Thank you. Okay, good. Thank you. Hi, good morning, everyone. Looks like a little bit of a delay today. So it's a pleasure to be here. Thanks, Vikas and the organizing team at Max for having me here. So I have two topics. I'll try to do justice to them in a short span of time. This is EUS guided pancreatic duct drainage and celiac plexus neurolysis. So let's talk about EUS guided pancreatic drainage first. This was initially described way back in 2002, and there are about 350 cases reported so far in literature. The indications really involve when the ERP is indicated, say patients with a dilated pancreatic duct, a stricture, ductal disruption, pancreatic fistulas, and importantly, when ERP fails. Now, either the papilla is inaccessible or you cannot get the guide wire across. So those would be the indications for EUS guided pancreatic drainage. But something worth considering is whether the patient is an operative candidate, and you have to be a little judicious as you are considering doing this procedure, and because complications have been reported and should be done in expert hands is the feeling. So the contraindications include some obvious technical issues like an invisible pancreatic duct or a non-dilated duct. Although we have done it in a bunch of non-dilated pancreatic duct patients, it requires a little more skill. Multifocal strictures, a long distance from the gastrointestinal wall to the pancreatic duct can be an issue because you're traversing a long segment of pancreas parenchyma and you're burning through it, so you don't want a long distance, ideally as short as possible. Of course, an intervening large vessel is not what you would want. Bleeding risk would be another contraindication. So if you really broadly classify, you either have the rendezvous technique where similar to what Dr. Bee was discussing in the morning, you're getting the guide wire in this case across the pancreatic duct and the papilla, and therefore follow up with regular ERCP. The transmural drainage is basically across the gastric or the duodenal wall into the pancreatic duct, either antegrade towards the papilla or retrograde, that's towards the tail. So as you're preparing for these patients, the patients have to be on IV antibiotics. Position whether you have to do supine or prone. A lot of people do prone. I've had good experience with supine, so I think whatever makes it comfortable. Supine works fine. You can visualize the pancreatic duct well on the fluo. Just go through quickly briefly the steps of the procedure, as not most people do these procedures. It's very analogous to biliary ductal drainage with some caveats. So the two sort of needles that we would consider using, a 19 gauge flexible needle, which I like to use from the Boston Scientific. There can be an issue with wire shearing. A 19 gauge access needle that Cook is also used. It's a little stiff, that's why I'm not a great fan of this needle, but the advantage is you see the stylet is sharp, so the needle actually is hollow. So what it permits you to do is manipulate the guide wire really well. You can use 20 gauge needles, but then that only allows you a 0.018 inch guide wire to pass across, and that is a weak guide wire in my opinion. So my preference would always be to use a 19 gauge needle. So as we proceed, the first thing we want to do is get the needle across into the pancreatic duct. Now remember, in a fine needle aspiration or biopsy, you're targeting something that's at least a centimeter or more. These pancreatic ducts are, quite frankly, less than 5 mm oftentimes in some patients. So you may not exactly get the needle bang on inside the pancreatic duct. So like here, we are targeting the pancreatic duct, which you see in the left hand of the screen. I do overshoot, which is okay. Back to get it right in position inside the pancreatic duct. Now, this is the orientation of the fluoroscopy. Ideally, as longitudinal as possible. Being perpendicular to the pancreatic duct can have challenges in terms of moving the wire. So you want to be as sort of longitudinal in the axis of the pancreatic duct if you can. Next is to inject contrast. We use 1:2 dilution in the contrast. Here we are injecting contrast and we're seeing a sort of tortuous, mildly prominent pancreatic duct. The next step would be to advance the guide wire. We have a couple of options here: 0.032 inch thermo angle tip guide wire, which is a preferred guide wire in many centers. The 025 is another very good guide wire, but the problem is advancing the cystotome over the busy guide wire. In my opinion, I use the angle tip thermo, although it's thicker, but it's a good wire to manipulate inside the pancreatic duct. As you advance the guide wire, here in this case, the guide wire first went back towards the tail, and then we manipulated it to coil it inside the pancreatic duct towards the head. It's advisable to have a couple of as much wire as you can inside the duct because of exchanges that you are going to do. So it's always desirable to have more wire inside the pancreatic duct. Now, if you are going to do rendezvous, you want to advance it towards the papilla and try to get it across. Now, what happens is the guide wire can oftentimes get stuck in the side branches, and it can be hard to manipulate. The next part is to do tract dilation. Now, as done in most other biliary drainage procedures, we use a 6-French cystodome in this as well. Biliary balloon can be used, but in India, when oftentimes the accessories are sterilized and used, the biliary balloon the second time can be not well collapsed, let's put it this way. So you cannot advance it as easily as you may like. Which angioplasty balloon has been used recently in a publication, something worth considering, or tapered catheters. But by and large, most people, I think, use the cystotomes. Now here, we are advancing the cystotome across the gastric wall. You have to go slow, steady pressure. You have to use fluoro guidance because you may not exactly visualize it always in the EUS. Now here, we're moving the scope and ensuring that the cystotome is inside the pancreatic duct. And here is the fluoroscopy view showing that the cystotome is inside the PD.
So what I prefer to do is switch to another stiffer guide wire, like a 0.035-inch Jaguar, which I did in this case, and now the guide wire is across the papilla inside the duodenum. And now we could get the cannula, well, the cystodome into the duodenum, and we confirm by injecting contrast, but you'll see in a second. So now this is confirming that the cystodome is inside the duodenum. So we call the guide wire in the duodenum 0.35-inch now, just because that gives it's a stiffer guide wire, permitting movement of the stent more easily. When you have a choice of stents, by and large, you have what you would mostly use is a single pigtail or a double pigtail stent. Now, just one caveat. You want to use a stent with no sidewalls. You're not really wanting to use a regular pancreatic duct stent because in theory, there's a chance that the pancreatic juices will leak outside the gastric or duodenal wall. Again, that's more theoretical, but as of now, this is what you would want to do. You can use covered stents, especially if you're planning to do lithotripsy later. And uncovered stents are not recommended because of leakage of contents. So next part is to advance the stent across. In this case, we got the stent across. It could not go across the papilla because of the angles, but we managed to get it across deep into the pancreas and then coiled it outside in the gastric lumen. So just a different flavor. This is another case. Looking at the pancreatic duct in the neck, which is non-dilated in this particular case. We get a 19-gauge needle across, and then contrast injected with a coiling of the guide wire. I just go forward. The cystodome is then advanced, and now we're injecting contrast, and now you see there's leakage in the tail. And now in this case, we managed to get the stent across. This patient had pancreatic ascites, and challenge to get the stent down, but I managed to get the stent in the retrograde manner. Different flavor. This is another patient. We slim endoscope, which could not get across, and the side view scope again could not be advanced into the duodenum, preventing a standard ERCP to be performed. So therefore, we switch to EUS. Now we're looking at the pancreatic duct, but there are vessels in proximity, so you have to be careful. The needle is then advanced inside the duct. Contrast is injected, confirming the presence of needle in the duct. And now you see the leak in the tail region. The guide wire is coiled now towards the head. Now I could not get it advanced across the papilla initially. Next, as described earlier, we get the cystodome across. And in this case, then we pull back the wire, and now we could get it across into the duodenum. We get the cystodome out. We inject some contrast again. Now you see there's a stricture in the head, which is probably the reason why it could not get across. And therefore, then we use a 4 millimeter biliary balloon to dilate the stricture. And then we advance a 5 French double pigtail pancreatic duct stent. Not the usual PV stent, across into the duodenum. And then we had the ultra slim scope going in and confirming that it had been placed accurately in the duodenum. So if you look at overall experience, there are reports in mostly 20 to 40 patients, and as you see, people are not doing hundreds of these cases, so therefore there will be more adverse events, including pancreatitis, bleeding, perforations, and if you see, for transmural drainage, the technical success achieved was 90%, the clinical success of 87%, and complication rate of 12%. Hence, it's something that that should be done in expert hands. And I think it's important that you know, most people don't have a lot of experience, so those are the issues. But one thing to note when you're doing these procedures, you want to be traverse as little pancreatic parenchyma as possible and find a neurovascular path. This is one publication out of India from Ankit Dalal and Dr. Maido's group. They did 21 patients with transmural drainage with about 80 to 90% technical and clinical success. This has been our experience. We started doing it in January this year. There are a lot of patients with pancreatic ascites, which is predominantly our indication, and most of them are really not dilated. We use a 19 gauge needle with a 6 French cystotome. I use a 5 French stent. It has worked well for me. Mostly a transgastric approach. Some once transpapillary, as I showed you. We could get into all of these, but then there are a couple of patients in which the pancreatic duct was not dilated or not just accessible. So maybe 7 out of 9. Clinical success in all except one was lost to follow-up. And we had one patient with pancreatitis. Fortunately for us, the others did fine. Just a different flavor is rendezvous, where you get a guide wire across the papilla into the duodenum. I think in candidate decided, in which this case we could not. So we grasped it with snare and pulled it into the duodenoscope. And then we proceed really like a regular ERCP. Here the dilator is advanced of the guide wire. We are getting some contrast. We did a pancreatic centrotomy, and the PV stricture was dilated. And then ultimately a stent was placed in a regular ERCP manner. If you look at EUS pancreatic duct rendezvous, technical success has been lower, likely because of manipulation of guide wire, in my opinion. Can be a challenge of getting the wire across the PV if there's a tight stricture. Clinical success 93%, complication data 14%. So what else can be done? Once you have access, you can use covered stents and go inside with pancreatoscopy and do laser lithotripsy, as shown in some of these reports. So I have one case, hopefully we can try to get it done. So next part is the EUS guided celiac plexus neurolysis / block. So if you understand pancreatic cancer, the origin of pain is, excuse me, because of pancreatic cancer cells invading the peritoneum, and then the pain signals the transmitted by the superior mesenteric ganglion and the celiac ganglion. Excuse me. So the earlier reports was by Mortis Biosema and colleagues from 1996. Thank you. We have published our sort of experience and on EUS guided celiac plexus block. We're compiling all the studies in this paper. So if you look at the celiac plexus neurolysis, it's basically permanent ablation of nerves, while when you say block, it's temporary inhibition of pain transmission. The neurolysis involves using alcohol, 98% with an anesthetic, and celiac plexus block involves using corticosteroids with an anesthetic. So just to clear the terminology, the indications include patients with abdominal pain and intra-abdominal or pancreatic cancer most commonly. Chronic pancreatitis, celiac plexus block, it's fallen out of favor because of studies not showing convincing results. So not all the centers do it. Contraindication includes coagulopathy, thrombocytopenia. So just to briefly go over the technique, it's an outpatient procedure. Patient is placed in the left lateral position and the vitals are monitored under sedation. A 22-gauge needle is then advanced at the origin of the celiac artery. This is what I use. There's another 20-gauge needle, which is made by Cook, which has side hoods, which permits delivery of the substance in the surrounding region. Here, the celiac artery origin is identified at the aorta. The needle is now going to be advanced. I'll just move quickly forward. The needle is now advanced at the base of celiac artery, and then we inject the mixture, which in this case I've used 5 ml of 0.25% bupivacaine and 10 ml of 98% alcohol. And what you see is sort of a snowstorm effect, and the bright substance being delivered for neurolysis. So there are several techniques and modifications for the same. There is a central technique, which is right at the base, unilateral, which is on one side, bilateral on both the sides, or celiac ganglion neurolysis, where the injection is performed in the ganglia, or broad plexus neurolysis around the SMA with a 25-gauge needle, which percolates the injectate in the surrounding region. I'll be quick in the next few minutes. So if you look at the overall experience and the issue is there are a lot of heterogeneity in terms of the technique used, the active product drug use for delivery, and different outcomes assessed. But bottom line is 60 to 90% will have some degree of effect. 30 to 40% may have complete relief of pain. 30 to 40% will have reduced opioid use and reduction in the pain by say 2 or 3 points on the visual analog scale. And say 10 to 20% may not have any effect at all. And if you look at data comparing the different techniques, the bilateral was superior to unilateral in this retrospective series. There were 2 prospective studies showing basically bilateral was not different from unilateral. Celiac ganglia neurolysis, where the ganglia are identified with the needle advance in the ganglia and the drug delivered. Now, if you see the earlier studies show promising results, a randomized controlled trial showing superior outcomes with positive and complete response, more in those with celiac ganglia neurolysis versus standard CPM. But a more recent publication of Michael Levy and group from their clinic, who actually showed celiac ganglia neurolysis to be pretty good initially, showed that there was reduced survival, 5.6 months versus 10.5 months with celiac plexus neurolysis. So now people have swayed away from doing celiac ganglia neurolysis. Just to touch upon broad plexus neurolysis in my presentation. So this is an interesting study. They use a 25 gauge needle to get across near the superior mesenteric ganglia, and then they put some contrast as well with the active ingredient, and then they did CT scans after to see how many areas around all the three ganglia, so celiac, superior mesenteric, and inferior mesenteric, has the active drug reached. So when they found more areas which had contrast, which means the active drug had reached bilaterally across all the three ganglia, they had much better pain control than in those cases where it did not reach, compared in which was the celiac plexus regular neurolysis group. So just to touch upon predictors of response, greater pain before the procedure, tachycardia during the procedure, which we often monitor. I tell my patients you experience pain more after the procedure for 2-3 days, which means the active moiety has reached. Using CPN early in the course of cancer and absence of invasion of celiac plexus by cancer. So last slide, complications. Very important for anyone doing this to note that although most patients may have some mild adverse events like diarrhea and transient hypertension, but 1% risk of severe complications has been reported, which has been quite debilitating, with 2 patients dying from this, 4 intra-abdominal ischemia, paraplegia, abscess, cerebral bleeding. So ultimately, thank you, this is me doing the procedure, but it's ultimately not possible without a great team around you. Having great technicians, radiographers is vital for the success of the procedure. Thank you. Okay. Sorry for the delay.
Thank you so much, sir. I think you really went through very fast. Thank you so much. We still have a little time we'll take for discussion. We have 10 minutes, so we have 3 lectures which were not covered in the discussion. So we can go one by one. We have our speakers very much here. So yes, please.
My question to Dr. Singh, sir. So actually, sir, wanted to know that is it really first indication for those patients who are malignant tumor offsetting duodenum, or we can keep it as a second indication, because stenting such patients is very easy and very without any complications. So what do you recommend, that GJ should replace stenting, or first we should do stenting in such patients, and in case of tumor offset not stent blockage, we should do GJ?
That's a very good question, Yogesh. We are doing an InterStent in most centers where duodenal obstruction because of malignant etiology occurs. And in case where it fails, then GJ can be a fallback option. But now that we have gathered some experience ourselves and from other places, the aim is that if you're away from the tumor, then even if the tumor grows, which will happen naturally, the obstruction of the stent will not happen. So that's the aim, not only for GJ but also HGS. If you have a transpapillary biliary stent or a choledochordiomas, we are very close to the tumor itself. So a stent is likely to block that biliary stent, and that's why HGS has a little more stent patency for a longer period of time, and same holds true also for the GJ over an InterStent. So only if you can make it safer and quicker and efficient, then I think it may eventually replace InterStent. And that's why we're doing this international randomized controlled trial. We are comparing same group of patients who have malignant gastric outlet obstruction without any biliary stent being placed. In one arm, we are doing an InterStent versus other arms in US GJ.
Yeah, my question is to Dr. Saurabh. Yeah, nice lecture. So you guys got it penetrating, like if you see the literature, it's quite a, the complications rates are really high, up to the tier of 40%. So the so whenever you can cross the guide
across the papillitis, what is advisable to do transport cleavage. So that's a comment because in your case, you were able to pass the still work on transport cleavage. So that is one comment.
See, I think in that particular case, if you see, the guidewire went after the 6 franciscomas in the back. So now when you have already created a fistula tract across the gastric wall and pancreatic parenchyma, yes, you could in theory go down and do the pancreatic duct. But since we had easy access, we placed across the gastric wall and then across the papilla as well. So it was sort of a transmural antegrade papillary stenting. And in this case, they exit for pancreatic collection or pancreatic juices on both sides, the gastric as well as the papilla. So that's why my opinion was fine. Worst case, if I had the wire across and I'm trying down the view and then it gets slipped, then I'm back to square one. But I have to puncture again. So I think at that point in moment, it seemed like a good strategy. And frankly, once you've done, and there is no middle time coming between so called in the PD, so it's like 3 mm of. Then I think the complication risk should be generally a little. If you're traversing a lot of pancreatic parenchyma or burning a lot of tissue, then issues arise. And if you have only 3 mm of pancreatic parenchyma in a nice position, you might as well just go on and do it.
So it's advisable to use non-cautery over cautery. So have you ever tried with mechanical dilators rather than using cautery?
Yeah, I haven't tried. I think maybe in my next case I'll use
Because the maximum complications are due to cautery.
Yes, you're right. I think
Because of the atrophic tissue and fibrous tissue, it is very difficult that non-cautery dilators or who will go. So usually what happens when we push non-cautery accessories, wire gets misplaced or it gets shortened and all these problems occur. So cautery is better always in such cases.
Yeah, I think unless you have a very slim dilator which can be smoothly passed across. I haven't personally tried. I've not seen if it's cautery, but I'm happy to hear anybody else who has done it in a non-cautery manner. Whatever accessories we have in India.
Usually in chronic pancreatitis, nothing happens because your tissue is so much fibrous. Even if you use cautery, nothing is going to happen.
Thank you.
Saurabh, yeah.
Yes.
Up here.
Oh, yes.
Nice talk. So
thank you, sir.
in your this time PD brain you have used mostly in this indication of pancreatic ascites. I
Yeah.
guess 5 out of your 6 patients were
Yeah.
pancreatic ascites. So what has been the result? How do you need to leave the stent permanently there? Do you take the stent out? And what happens once you take the stent out? And if it is a distal pancreatic tail, the gold standard would be to do a distal pancreatectomy, and that's the end of it. So what is the follow-up, clinical follow-up? What happens to these patients?
Yeah, thank you for bringing that up. In the interest of time, I won't show much follow-up there. But yes, 3 or 4 were more recent ones. So we are waiting follow-up. But the 2 patients, we managed to get across the papilla in the follow-up when we did the endoscopy and got the gallbladder across. Clinically, both of them responded very well with resolution of pancreatic ascites over the course of 7 to 14 days. The first one had pancreatitis, the others did not. They all had resolution of the pancreatic ascites. And follow-up, we go across the gastric axis. Now that can be a challenge, and we want to make sure that we don't lose that stent. We go across the gastric axis side, get the guidewire across. Things are much stable now, and we get the guidewire across the papilla. And then we want to do technique again transgastric placement of a plastic stent across and transpapillary access. These patients have edema. So much edema that we cannot get the scope across, or we can't see the papilla, we need to be possible. So by the time they come back to follow up, everything is settled, the edema is gone down, we need to be at that point.
And my question, sir, what about the downsizing aspect? You said that in this thing, ablation, doing this thing with a small tumor is all right, but what is the size limit? Because when we talk of downsizing in pancreatic ductal adenocarcinomas, these tumors would be abutting the pancreatic duct, maybe the portal vein. So the complications, the closer you are to the pancreatic duct, maybe portal vein.
So when you abate these tumors, the average size that has been used is 2 centimeters.
for the neuroendocrine and the other solid tumors. For pancreatic cancer, they are now 2 centimeters, a good size for a surgeon to operate, especially if there is no involvement in the vessels. And but if they're invading the vessel, our aim is to burn the central part of the tumor, leaving a shed. You can always come back and do it again a few weeks, 4 to 6 weeks later, and probably do it at a separate setting. But try not to overdo in these patients, for the simple reason that if you cause pancreatitis because of the procedure, then patient has a second problem now with its own complications.
With this picture, is it seen in long-term follow-up in these patients?
Yes, so pancreatitis is one of the complications, and that's why we reduce our vortex from 50 to 30 now. Although it takes a little longer than usual. Earlier, when we used 50, about 10-15 seconds, the burn used to happen, but now it goes to about 20 more than 20 seconds or so. And this picture is related to the pancreatitis, which can sometimes lead to fluid collection as well.
So my question to Dr. Sandeep sir, when we use intraductal biliary RFA, so what is the difference in biliary RFA catheter versus this catheter which is used in pancreatic, and what is the different protocols? Because in there we use 70 watt and the catheter is available different lengths.
So biliary RFA and pancreatic RFA, there are two different things. In biliary RFA, it's an intraductal RFA where we use about 10 watts of and the generator remains the same. It's built from Taiwan. The catheter goes over the guide wire just like any device, and you station your the spirals or the electrodes at the site of stricture, and then you burn. But you don't see anything objective. You can't see anything on a fluoroscopy unless you do a cholangioscopy before and after and see that area has got burned. That's only academic purpose, but doesn't serve any other purpose. Whereas in this transmural or EVS guided RFA, we actually burn and see under EVS visions, and the wattage generally people use about 30 watt or so.
The secondary guiding say EVS region, because E-pass balloon is commercially not available. Now, what is the tips and tricks? Because we want the jejunum should be dilate, proximal available jejunum. What are your tips?
So for that, we need to pass a thick nasojejunal tube, you can use a nasocystic tube that you use for a biliary system, and position in such a way that you are around the DJ flexure area, which you can identify on fluoroscopy at the time of placement, and then inject very vigorously large amount of saline with contrast and a coloring agent. At the same time, you also paralyze a duodenum so that the small bowel, so that the fluid remains there. The very important part of this is, at the time of injection, your EVS scope should be there so you can identify, and it has to be under fluoroscopy. So you either use prone or a supine position so that you know the anatomy well, just like for any other biliary or pancreatic duct interventions. And once you have paralyzed the duodenum, you accumulate the loop is distended, you immediately puncture it. Don't wait for too long. The longer you wait, the more chances of complications. Because sometimes it goes down into the small bowel, even the colon, so people have ended up being gastrocolostomy when they kept waiting long enough.
Thank you so much. I think we'll close the session there now. Thank you, esteemed speakers, Dr. Bapuna, Dr. Sandeep Lathakia, Dr. Saurabh, and our chairpersons, Dr. Pankaj, Dr. Ahmed, and Dr. Piyush, my fellow co-chair, Dr. Dinesh. Thank you so much. And do we have a deep breath?
Yeah, hi, thank you everyone, and we have a tea break now for 10 minutes sharp. We'll start the next session at 11:40. Thank you. All right, ladies and gentlemen, we are ready with our live demonstration. I will request the chairpersons for the session to kindly come on the stage. If you are in the auditorium, of course. May I request Dr. R.C. Soni, Dr. R.C. Soni, Dr. Ramila Shrestha to kindly come on the stage. Dr. G.S. Lamba, if you are here, kindly come on the stage, please. Dr. Vikas Pandya, request you to kindly come on the stage to take the chair. And Dr. Amit Niglani. I can see Dr. Shrestha is there. very much for coming back, ladies and gentlemen. I will take the name of the chairpersons once more. Dr. R.C. Soni, if you are here, kindly take the stage, please. Dr. G.S. Lamba, Dr. Vikas Panwar, and Dr. Amit Midlani. If you are here, kindly take the stage, please, as chairpersons for this session. Dr. Saul, are we good to go?
Good morning, everyone. We're starting the 37-year independent. Back, we have a research certificate of deliberate athletic pain, employing and unbroken. This bar, ultrasound show insensitivity in view of a typical history and the practice back 6 months back, previously responded in. Short summary, the patient to Dr. Hipendra Dutta, who is present. This case, Am I audible? Am I audible? Yes. Hello. Are you audible? Am I audible? Am I audible? Dr. Darren, are you audible? Yes, you are audible, sir. Okay. What is your topic? We want to pancreatic mass, where the resolution divided. This is the pancreatic mass, and we have to take it out. This is the ischemic vein, and there is a period, and you can see the PD. This is a PD, which is slightly prominent. When we this is the most prominent part, and measure it. This comes out to be 3.6 millimeters, slightly prominent. Actually, look at the current criteria. I didn't find any hyperechoic profile. So there are certain good steroids. There's no the certain hyperechoic trend is about than 3 millimeters, and if I use less than 2 millimeters. So I'm going to quickly pancreatic body pain, slightly prominent. You can see the pancreatic PD. I'm going towards the tail part. Now this is the left kidney. Going towards the tail. Towards the tail. This is a PD going towards the tail. This is a thin PD. Yeah. So only thing which I will find is prominent PD. And then hyperechoic PD margin, which is I don't see no much space around maybe one third of the pancreatic protein PD line. So till now I haven't seen any hyperechoic society shadowing or hyperechoic trend is shadowing PD. So I mean, go by major criteria. I didn't find any major criteria. I'm going to what we have. I'll show you. We have. Okay. So this is this is a figure again. You can see at the head. This is the neck part. This is a polygon. This is a PVD. And this is a PVD. Okay. This is going to working with. And slightly hyperechoic noises. Measuring it, if we had, it's come out to be 3.1, 3.2 millimeter. So no side branches, no current terminal is no hyperechoic bands which arrange or hyperechoic globules or lobules. I didn't find any mobility also. I'm going towards the LED to look at the unfinished part and in the way to now. What's the planning? Just immediate water. So, this is the rotor. This is now incident part. You can see the 3D. This is a 3D, I think, slightly prominent. Prominent 3D and that upper the 3D. And this is a patella, small patella. Only, I didn't find any side branches also. Some current, static current, but there's no several at all. So all the minor criteria, no major criteria. If we go by US, I mean, so hardly most of the US they will follow by resonance. Even if we go by resonance criteria, not fitting into the 2025. I show a whole of the antenna. See, this is antenna that is one way. I didn't find any major criteria. So only minor criteria. So I just wanted an opinion from the how do I do it? Because major need to do the CPD, but I don't find any major criteria to do the CPD. So I want an opinion from the how of the chairperson. What should be actually to be done in this case? This patient has a loss of weight loss of around 15 to 20 kg and pain. And the one important history we had some relief with the previous 6 months or 5 months ago with the CPD. So I don't get please let me know the opinion of the house, what should be done actually to be done in this case. Do I go ahead with the, in my opinion, should not be done because I didn't find any solid criteria for point consideration.
Yogesh, Dr. Sandikar, Yogesh.
Yes, indeed.
Yeah, so as you can see from the US, there are no definite criteria to level this as chronic pericarditis. So you should not go ahead with any celiac plexus block.
Dr. Saurabh Bukewal is there. He recently talked about this topic. So what are your comments? Dr. Saurabh, are you doing anything? The important part, only thing is we can see the renal artery is quite prominent, even more than a serious artery. So I think we should look for this is a renal artery. The renal artery is quite prominent.
Yeah. Have you seen from the D1 head of the pancreas and lancet?
I'm in the lesson, sir.
Yeah, can you show us like the head of the pancreas?
Okay. So this is a very difficult case actually. He is alcoholic. He had documented episodes of pancreatitis around 10 years back. This is the head of the continuous alcohol. Now I mean significant weight loss of 20 kg and fear of eating and post-renal severe pain in the epigastric going to the back. And there is no other explanation for the weight loss. Metabolic factors are normal, baby chest is normal. And pain is very typical of pancreatic pain, post-renal pain going to the back. So, but on the US, there is evidence of chronic pancreatitis. I think the duct is slightly prominent. The only and the ductal margin. Yeah, duct is slightly prominent. So I think this likely have chronic pancreatitis if we take the biopsy. Maybe we are on US, we may miss certain patients who have pancreatitis. So this may be one of those patients. When you're X-ray and one other things, I think we're dealing with the pancreatic pain actually.
Dr. Sanjeev, you are here, sir, if you are well, can you recommend for this patient? Sanjeev, what is audience suggestion then?
So if you go by guidelines, like it's always patient to patient, we can always individualize the treatment protocol for the patient. But if you go protocol wise and the guideline wise, this is not a patient for block. But yes, if you don't find any other cause, and maybe this is a disease in evolution, and so much of weight loss, and there is a past history that he had responded well to the celiac plexus block.
Finally, we leave it to Dr. Vikas. Okay, so Dr. Vikas, it is doing the procedure, so we go ahead, sir. Okay?
Very severe, significant pain, losing weight, and I don't think there is any harm if it is very safe procedure. My opinion in this case, let's go for the severe block. We have already tried the pancreatic treatment in case then or large. And we had partial response earlier. We can give him the more trial.
So what are the agents you are going to use? Dr. Yogesh and Dr. Gaurav?
Okay. So this is the celiac plexus, celiac artery. You can see the aorta. This is the celiac artery, and I'm going towards anti-clockwise rotating the stroke. You can find the left gastric artery, and then divide into renal and pulmonary hepatic artery. The first part is usually the four ways to do it. One is you just put a agent and using this GC again 1 to 5%, and the transferrin 80 milligrams. And there are 4 ways to do it. Either you just, I think, find it earlier actually. You find this in around 2 side of cases, around 60% should be potential, right? But in my experience, I didn't find even in 30% of cases. So you can inject here just above the electron and bilaterally, either on the left, just rotating on the this side, left side. This is space. Space is less on the left, and this space is on the right side. You can do so it's a bilateral anterior, or you can do this is a SMA, is on again the second one. You can do here the broad plexus. You can there are the studies which suggest that the broad plexus neurolysis is better than the celiac plexus block, and or you can do the both celiac plexus also along with the broad plexus block. So basically you can see here there is SMA arising, and you can see there's no artery or any celiac plexus coming. So I'm going to put a Glucagon first, and then the steroid. Will be steps before we are moving the insulin gene. Yeah. So first, one should because this is a US that is an interior approach. So first we localize the aorta and then the electron, and you can confirm it by just rotate the spoke by very anti-clockwise. You can find the left gastric, and then the renal artery, and this going down into the pulmonary hepatic artery. Okay. So first we just to localize, and we can inject the agent here just after the originated, before the origination of that gastric artery. This is the perfect place we can find. So I'm just going to the anterior approach on the chiplet of electron. Yeah. Usually you find a ganglion theoretically. You can find a ganglion there. It's a down around 5 to 8 millimeters round, hyperplane structure just above the seeded trunk. And this is studies, if you put a ribbon directly into the ganglion versus if you can find there's an equal result. So, I mean, there's no other advantage of putting a ribbon into the ganglion. Okay. So actually, now here, actually, the issues in this case, which is chronic pancreatitis, we can find a you confuse in a case of when there's a malignancy and if there's a lymph node. Then there is a difficulty, but again, we go with the position and small in 5 to 8 millimeters, just above the ciliary trunk, those, most convoluted area. So, are you ready? So, this is a diagram. We should avoid this. This is a diagram where my cursor is. So this is pivot trunk. So there are two. I showed you there's a 4 ways to do it. Either inject here, slightly anti-clockwise. You can inject here. So this patient is clear that face is left, and this is a left side. You rotate your feet clockwise, and you can inject here. This is a right side of the curve. So this is a bilateral block, or this is anterior to the fibula. Second, then you inject the above the SMA here. So this is a broad practice block, or you can do simultaneously both. Simultaneously both. There are studies that show that doing both broad practice or the figure practice is better than the figure practice. Are we ready? So I'm using the principal grade needle. This is Boston. So there are various specially designed needles available. You can do it by 22. You can do it by 19. Yeah. So you are using a 19 gauge needle? Yeah, 19 gauge. I'm using the 22. And there is one special spray needle from the book. Let's take out the needle. Show me that. Just show me. Yeah,
How much Bupivo and how much triamcinolone you are using?
So I am using terminal of Discipline. One should very cautious before putting a Discipline on the show. Because if you put this in his artery, then patient goes in a arrhythmia.
Should I spray it before injecting all this?
Yeah, very important, very important. This is I am not using this spirit because you can go with the spirit also, but I am not using it. Reason, as we put the spirit into the needle again, some air will come here and just void the area. So perfectly not using, but one can use it. So any question? I'm going in. So this is
Suppose you inject the ganglion, how much do you inject?
I'm using 10 ml of Discipline, 0.25%, and 80. This is a block. So I'm using 80 milligram of triamcinolone. That 1 ml is 20, 1 ml is 30, and 2 ml is 80 milligram. So this is before putting, I want to do the process. This is a tree, and you can see there is a left production. Okay, there are other videos also available. Yes. Yes. Going on. I'm inside. Just what is signal. Just above the electron. You can see just the drawing button. Just above the electron. Okay. So now just aspirate first. Aspirate. Sorry. Every just aspirate. Aspirate. Huh? Before putting any agent, you need to aspirate. Aspirate for one right. One should be sure it should not be in a vessel. Just keep on. Just 30 seconds. Just
Dr. Goel, like while injecting, it's always advisable to use a 10 centimeter because the technician is thrusting from above. It's like when he's injecting, there is always a chance.
I asked him to put a tool here.
No. So the better way is use a 10 centimeter with a three-way stopcock. 10 centimeter extension. So that is always a safer technique to do.
Yeah, I usually do my technician take his tools. We just, with the height becomes more than me, and then inject it from the above.
Yeah, that's also can be done, but that always the risk is there, like because when he keeps on pushing from above, sometimes the needle might go in and may not be in the desired.
I just put in my hand.
Yeah.
So my needle goes in.
Now for the beginners, like when you are an expert, you can do.
Okay, aspirated. Just put a. I think you can do it by this method only. You can. Okay. Again, aspirate. Just go it away. No, I'm not able to see the screen. Pardon? This is a cigarette artist. To select from this is a this is a cigarette. This is a rotor. Just 1 centimeter. This is a rotor. This is regulated. I can go a little 0.5 centimeter here also. Yeah, that can be done. But this is, you need to inject it before the origin of the gastric artery and quite before that. There is no artery coming here. This is a signal of a negative. Okay. Aspirated. You can, I can keep it. To some extent. Yeah. Aspirated first. Okay. Yeah. And you can, as you just putting a agent, you can see some of the haziness coming around. More with the alcohol, you can see here, and sometimes you can see some hypotension as well as the bradycardia.
Can you comment on how much pressure or strength is required while this is being injected?
If you go with a 22, it's a little more. If you go with a 19, pressure is little less.
Yeah, I think it's important to highlight the fact that the technician is applying a lot of pressure, confirming that in the right space.
If you take a 19 view, there is some tension of sometimes there is doesn't go in because of the tension. Just aspirate it. Okay. No, I have, yeah, if I use I mean, even EMI. First is I prime the needle with a saline and then aspirate and then put a Jessica vein and then aspirate and then put a 10 ml of absolute alcohol. Okay, one. And this you need to say 30 ml of saline. So everything is 1 minute, little 3 ml of 3 ml of saline. So just because all the steroid goes in the face. Okay? Yeah, that's the steroid. So I have done the procedure. I'm taking out the needle. Just take out again, I just aspirate again. Also, between adding hazard is 22 or 19 things. 22 is because you just usually don't give the epic tempting of gastric mucosa. Sometimes it's difficult to clear. It's very close, sometimes it's very close to letter the patient is very thin. So I'm taking it out. Patient is very thin and very close to gastric wall. You see sometimes bradycardia, more so if you inject in a ganglia, bradycardia, hypertension, also diarrhea, and this is the common, these are the manageable side effects. Okay, at the site of injection, how do you see the screen? Because initially injected here, you can see some hydrate, usually with alcohol. Yes, it is hyper-alcohol on high drink for which usually don't get with steroid or with the steroid. Okay, more of it you can see with the alcohol. So good. As per theoretical teaching, ideal site is of injection is at the origin of injected here. Just injected slightly above than the origin of the celiac acid. I mean, it doesn't make. I injected here, you can inject here, I mean, 1.5 centimeters. Then, how to evaluate anterior aspect, posterior aspect is usually they do by CT. I mean, it's not by, yeah, we will try to go anterior to the organ. So this is anterior approach. Posterior is with the regular CT. And I told you that there are the 4 methods. So we start with the next live demonstration. Thank you, Dr. Bhatt. Thank you, sir. Challenge is moving to next phase.
Moving to the next case, we have this 90 years old lady. He had history of pain and torment with recurrent non-liver stomatitis and a significant weight loss for last 2 months. On upper GI, we have the circumferential European duodenum at T1-T2 junction and stool was not negotiable. The injury is likely malignant. CT scan was confirming. So finally, the case is a case of a gastric outlet obstruction, likely malignant. Doctor on she was the gastric region to be OD.
Can you see me?
Yes, we can see you, sir. We can see you.
So we have the patient ready to find, and the most important part is the patient is under care of anesthesia. Dr. Rahul is here and he has intubated the patient and we have kept her in designed position. So as we heard the history, she had a duodenal obstruction in second part with outward obstruction syndrome, and the diagnosis is most likely malignant. So we are very slowly, step by step, and using the EPAS value, and for EPAS there are several steps are required. So before coming to the screen, what we did was endoscopy to look at the stomach, because any patient who has outward obstruction, you are all must be knowing that they can have food inside, so stomach has to be clean. Fortunately, she had an ice cube inside which was irrigating and draining the stomach, so stomach is relatively clean. So that's the first step. Then we start the procedure after intubation, say food is there, and then we go down to step. So now I have a IOB endoscope in my hand, as you can see, and I am using an oral tube, which is the overtube used by the endoscopy people, like single balloon endoscope, the short overtube, and this has now passed through the overtube. The scope pit is beyond. I will tell that the purpose of the overtube is to prevent looping of the double balloon in the stomach. That's the only purpose. Since this EPAS balloon or double balloon is a very floppy one, if you had a stiffer one, then the overtube is not required. So one step can be avoided. So now I will ask the scope with the overtube. This has to be very gently done. Because this has to go beyond, beside the. Okay, so we are. Little bit of trauma is there in the esophagus. That was because of the virus which was there earlier. And now I am in the upper esophagus. So don't worry about the trauma. This is not the problem. But this is another thing which is happening. So my overtube is now going along with the endoscope. And I will go. You can read, then from the gastric content, go towards the pylorus. You can see some food residue inside. This much is okay. But ideally it should be as much clean as possible. Try to go across the pylorus. And that should be okay. So that's the first step done. I will now use a regular cannula with a guide wire and try to go beyond the. Now, if there is some food matter just proximal to the stricture, you can have the fluoroscopy ready, which can be focused at the tip of my endoscope. Fluoroscopy too, and focus at the tip of the endoscope. Some matter you can see on the far end, on the right side. Okay, is the fluoroscopy there with you?
No.
Okay, just a minute. Okay. Only US and fluoro. Other endoscopy. So here comes the cannula. This can be a regular cannula or sometimes a double lumen cannula can be used. The purpose of a double lumen cannula is you can also get contrast beside it. Tip of endoscopy is on the fluoroscopy. Okay. Can you remove some of this wire that is side and make it easier for the audience? If it can be, otherwise it's okay. Okay, no problem, no problem. That's an interesting point. So let me now pass the. Okay, right. Okay, good. My wire is gone, so fluoroscopy please. Okay, so gone beyond, so can you trace the wire tip? So the horizontal part of the diaphragm is okay. We will now go to another side. Thank you, sir. With the toss around, I am very comfortable now. And with the Jahangir sitting here also. So, can you just manipulate and let's go deep down? I want it as deep as possible. This is bouncing back of the deviate person most likely. We'll try a few times and then we'll inject some contrast and get an answer. As we went up with it. Okay. And wait, the top session. Wire manipulation is important at this point. I think each step is important. It is not, yeah, that's good, down, very nice. Very nice. So I just follow this wire now. And as deep as possible. Let's go deeper now. A little bit more, some more. And yes, thank you, Vikas. So Vikas is reading my mind and is moving accordingly. That's right, that's right. Very nice. So we'll cross one more loop. Once I go deeper now, I will drop it. And go deeper in the interior loop. It's going like bouncing on the same loop. Come back, come back, come back, come back, come back inside the pattern. Now you try, now try. I think it's same way to forward. So if it goes a little bit more, I think 10 centimeters more, I will be happy. No, I will pull back a little bit more. Pull back the wire and try again. Try again. Slipping back, yes, okay. Update it. I think update it. I think it will go down. It will go down. Withdraw the wire, no? Withdraw the wire. Withdraw the wire. And now we try once again. I think everything is okay. Okay, so I think let's okay. Maybe we can get a contrast. Maybe go like this point. Let's look at the distal two of the contrast. After the contrast value. And pull back a little bit more. Make it clear. वही बात क्या है? Not going further. ऊपर सेंटर कर सकते हैं। ऐसे the doctor में सेंटर। इसमें इंक्रीमेंट हुआ है। Okay, okay. We'll figure out the wiring and stop contract. Put some correct. And it's pull down. So the wire has to go downward. Increment. You pull down the wire. Pull down the wire. It is hard. मैंने तो इतना कि नीचे रहना है। आप पुल कर रहा हूँ। आपके ट्रायल को चला जाएगा ये। यहीं पे घूम के जाएगा। और विड्रॉ कर रहा हूँ। कोई बात नहीं। Very nice, very nice. So it's all. So this is the position that I want. Let me change this for a while because this is very good, right? So now I encourage this inside. I took out the camera, raise a bit larger, and now we will keep that and change the. Let's really like 150 is done. It's very well. Very well. So that's one of the steps crossed now. So you see the anatomy there, and the DJ structure is taking a loop and then going down. So that should be a target for DJ. So here goes the wire, yes. So at this point will be one of our target areas. Where it's taking now a turn down, that's closer to the stomach. That will be a target organ or function. So, okay, I will draw the catheter, leaving the guide wire inside. Okay. Intermittent therapy. Yeah. Very nice. As the date now we inject in contrast there also to define that picture. Just for the academic purpose. I will draw that. Easy, very nice. I have a name. Nitish, what do you mean? Because you are blessed to have Nitish with you and the entire team, I think that's fantastic. The setup is amazing and everybody knows his job. And that's the most important thing because we are dedicated and very tricky to people where we do not have to teach them at that critical time. And he is aware of what he is doing and what is expected to him. So please, I will try very slowly so that the method of the wire doesn't move from its place. And now we can, in the same contrast here, can you bring this card in the center of the screen of the floor? So that just for the reason where the picture was located, which is found also to use the distal margin. थोड़ा कंट्रोल करिए एंड थोड़ा सा यस कीप इन दैट ओके ओके so that's a picture okay very nice so water flow type of agreement so the job is done now this now I will withdraw the catheter leaving this long diameter inside exchange please one more time that I don't accidentally put it back. You can identify the picture very nicely and go out to it. Yeah, the floor there in the hall.
Yes, yes, we have that floor image. Sir, which part of jejunum do you plan to puncture? Like always, this is a first part or whichever segment is easily available?
Whichever is easily available. So now we have the catheter out, and at this point, I will withdraw my scope and get to the fluoroscope, please. Scope. I will I just want to see the overview now. The shape of the overview is very much you can see that. So I will use the overview there and withdraw the scope, keeping the diagram of the question. I'll be the hand of British, I'll be the hand. Right here, हल्का सा push करते रहेंगे। अब scope पे निकालना है, तो फ्लोरो please, फ्लोरो, yes.
So Sandeep sir, Saurabh, have you had trouble getting the overtube across, and can you describe what is the diameter of the overtube in extremely tight stenotic lesions sometimes? Exchange.
This is a standard overtube of the shot and then a single balloon for the vessel.
Oh, I apologize. I meant the balloon catheter. I didn't mean overtube. But that's okay. Take your time. Take your time.
16.16 and it's 3 meters long. And that's why we need a very long wire, 450 centimeters or even longer. So here comes the endoscope out of the overtube almost. And the job of endoscope is over now. I understand there will be a lot of questions among the audience that why so much of fuss and fuss about doing so much steps and then rather entrance, but that we can always discuss. We have some query and question answer that time. So now we will pass the overview and the cameraman can focus here on you. So this is the overview. There are 4 channels here, as you can see it. The 2 orange ones, if you can see, are to fill the balloon. And we will fill the balloon with about 40 cc of saline and contrast. The purpose of these 2 balloons, the forward and the backward balloon, is to anchor the vaginal vein close to the stomach so that it doesn't move around. This one is for the guide wire, and this one is to fill the intervening space between the 2 balloons with plenty of solution of contrast, saline and a carbon agent. Okay, and this goes over the molecule. So this is the tip of the catheter, which is 16 millimeters and 3 meters long. It has 6 leg balls at the tip, and the first balloon starts about 5 centimeters from the leg ball, which has a radiographic marker, and the second balloon has also a radiographic marker, which you can control on the. So these are 2 balloons which I will be filling up, and in between this area, in between this saline. It has multiple side holes here. Okay, so let's now pass it over to diagram with it. After it, thank you. So the purpose of overtube is only, as I said earlier, to prevent the buckling of the very floppy piece of balloon. That's the drawback of it. If it was stiffer, I believe the one step can be avoided and passage of overtube can be avoided. Good. So this we will follow on the over again. Follow please. I'll just pulling that. So it is so long that it is taken out the guidelines. You will still not come from the proximal end. So then I have to put out the wire of thoracoscopy. Yeah, I'm pulling back, it's not deeper now. I have one optimal, a little bit, another line. That's another challenge that sometimes can go there, come there. Okay. Okay, 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 so now I'll push it in. So that's one little issue, push the wire and then push the wire. I have somebody observed rightly that the wire has come out very well. And yes, please push it down, push it more. Very good, very good, very good. Here comes the wire in the overview, sorry, you can put the red ball from this too. We can now follow the red ball. It goes to the overview. Then without changes. Yes, thank you. So it's now crossed the tip and it's following the wire. And we are just at the picture side and it goes across the picture.
We lost the flow image.
No, no. If you get in late for you, will not move forward till you have your back on ferocity. Are you getting the photo now? No.
Not yet.
Are you?
No, sir.
Just say yes from that side. You got the photo?
No, sir.
Okay. Photo on for you?
Yes.
Are you there?
Yes, yes.
Okay, so when you see the red ball is there, the third side of there now, and the first color is you can see the mark, radio page mark of the first, the column balloon.
Yes.
Okay, it's now in the second, third side, and then it goes down, take it as deep as possible, as deep as possible. Right, right.
बकल हो जाता है. So actually
There is
बहुत
one
flexible.
second balloon, which is now crossing the picture.
Yes.
On the left side of the screen.
Yes, yes, yes. We could see that.
I am now looking at the two balloons, two markers, radio page markers. They look far apart from each other, but that's fine. That's fine. Yes. My aim is to put the backward balloon or the more proximal balloon somewhere in the third part. So if I keep it like this, I will be functioning the DJ section.
Yeah.
But I can also have another loop beyond, which will make it my answer to ask me. And let me go down more. Since we are getting one more loop, is actually division close to this one. So I'm pushing everything down, You have to be careful, this is the forward balloon, which is the backward balloon.
Go forward.
And it's better to move as deep as possible, you always pull back, but cannot push it once the load is out. Column balloon is now going on the right side of the field, just
Yeah.
cross the screen, and the hair comes up backward balloon. I think we can stop here. Can you just towards my side, a little bit? Yeah, okay. So we have now inverted U-shaped loop, and now we will what we will do is pull down the overview. Okay, the overview has done its job, even the diagram inside, and the and pulling down the overview, The overview is not hanging on the e-pass balloon. We cannot pull it out because of the proximal multiple channel or full channel here. So now we start filling. Can you fill the balloon now? The forward and the backward balloon by contrast. Center इसमें एक में S लिखा है और एक में B लिखा है. Backward balloon orange to go.
So which balloon do you reflect first?
I think forward first. It will have up to 20 contrast.
Forward first.
We saw the balloon that is filled
Yes.
outside of the screen. Is it dilute contrast or pure contrast? Actually, it's dilute contrast. दूसरे को भी स्टार्ट कर सकते हैं. दो आदमी चाहिए हमको, एक वो करेगा एक वो करेगा. 40 cc. अदर पर्सन एक और अंडा वो contrast के साथ है. इसी में डालो. कितना डाला आपने? 10% डाला है, 10 वाला ये आपको 40,000 का याद रखना है और दूसरा वाला बलून में शायद डाल 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 ये थोड़ा थोड़ा डाल डाल ठीक है डाल डाल के डाल डाल मेरे 30 डाल के देखते हैं ये कौन खाते हैं गुलाब जो वो विष्णु बस ओके 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 अनालिसिस में आना पड़ेगा इस तरह से now we set up balloon which is back balloon towards that is proximal balloon. The distal balloon is filled and a cylindrical which is very nice position. You get this? See, sorry. So see the other balloon getting filled up now. It's lighted up. Sandeep, you can see it there?
Yes, we can see.
Okay, okay. Very good, sir. 10 more to go. I think 20 will be okay here. So we will get top here, 20 circle will stop here.
Yeah, I think looks
I
right.
recommended you about 30, but I have clear that if it does do more than it does, then one experiment goes with. You can also add more fluid later on if required.
So,
Yeah, 30.
so how much fluid have you injected in between the balloons?
20 cc in each balloon now,
Okay.
and that looks to be a good cylinder, which looks to be anchoring well to the loop. Okay. Now we will use the US scope and I will pass it down. Is the stent ready? Stent open करके ready करना है. And when I have the US scope without the balloon. So we pass the second most crucial step.
And sir, how much fluid is required, in between the balloons?
Very good question, sir. That will be about 100 to 120 cc generally required. But we will see how it goes. This may be required much lesser amount with the balloon. I anticipate even better may be required that side as well.
So that you assess from the US image.
Yes, yes. So once we have a good view, at this time we are able to will get some saline. Sorry, Duxoban. Okay, so just to paralyze the bowel. Sometimes if the balloons are not doubly settled, some of the contrast can leak inside and go forward.
Okay.
And longer it takes, then that may also cause hindrance in my view. What I told in the morning, that if you're doing 3 hours and taking longer time, the same problems can also occur during this procedure. Always much less common, and that's why my target organ should be the moment it's ready, I will puncture it.
So is the coloring agent you use methylene blue?
It's indigo carbon.
Indigo carbon.
So we can use methylene to indigo carbon. Indigo carbon is safer, and it's now prevalent constitutes of all the third phase procedures. 20. So GK is 20. All the people are used to see. So you have US code ready, and your coloring agent you can just ready with the right happen. Is that 20 cm? Okay. It's a first. इसमें ना first पहले contrast डालना. First 20 cm pure contrast डालना. And then you will follow with the coloring agent. So you can actually mix the contrast in the solution, or you can first inject contrast and then follow with the coloring solution. So far so good. We are doing okay. This is a regular US junior school, and I am really fortunate because the old friend lady is here, and I have to do. Besides this, so we have endotracheal tube and the balloon and the left side is beside it, and थोड़ा सा It can replace little bit. That will allow my. I thought this part different position.
I think the scope is within 50 years because we have. As a very careful and gentle.
And I just pull back and. A little bit of trick from the anesthesia to me, and he allowed me to get a little more space with the relaxation of the left. Besides that, he will not. Go down. इसमें डायरेक्शन लगा है ये भी इस तरह का नहीं हो रहा है एंडोक्राइन जो आता है I down. I think I have done it. I don't know if it's not that. I don't know. Oh, felt again. What is the right?
Yes.
Yeah. I'm not going. Still not going.
So he is a 90-year-old, very thin, frail patient with a short neck. That's why there is some difficulty.
After that, they have it.
Normally, earlier you would prefer careful intubation, but in this particular patient with ED2 and already we consider very careful like this.
And a one. Okay, I'm done.
Yes, sir. Won't be easily restrained.
And playing my own level, I don't get but still have some discomfort in my throat later on for a few days. I anticipate that, but that's okay. Now you can have the ears big, and now you can fluoro please, and I have the fluoro. I position myself between the two rooms. So that's putting connection now. So very nice.
So we want fluoro and those both images we want.
Yeah. So only endophono and fluoro. Can you have fluoro and make it really lower down? Yeah, that's perfect. That's very good. So now I'm looking at the group. So it's an inverted group, and you can fill all the controlling area. And Pustaka has been given. And get that. Fluoro continuously.
Can you get the US image side by side? We are getting only the fluoro image. Yeah.
Yeah, that's cool.
And you can see on fluoro. You need to see on US.
Can you enlarge the US image? US image. Zoom in. No, no, not. So,
Is that allowed? How much is one?
yeah, that's okay.
I want to see that look now. I don't want to look that. I have to rotate and see that. Although my US is there, I have to see it behind my it. Yeah, it is little on a different angle. Stop this. Don't like that. If I like it, I just hold on there, hold on there. And too bad, this is it. And this is better. I saw one loop which went by. Yeah, you're very good. And I'm just I will. Well, I'm gonna. Okay, there is. I'm still not able to see the in a very comfortable position of that. And I put that. I went down and I now pulled back. This is one balloon. One balloon. So you can see it's very close. I'm putting an even and I'm pull back. Pull back. Yeah. We should do it there.
Yes, so maybe you can pull the scope up more. I guess you're looking further down, I suppose.
I'm also trying to get my foot position very comfortable because when I
Yeah.
stand, I don't want to get a half bend, twisted position and I get a back.
Yeah.
Okay, no problem. And you will get it if you are in a good position for us to take it. Maybe it's towards you on that. You here.
Yeah, maybe you can pull back the
What is
scope.
the other better? Normally we target a serious fracture area. That comes very easily and so. This because the I can usually come out more. And then just press again. There it is. Okay, this is better. More and little more. No. I'm around that. Far away from my comfort point. This is one area. It is still far away from me. I want on the right side or just below my knee. I pass around.
The area looks good, but I think the intervening bowel between the distended one.
Yeah, that's right. We do not go too bad over there.
Yeah, there it looks like there's a bowel between the gastric lumen and the distended lumen there.
I pull back quite substantially.
It looks better there.
What are you? I don't miss that.
That looks like a nice site.
Yeah, this looks good. Stomach. You have to inject more.
Yeah, I think having the dilated loop on the left of your screen is probably desirable, I guess.
It's not a very convenient position on me. It looks good on the true, but I become a very
So the US image is from the left hand side, like, is that? Yeah, now it looks good.
I think Dr. Rajesh put it in the last case.
Yeah, yeah. So I'd like to inject more in the intervening segment. Yeah, leaked out. Yeah.
Maybe injected in because this liver has collapsed. And I'm going to rightly observe that the parameters that this is also dilated. So we are increasing the volume of the two variables by 250 and then quickly, and then we will inject the segment with more current and the very movement there. That's the volume getting it's not very bad. It's okay, I read this now. This is segment now.
Yes.
Better now?
Yes.
25 degrees now. That looks nice. I'll pull back a little bit more maybe, so that I can get it. That is more offended.
Sandeep sir, just a note, I mean, we're going to distill it as much as possible. But the Axios assembly will want to insert the catheter about 5 centimeters in for appropriate deployment, right?
Somebody remove it. Somebody remove it. Okay, then. That's all my work is fine.
Yeah.
And that's why I'm just seeing it here.
So longitudinal axis is nicer, so you get a deeper. Yeah.
It's okay? Are you happy?
Yeah, looks great. I think you can advance the catheter nicely. Let's go. Okay. So are you going to pull back a little bit? Just as in the scope a little? Yeah. Yeah, that sounds nice. Yeah, it looks great. That's, yeah, looks fantastic. Very nice. Yeah, I think, thanks for showing it. I think it's important that we advance the catheter to the full extent, just because of the deployment, yeah.
Actually, I will write, I will come to you the speed and can be part. There is a little bit more.
Yeah, if you could also see the fluoro just to illustrate. I suppose. Yeah,
I'm going to give you a
yeah. Okay. So looks like the inner flange is deployed well.
And so right now, is that okay?
Yeah. No, but just before you, sorry, just before you do the last step, how much would you want? I mean, how much do you pull?
This much?
That seems like a lot, right?
Just deforming the inner flange.
Right.
And then I will lock the wheel shoot, unlock the proximal end. I'm not trying to see the knob to you. You want it more out?
I think that's fine. I think that's fine. I suppose the length between the gastric and the diurnal or jejunal wall is about 1 centimeter, which will be crucial.
Sorry? And now to you?
Half the cover. Half the
Yes, yes, yes. 100%.
Yeah. Okay. If you can show the scope needle hub, like the Axios assembly, perhaps, if a camera can show it, it'll be nice.
I now push it out and turn my scope away.
Looks good. Okay, wonderful. Yeah. That's excellent.
Yes, please. Yeah, we can just take it out. We can, let's let me finish the complete part of it. After that, question answer everybody. And because the blue color is now confirming everything, we can detail the balloons now. So I put your brain, please. The job is still not complete. Okay. So that's what I want. I will say, let it expand on the take several days, but that's okay. So, as you can see on the block, we're detailling now. The intervening segment anyway is going into the stomach and carrying your exam destiny. I'll keep cutting out the drastic content because once you get extubated, you do not have it. That's the last thing we want, but such a good anesthesia being done. I'm cutting out the drastic content and deflating both the balloons. Because while you pull back, it will hit the inner flange of the stent and either it can accidentally discharge. Although the lungs is long, but let's not try and challenge it also.
Sandeep sir, just a question. After you did the inner flange deployment, would you ever consider putting a guide wire worst case scenarios if there's mal deployment as a salvage sort of option in case access is there.
That's always a matter of option when we start thinking once some kind of accident happens.
Right.
And very kind of that. The fact about the contract is value in the government.
Sir, is there any chance like when you try to take out the balloon that it might take out the stent or? Is-
That's what I was telling you. Can you show the balloon in the center? Yeah, okay. So I am not deflating it gradually and I will know how to come out, put everything out. So what is the question? Sorry, to an extent. That somebody else can discuss, but cost to cost, I think that lands is cheaper, but we need to go for the best. When we are doing these high procedures, I think we should not compromise on that part of it. Either go to that, put an interest and then finish it off. And I agree with him. And my job is to do the procedure safe manner and for a sustained self-agency. So if you don't start with a lamp, start with interest. Follow? Now the balloon has deflated as you can see on the screen, and I'm pulling back the EFAR double balloon with the wire, everything out, and you see the stent is not moving there.
Yes.
Besides the stent, that didn't move.
Yes.
Sorry. It's all done. Now, so that everybody can see us and we can ask the same question. So OOTP is necessary for preventing buckling of the EFAR balloon inside the tunnel. If you have a stiff NJP, then OOTP will not be required. Yeah, so descending the lumen and focusing on the lumen from the stomach and keeping a eye fixed on the target organ, target area is what is most important. You cannot move it cannot be a moving target. So that's why we will put on the right thumb and when the contrast and saline is descended in the lumen and then not one distributes. So be very.
So do you dilute the stent like you like 1 or 2 days after or it gets expanded?
So this expand today it is 5 millimeters, you can measure it, tomorrow it is 7.5, day after that it will be 10 mm. So I mean it starts only about 6 to 8 hours, 4 to 6 hours later. We should be having new tape and only what because entry cost at requiring for mortality. That is not there, there is no kind of pain and we will want to request you can start device by evening.
Okay, and did you use a 15 mm lamps or a 20 mm lamps for this case?
I'm sorry?
What size did you use, a 15 millimeters or a 20 millimeters?
20 millimeter hard
Oh, access, yeah.
and I have a question I answer is no, because we need a stent which anchors the two organs tightly. The stent should not move. Magic stent has a knot on both human and capability. The only stent which comes closest to access is access, but access has a maximum experience and has found to be very, very effective and safe. So we had experience of 2 patients out of 30 where benign conditions in chronic pancreatic infection and duodenal manifestation are in collateral. We have used hot axis, but here we use 1 in 50 and 120 mm stents in the 2 patients.
So thank you, sir.
Reported and the longest patency of the axis is 6 years by the Dakar report. We have faced in one patient many years ago and recently reviewed that case report.
So thank you, sir. Thank you for the excellent demonstration. We now start our next session. Sir. Thank you.
All right, so thank you so much, Dr. Latakia. We'll move to the next session now, and the topic for the same would be endoscopic ultrasound, liver and bile duct anatomy. May I request the moderators for this session to kindly come on the stage. May I request Dr. Kunal Das and Dr. B.D. Goswami to kindly come on the moderator side. And to chair this session, may I request Dr. Nikhil Gupta, Dr. Rinkesh Bansal, and Dr. Adnan Rafiq to kindly come on the side for the chairs. The first speaker for the session would be Dr. Siddharth Srivastava, please. Thank you.
Good afternoon, everyone. Lights are not going to stream coming up. Okay. Firstly, thanks a lot for the US 2021 team to give me this opportunity to talk about basic anatomy of the liver and bile duct. So sorry, there is some technical glitch. So I will take it later on after the first talk. Please. Dr. Subhash Gupta to speak on gallbladder and bile duct malignancies, my expectations in endoscopics. Dr. Subhash Gupta is chairman Center for Liver and Biliary Sciences.
So is it? It's really good, no? Yes, Thank you for the technical glitch. This is why it keeps a surgeon still active and working. Otherwise, with advancement in technology, you'd have the So surgeons to the rescue as always. So I'll be very brief because I think Sunday and everything. So by biliary tract malignancies, my expectations from the endoscopists. So the four areas where we need their help, or rather we work together in 4 areas: diagnosis, resectability, mainly for local spread, preoperative biliary decompression, and a tremendous role in palliation, and I will not cover that at all, because obviously that's an area where there is a great role for the. And can I, it's got to stop. Hello, can somebody help me out, please? It's stuck. Yeah. Okay. So as far as diagnosis is concerned, in gallbladder malignancies, polyps, symmetrical gallbladder wall thickening, xanthogranulomatous cholecystitis, Meiji syndrome, Hyler blocks, which are sort of amenable to medical treatment, such as IgG4, cholangiopathy, tuberculosis, lymphoma. And in transplant practice, if there's a primary sclerosing cholangitis with a dominant stricture, and sclerosing cholangitis, and these are the areas where we need the help of the endoscopist to guide us and save the patient from mutilating surgery. So we have also an important area which is now sort of emerging with increasing transplant practice is portal vein and bile duct tumor thrombosis, and I'll show you some cases of that. So a lot has been made about preoperative diagnosis. I think in HPV surgery it can be performed safely with improvements in sort of anesthesia, imaging, and then we'll show you here a bit about that from our radiology colleague, about the delineation of vascular anatomy. And therefore, in these situations, as is similar to periampullary carcinoma, biliary tract malignancy, surgery would be both diagnostic as well as therapeutic. However, what the endoscopist can do is save the individual from a sort of a big surgery. For example, if the gallbladder polyps greater than 1 centimeter in size, of course, they'll all have cholecystectomy. If it's less than 1 centimeter in size, and the doubts about what that lesion may be, endoscopists can help us in guiding the treatment. Quite often we see asymmetrical thickening of gallbladder wall, and the endoscopist will tell us what this lesion is, whether it is infiltrating the liver bed or free from it, then laparoscopic cholecystectomy alone would be curative. Similarly, in xanthogranulomatous cholecystitis, if the endoscopist could make this diagnosis preoperatively, complex surgery could be avoided. Syndrome, which often mimics Hyler block. So this is a thing that presentation that I picked up. Malignant bladder lesions, ultrasound FME, and xanthogranulomatous cholecystitis can be sort of diagnosed. And I've had on multiple occasions operated on xanthogranulomatous cholecystitis as malignancy. So that was gallbladder, then is Hyler block. Sometimes, although most of the time the lesion is a malignant lesion, but sometimes over career spanning 30 years, we come across tuberculosis, lymphoma, IgG4, cholangiopathy. And here the endoscopist could tell us what to do, because these are conditions that could be treated medically. But before we sort of start intervening, I think it's important that the triple phase CT of the liver should be done prior to endoscopy. A condition that we see quite commonly in our transplant practice is primary sclerosing cholangitis, which is an indication for transplantation. However, cholangiocarcinoma will develop quite often, and endoscopists must rule this out prior to transplantation, because if there is a coexisting cholangiocarcinoma, then obviously results after transplantation are poor. And this is something that where you see the involvement of only one lobe, the sclerosing cholangitis, and this condition, if you were to resect the left lobe, the person is cured and he does not need a transplant. Another important area that we see quite frequently nowadays is either both portal vein and bile duct tumor thrombus, and quite often these patients are downstage and the
the float is not restored, but the tumor may be gone. So the EOSFNA may make this diagnosis and help us in deciding for the rest of the treatment. Total biliopathy is best diagnosed by the endoscopist, and bile duct tumor thrombus, important thing to keep in mind, because with cirrhosis, HCC, altered liver function from the bile duct tumor thrombus, it may seem that the disease is incurable. Endoscopic ultrasound and endoscopies can help us in sort of diagnosing this and letting us know whether it is malignant or not. So we had one, the bile duct tumor thrombus, which, in the past I used to wonder why the Koreans and the Japanese report so much of it. But nowadays, when we started looking into it, we find that this is equally common here as well. So real lesion that's going into bile duct resulted in cirrhosis and raised LFTs, and obviously you would think that this would require transplantation or some downstaging and then transplantation. But you did a simple resection here, and we set out the bile duct tumor thrombus, and the person had ascites for a while, but now is well. So this again, the endoscopist can tell us what to do in these situations. Malignant lesions of the liver, particularly when they're single, then is it HCC, it's neuroendocrine, metastatic, and quite often they would undergo upper and lower GI endoscopy. But I wonder what is the role of that if the PET scan is negative. But I think at the moment we carry on doing all these things. In general, if it's a single lesion, it's a malignant lesion, then we should go ahead and resect, because I think results are good. So that was diagnosis. Then important role of endoscopist in telling us about resectability, of which I think CT angiography is the single most investigation. Lymph nodes, we must remember, they are not always sort of malignants. Quite often biliary obstruction will result in lymph nodes. Chronic viral infection, hepatitis B and C will also result in lymph nodes, and the endoscopist will clear the confusion. General gallbladder malignancy with surgical obstructive jaundice is generally regarded as unresectable unless the ultrasound and the endoscopist tells us that it is just because of local spread, not lower end block as well. Vascular involvement and resectability, bilateral involvement of vessels means it's not resectable, but luckily liver transplant techniques have evolved, and hepatic artery can also be reconstructed. And in very select cases, and I say very, very select cases, liver transplant could be an option. So here you have a cholangiocarcinoma, which is sort of involving the left portal vein and the left hepatic artery. And this would ordinarily be thought to be unresectable. But using liver transplant techniques, you can reconstruct these vessels and do a resection. You get lymph nodes from cholangitis as well. This was a 39-year-old lady who was recently referred to us, actually given chemotherapy because PET showed some lymph nodes. When the endoscopist did an ultrasound of the lymph nodes, they were negative, and we were able to do an R0 resection for this particular case. And in the specimen, all the lymph nodes were negative. Occasionally, we do encounter cases where sends have been placed in an operable lesion. That's why I keep saying that a CT angiogram should be done prior to any sort of endoscopic intervention. And we have a 40-year-old female presented with surgical obstructive jaundice, left-sided lesion, a metal stent had been placed in another hospital. She underwent a detailed ultrasound examination at a center, and we did an R0 section with removal of stent. So gallbladder cancer with surgical obstructive jaundice, is it always unresectable? Mostly so, but occasionally the ultrasound person tells you that it's resectable, we should go ahead and resect. Coming to the sort of another important area, in biliary tract malignancies, which is preoperative biliary decompression. In general, the pancreatic duodenectomy, it's clear that it's probably not indicated cholangitis, so there's doubts of liver function, such as those who are alcoholic, or if the INR does not correct with vitamin K injection, then it may be indicated. Highlight block and decompression. The Japanese groups have sort of popularized this drainage and embolization, but our experience has been not so good, expensive, patients are lost to follow-up, the spread of disease and the infective complication, of course, then will not end up with surgery at all. So if you're doing a left hepatectomy, decompression is not our policy now, and the frequency of right hepatectomy can be by vascular reconstruction of right hepatic artery. So we've done about 65 cases since we've been here in Max of biliary tract malignancies, and with a variety of surgeries, and they've all been because we sort of work together as a team. So finally, to conclude, the endoscopist must confirm the diagnosis for us so that limited surgery can be done in benign disorders such as, symmetrical wall thickening or sort of gallbladder, Meji's syndrome. Exclude malignancy in dominant stricture in PSC because transplant would not be indicated. You can sort of look at feasibility of laparoscopic surgery in what is suspected gallbladder cancer, but the endoscopist tells you that no, it's just asymmetrical thickening horizontal granulomatous cholecystitis. Preoperative optimization patients for surgery in select group of patients, and of course the endoscopist has a great role in palliation in cervical obstructive jaundice. Thank you very much for patient listening.
Thank you, sir, for nice lecture. We'll have question in the end. So for the next talk, we'll invite Dr. Ruchi Rastogi, Senior Consultant in Radiology Department, Max Hake. She will deliver lecture on imaging in bile duct and gallbladder disease. Dr. Ruchi, please.
Good afternoon. First of all, I would like to thank the organizers for giving me this opportunity. So today in the next 10 to 15 minutes, we are going to talk about imaging in gallbladder and bile duct diseases. So our imaging armamentarium includes sonography, which is especially a very favored modality because it is the most commonly available and very easy to use and can be repeated a number of times. Then CT scan is very helpful for hepatobiliary malignancies, and especially the wall imaging CT has a special role in increasing the conspicuity of the non-calcified gallstones by using two different images. The MR is again very important, especially in cases with suspected choledocholitis, Mersey syndrome, and acute cholecystitis with equivocal ultrasound findings. And also, it has a special role to differentiate gallbladder malignancy from xanthogranulomatous cholecystitis and adenomyosis. We'll just discuss some of the important imaging differentiating features. Then Hughes scan or hepatobiliary nuclear scintigraphy is especially helpful for detecting the acute cholecystitis because it helps to show the functional gallbladder obstruction. Now, first let us discuss some of the gallbladder pathologies which we can categorize in congenital, inflammatory, and neoplastic etiologies. The congenital gallbladder diseases, first of all, the duplication of gallbladder, it's an incidental observation in which there is a longitudinal septum dividing the gallbladder cavity, and each of the cavity drains through its own cystic duct. Usually it is not symptomatic, but sometimes it may lead to cholecystitis. The Phrygian cap of gallbladder is the most common anomaly, and the importance is that it should not be confused with adenomyosis or gallbladder septum. Agenesis of gallbladder is a relatively uncommon congenital abnormality, and it predisposes to stone formation whenever it is there. Now, the most common benign inflammatory disease of gallbladder is the calculous cholecystitis. It may present in acute condition when there is an obstruction of gallbladder neck or cystic duct. On imaging, we can see gallstones, which are usually hyperintense on both T1 and T2, but when there are pigment stones, they are bright on T1 and dark on T2. There may be gallbladder wall thickening, which is more than 3 mm in thickness, pericholecystic inflammation, thickened bile, which is suggested by increased echoes and ultrasound, and there is an indistinct interface between the gallbladder wall and the liver capsule. The acute cholecystitis may complicate further in emphysematous cholecystitis when there is a vascular compromise of the cystic artery, which leads to development of the gas-forming organism. Sometimes these empyema formation, like we can see in these images, the wall is quite thickened, there is a lot of pericholecystic inflammation, and there is a diffusion restriction in the wall as well as the contents of the gallbladder. So this reflects that there are exudative contents in the gallbladder lumen. Sometimes there may be gangrenous cholecystitis with formation of interluminal membranes and irregular intermittently perforated gallbladder wall. And in chronic conditions, the gallbladder may be contracted with decreased ejection fraction. Adenomyosis is a condition when there is a hyperplastic cholestasis. It may present in a fundal, segmental, or diffuse generalized fashion. The fundal pattern is the most common, but the segmental pattern is the most sensitive because it leads to higher frequency of gallbladder malignancies. On imaging, one can see neural thickening, focal sessile mass, and fluid-filled intramural diverticule, giving rise to a pearl necklace appearance. And in annular type, there will be hourglass configuration of the gallbladder. So, a lot of times we can see this hourglass configuration in the background of malignancy of the gallbladder. Now, xanthogranulomatous cholecystitis is an important entity, and the main importance is that it closely mimics CAGB. So, in this, there will be focal or diffuse destructive inflammation of gallbladder. Typically, this is seen in elderly women. Pathologically, there is intramural extravasation of bile from superficial mucosal ulcerations, which are usually caused because of presence of stones in the gallbladder lumen. So, on imaging, we usually see the stones. There is a irregularly thickened gallbladder wall, and there are these characteristic xanthogranulomas in the wall, which are hypertenuating on CT, like seen in this CT image, and on MR, they are bright on T2 and dark on T1. The important clues to differentiate it from gallbladder cancer are seen with xanthogranulomas, and also the mucosal lining is patent and continuous in xanthogranulomatous disease rather than CAGB. Now, gallbladder cancer is the most common and the worst kind of hepatobiliary malignancy. It is relatively common, unfortunately, in our country, and the predisposing factors are gallstones, porcelain gallbladder, and abnormally long pancreaticobiliary junction. There are various kinds of imaging patterns. It may present as irregular focal or diffuse wall thickening, intralineal polypoidal mass, or a mass which completely replaces the gallbladder. And whenever we find a gallbladder wall thickening more than 1 centimeter, then it is suspicious for a malignancy, and accordingly the workup should be done. ESFME may be done if there is a strong clinical suspicion. Also, in gallbladder neck cancers, it is very important to differentiate it from perihilar cholangiocarcinoma, like what Sir just demonstrated, that in hilar cholangiocarcinoma, one can be very adventurous while doing surgery. One can do hepatectomy on one side and arterial reconstruction on the other side. While in cases of gallbladder neck malignancy, these procedures are usually avoided because of their poor prognosis. Sometimes the sludge may exactly mimic cancer, especially in ultrasounds. Like in this case, which we saw just few days back, there was a polypoidal sludge ball inside the gallbladder, which mimicked cancer on ultrasound, although there was no vascularity. So this patient underwent the MRI. Even on plain MRI images, we can see the signal of the intravenous sludge is much different than a soft tissue signal. So even on plain MRI, we can say that this is a sludge rather than a malignancy. And if the patient can have contrast, then it further increases the conspicuity of the enhancement pattern of the lesion. Now, uncommonly, there may be IgG4 disease in gallbladder also. It may occur in a diffuse or focal form. The focal form is very difficult to differentiate from malignancy, and usually the diagnosis is made in retrospection only. Like in this case, it was thought of as a CAGB and the patient underwent a radical cholecystectomy, but ultimately it came out as IgG4 related disease on histopath. In a diffuse pattern, the clues are continuity of the mucosal layer and homogeneous contrast enhancement in IgG4 disease. So in this case, this is a post-surgical specimen in which the entire specimen was laden with plasma cells. So after gallbladder, let us discuss some of the biliary system diseases, again categorizing congenital, benign, and malignant lesions. We are all very familiar with this Todani classification of cholebrocal cells, so let us just see some cases. So this was a young child presenting with abdominal mass, and on imaging we can see there is a large cystic mass filling almost the entire abdominal cavity, and there is significant dilatation of the common bile duct, and we can see the continuity of the common bile duct with the cystic mass. So this was a saccular dilatation of the CVD and type 1A kind of cholebrocal cyst according to the Todani classification. This is type 1C cholebrocal cyst when there is a fusiform dilatation of the entire common bile duct, and because of bile stasis, it is common to see sludge and calculi in these dilated ducts. This is a type 4A cholebrocal cyst in which there is a multifocal dilatation of the intrahepatic and the extrahepatic bile ducts. And this is a type 5 cholebrocal cyst or Caroline's disease, and the important imaging feature in these kind of cases is central dot sign, which is because of the portable radical in between the dilated ducts. Another important congenital disease of biliary system is biliary hematoma or von Webber complexes. So although they are by themselves incidental and usually do not cause any symptoms, but it is important to recognize because they are usually associated with fibrosis of the liver. So and also whenever there are these biliary hematomas, there is more association with polycystic kidney or liver disease. Now, choledocholithiasis is the most common bile duct abnormality, and US scores over imaging in choledocholithiasis, especially when the calcula is small, less than 3 millimeter in size, then MRCP may be false negative. Still, MRCP is the first line investigation because of its non-invasive nature, but EUS should be performed when it is negative and there is a high pretest probability of a choledocholithiasis, and there is no explanation of the delayed LFTs. Also on MRCP, it's very important to see the axial T2-weighted images besides the projectional MRCP images, because in the projectional images there may be partial volume averaging and the tiny stones may not be seen on the single shot MRCP images. The extrinsic compression of bile ducts may be seen in cases of extrahepatic portal vein obstruction when the prominent epicholedochal and paracholedochal venous plexus collaterals, they dilate and indent on the CBD causing a scalloped margin, and sometimes there may be upstream biliary dilatation because along with compression there is also fibrosis of the duct wall. So all these pathological features lead to upstream biliary dilatation, and we can see this portal biliopathy. Also, another common reason for extrinsic compression of bile duct is Nereide syndrome, in which there is a calculus infected in the neck of gallbladder or the cystic duct, which is impinging on the common hepatic duct, and there may be upstream biliary dilatation. Again, the severity of this disease can vary from just indentation to fistulation in severe cases, and there may be fistula formation between the gallbladder and the common hepatic duct or with the adjacent bowel. In cases of ulnar pancreas, there is an accessory pancreatic duct along with the accessory pancreatic tissue, which encircles the second part of the duodenum and the lower end of common bile duct, causing obstruction and upstream biliary dilatation. Next, coming to the benign biliary strictures, these are classically short segment strictures with regular margin and symmetric narrowing, and causes may be post-surgical, post-liver transplantation, post-cholangitis, or inflammation from choledocholithiasis. So like in this case, we can see there is a post-cholecystectomy stricture, abrupt cutoff in the region of common hepatic duct, a very short segment, smooth stricture with moderate upstream biliary dilatation, and there is no associated soft tissue on corresponding plane images, T2 and T1 weighted images. This is a case of post-transplant anastomotic biliary stricture in which there is upstream dilatation of right anterior and posterior sectoral ducts. This is a non-anastomotic biliary stricture after liver transplantation in a child because of compromise to the hepatic artery, which is the main blood supply to the bile duct. So whenever there is arterial compromise, there is a risk for non-anastomotic stricture. Now, primary extrusion cholangitis is another disease, important disease, which is characterized by multifocal intrahepatic bile duct strictures, alternating with normal caliber ducts, giving rise to beaded appearance. And in very severe cases, this is a quite a severe case of PSC, in which even the beaded appearance is lost, and there is this irregular dilatation of the entire biliary system. Recurrent pyogenic cholangitis, on the other hand, is more associated with parasitic infestation, nutrition deficiency, and lower socioeconomic status. It is more prevalent in the northern part of country and the Southeast Asian countries. So in this, we can see multiple irregular strictures within the intrahepatic bile ducts, bile lakes, and pigmented stones which are classically bright on T1 and dark on T2. So this is a diagnosis which is confirmatory on MRCP. Sometimes IgG4 related disease also affects the common bile duct, and when it does, it usually affects the intrapancreatic part of CBD, because this is a part of CBD which traverses through the diseased pancreas. So there may be stigmata of associated autoimmune pancreatitis. In this case, it was a chronic disease, so we can see atrophy of the pancreas. In the end, let us discuss some of the biliary neoplasm. The benign neoplasm include biliary cystadenoma, classically seen in the middle-aged women, and left lobe, especially segment 4, is the preferred site. Now, this is although a benign lesion, but it is very difficult to differentiate between a benign and a malignant biliary cystadenoma, unless there is a neural nodule or thick septa or thick calcification. So, usually it is recommended to accept this kind of lesion. The cholangiocarcinoma may be intrahepatic or extrahepatic. Intrahepatic cholangiocarcinoma is characterized by a ring-like enhancement in the initial phase, which progressively fill in within the lesion, and in later phases there may be actually halo in the periphery. There is a intrahepatic biliary radical dilatation, and when the tumor is peripheral, there may be capsular attraction. The extrahepatic cholangiocarcinoma presents as malignant biliary stricture, and the malignant features of a biliary stricture are irregular wall thickening with long segment involvement, urinary irregularity, and hyperenhancement. So, if you compare this case with the earlier case of benign biliary stricture, we can see the segment involved here is quite long and irregular. We are all familiar with this Bismuth classification, which helps us in delineating the extent of primary and secondary biliary confluence involvement. But as discussed by Dr. Gupta, it is very important to assess the vessel infiltration, because that is the ultimate thing which helps in pre-surgical planning. And even when vessels are infiltrated on one side and the bile duct is also infiltrated on the same side, surgery may be done. But if it is a contralateral vessel and bile duct infiltration, then it becomes very tricky. And even if male portal is infiltrated for less than 2 centimeter length, reconstruction can be done by using graft. Also, one should note presence or absence of any lobar atrophy and spread to the nodal groups, and which nodal groups are affected, because the regional nodes do not make the disease unresectable. If it is going to the distal nodes, then it becomes unresectable. So CT is the modality of choice for evaluating a patient with hilar cholangiocarcinoma, because it can nicely depict the infiltration of vessels as well as bile ducts. So basically, we need to have a patient-centric approach, and it's very important to have all the clinical inputs, the history of the disease, correlation with liver function tests, and there should be problem-solving attitude. Thank you.
Ma'am, for a very exhaustive discussion. We'll be taking the questions at the end of the session. Call Dr. and gallbladder and malignant malignancies.
Good afternoon, everybody. I thank Dr. Vikas for organizing. So today we'll be discussing on role of ES in bile duct and GB malignancies. To make my talk simple, I have divided this in 3 areas. First is bile duct, distal and proximal bile duct. Other is gallbladder, and third is ampulla. So let's begin with a case. Most common scenario when face colon will be an ES. So similar case, 55-year-old male presented with obstructive jaundice, no pancreatitis, the abdomen shows multiple GB stones, dilated CBD and RHBR, no calculi in bile duct. So what are the differential diagnoses at this stage? First is CBD calculi, not visualized on USG abdomen, or a passed up stone, and third is lower CBD mass, which is again not visualized. So we do an MRCP. MRCP suggests distal CBD stricture, but again no mass. So what do we do next? Either we think it is a passed up stone with inflammatory stricture, we wait. Other possibility is that if we have high suspicion of malignancy, we evaluate further. So what are the modalities for diagnosis of such kind of stricture? First is ERCP brushings and biopsy. Second is endoscopic ultrasound, interductal US, and cholangioscopy. So ERCP brushings are a low sensitivity, ranging from 27 to 56%. The reason is because most of these tumors are desmoplastic, and submucosal tumors may not be picked up on ERCP brushings. And they are often negative for extensive tumors like strictures because of pancreatic cancer, gallbladder cancer, metastatic lymph nodes. So ERCP brushing sensitivity is very low. Other is direct endoscopic biopsies during ERCP. The sensitivity is slightly higher, ranging from 44 to 89%. Cholangioscopy is the most promising method for biliary sampling, but mind well, my message is not that you do cholangioscopy for all biliary strictures. It is important for proximal stricture, which we will understand in my further slides. So the sensitivity of cholangioscopy is up to 90%. ES It helps to visualize the entire CBD from papilla to hilum. Also helps in diagnosis of bile duct strictures in neoplasia and later tumor staging. So in this image, by a linear ES, we are able to find a hypoechoic, well-defined area, which is a mass lesion, obstructing the distal CBD. Video, here we can see dilated CBD with an intra-CBD stent, which is often placed before patient reaches us. As this mass is easily seen through D1, we can do an ES FNA or FNA-B by 19 days needle. And this is a short procedure, 5 to 10 minutes, which yields good results. So there was a study analysis of 20 studies involving approximately 950 patients. ES FNA had a pooled sensitivity and specificity from 80 and 97% respectively for diagnosing malignant biliary strictures. When we talk about proximal biliary stricture, sensitivity gets to 25, but it may range from 25 to 89%. Various studies they show sensitivity of ES FNA for diagnosing malignancy in proximal bile duct strictures from 25 to 89%. The reason is because they are often small, diffusely infiltrating, and localization may be difficult because of limited field of examination during ES. There was a study by Lee, which is published in Gut Liver 2015, that forward view echo endoscope, which again is not easily available, it helps in better visualization of hilum. So if you have a forward view echo endoscope in a unit, you can always use it for hilar stricture biopsy and FNA. Again, cholangioscopy has a definitive diagnosis in 77% of patients when ES FNA is inconclusive. So what we do is, in our unit, we never do directly for cholangioscopy. If there is a proximal stricture, we always try to look at it by hilum, or the hilum, and we do FNA if there are no intervening structures like gallbladder or liver. So this is a video which we performed just few days back. Here we can see a hilar mass lesion within the CBD. Hilum. So this is the mass lesion at the hilum, round, heterogeneous in nature, slightly hyperechoic, proximal dilatation. But unfortunately, in this case, there was an intervening gallbladder, so we could not do an FNA, but we have done this many times that from hilar mass we have taken biopsy and we have got encouraging results. So the message is that though you have ES at your center, it is good for bile duct strictures which are distal, but for proximal strictures, we should not jump directly to cholangioscopy because it is costly and may not be accessible everywhere. Again, issues of biliary stents. Many times at the tertiary care center, these patients are stented. So what does stent do? It often impairs ES imaging because of the sludge and artifact. In such cases, you can always remove the stent prior to FNA and then re-stent it post-FNA. Presence of stent can also facilitate detection of a biliary mass if this is taken positively. Other thing is that you can remove this stent when there is no mass but only a stricture for better visualization. But if the mass is large enough and if it's stented, we did not remove it. So my recommendation is for distal biliary strictures, ES FNA is better than cholangioscopy. For proximal biliary stricture, if you cannot do FNA by the hilum because of limited visualization, then you go for cholangioscopy. Now for all practical purposes, staging is for resectability. Staging accuracy for ES is very less, it is just 54%. So conventional cross-sectional imaging such as MRI, CT is good enough to stage such kind of lesions. So ES has a limited role in staging stricture and malignancy. Otherwise, how do we utilize ES? in bile duct malignancy treatment, that is by colorectal hepaticogastrostomy and by endoscopy, but I won't go much into detail because in morning already this part has been covered. So next we come to gallbladder. We all know that gallbladder malignancies have a dismal prognosis, and hence it is very important that we identify all polyps, either they are malignant, non-malignant. So gallbladder polyps are of two types. First is cholesterol polyp. It has no malignant potential. Surgical intervention is not required unless the patient is symptomatic. Another is adenomatous polyp. They usually follow the adenoma carcinoma sequence, and hence, if diagnosed, should be resected. So how do we diagnose a GB polyp? It is most commonly done by transabdominal ultrasound. Those polyps which are more than 10 mm, sessile, irregular contour, hypoechoic, they need cholecystectomy irrespective of symptoms. But the sensitivity for diagnosing GB polyps by transabdominal ultrasound is only 50%. And in a study, it was mentioned and proved that 19 to 29% of patients who have polyps of 5 to 10 mm, which we do not recommend cholecystectomy, they had adenomas and few had malignancies. So it is always important that whenever you find a polyp, you should evaluate it further. So let us see how does GB looks on EUS. On EUS, GB is seen as two layers wall. The outer is hyperechoic, which is formed by subserosa, fatty layer, and serosa. And the inner is hypoechoic, which is mucosa and muscularis propria. So gallbladder polyp, they are fixed structures protruding within GB lumen. They do not have any acoustic shadow. Why to suspect neoplasia in gallbladder polyp is when the size is more than 10, that is 10 to 15 mm, and it is homogeneous in nature. So this is a video of a gallbladder polyp. On ES, we can see an irregular protruding lesion. Layers are well maintained, and it is highly vascular in nature. And its size is about 10 mm. So what we do in this case? We likely go for cholecystectomy. Most of the cases we don't need FNA also to treat this polyp because it all ES, it is homogeneous in nature, highly vascular, so more likely to be malignant or malignant potential. Next is contrast enhanced harmonic. Again, availability is an issue. In this, specificity and sensitivity as compared to conventional ES is slightly higher. So my recommendations for gallbladder polyps are that is useful for polyps not meeting dissection criteria to 5 to 10 mm to know either there is adenoma or not, hypoechoic or not. Suspected malignant polyp who are unable or unwilling to go for surgery. And those polyps whom we are following on abdominal ultrasound, they have change in characteristics on follow, you can go for EUS diagnosis. So next is GB mass. Most important finding on GB on EUS for GB mass is that the integrity of both the layers is lost. Now this can be seen in adenomyomatosis, also in xanthogranulomatous cholecystitis. So FNA of gallbladder masses is accurate in diagnosing primary and metastatic malignant tumors. Sensitivity range from 80 to 100%. It helps to differentiate from adenomyomatosis and xanthogranulomatous cholecystitis, but it has a limited negative predictive value. Here is a table of various studies. The sensitivity and specificity for diagnosing gallbladder mass as a malignant is good enough. There was a study by Hijoka in which they affiliated 15 patients, and out of 15, 5 had xanthogranulomatous cholecystitis. So always when you have such patient, you can do an FNA and differentiate between other causes of GB well theory. My recommendations for GB mass and GB polyps that EUS FNA has higher sensitivity specificity, but negative predictive value of FNA surgery, FNA is less. So surgery should be pursued in all patients with suspicious GB lesions despite a negative cytology. Last is ampullary tumors. So ampullary tumors, how does EUS help? Many a times we see a bulging papilla, bulging ampulla, we do a biopsy and it is negative. So when those lesions were protruding ampulla without mucosal abnormalities, for those lesions in whom negative endoscopic biopsy is done, you can go ahead with EUS-FNA for diagnosis of such lesions. The sensitivity and specificity are 93 and 75% respectively for such kind of lesions. So for staging, especially such small tumors are not visible on CT and MRI. So this can be, EUS can help in staging of such lesions. So for those lesions who are T1A, that means that the lesion is only localized to the sphincter of Oddi, endoscopic ampulectomy can be attempted. For those who are in the submucosa, that is T1B, endoscopic ampulectomy is not recommended because there is 30% chance of nodal metastasis in such lesions. So this is a flow chart of complete tumors. Do an EUS if endoscopic biopsy is negative. If EUS is normal, no labs are normal, patient is asymptomatic, don't do anything. If EUS is showing a lesion, go for FNA. If FNA is negative, go for IDUS. So to summarize my talk, EUS increases diagnostic value for brush negative bile duct lesion, distal more than proximal. High resolution with EUS helps to diagnose neoplastic polyps irrespective of size. Loss of GB well integrity and EUS should suspect malignant for the evaluation. Submucosal and biopsy negative ampullary lesion, EUS has a definitive role in diagnosis and selecting patients for ampulectomy. Thank you. Presentation. Section of the first one, I think that is Siddharth Srivastava. I would like to welcome Dr. Siddharth Srivastava, who is Associate Professor of Medicine, JVP Hospital. Welcome, Siddharth. Lecture, basic lecture. Dr. Siddharth, please. Sorry for the initial technical glitch. Thanks the organizers for giving me opportunity to talk about very basic thing, the liver and bile duct anatomy. After so much of discussion about the utility of EUS, I think those who are beginners will understand that it is understanding the basic anatomy is of paramount importance. So I will look at first the anatomy of the liver. Secondly, then we look at the biliopancreatic, how do we evaluate them, and then we go with the anatomy of the biliopancreatic also. Okay, so for anatomy of the liver, the moment we enter from the GE junction into the stomach, we rotate our scope to look for the left lobe of the liver. As we all know that EUS is not used basically for evaluation of the liver initially, and even today I still believe that transabdominal ultrasound does most of the job, except for a few things which we will be discussing in between. And we all know about the Cronix classification. It is divided into 8 different segments, derived from S1 to S8. Similarly, the continuing line basically divides it into right and the left lobe. In the left lobe, we have both medial and lateral segments. If you look at how we separate the medial and lateral segments, it is by the falciform ligament. Similarly, for the right lobe, we have anterior and the posterior segments, which are basically separated by right hepatic veins. The basic landmarks are the petrivene, hepatic veins, the IVC, the ligamentum teres, venosum, the gallbladder, and the right kidney. For the left lobe, we have to understand that the left hepatic vein basically separates segment 2 from segment 3, and middle hepatic separates segment 4 from the rest of the right-sided segments. For the right lobe, right hepatic vein basically separates the anterior and the posterior segments, which is S5, S8 is the anterior one, and S6, 7 is basically the posterior one.
as we enter into the stomach from the G junction, and we turn the scope more counterclockwise, you will start seeing the left lobe of the liver. The area which is closest to you, to the probe, is usually the segment 2, and in between is the middle hepatic vein, and the area which is away from your probe is usually the segment 3. Now, how to identify the ligamentum venosum and ligamentum pubis? For this, you have to start rotating the scope into the clockwise direction till you find the this portal. The umbilical portion of the portal from there arises a thick white colored structure which is going to upwards towards the probe. This actually is the ligamentum venosus, and similarly the distal part of the umbilical portion gives rise to, there is the attachment of ligamentum pubis. Why it is important to know? Because once you have identified ligamentum venosus, then just above that area is the segment 1 of the liver, beyond that is the segment 4 of the liver. Once you are counterclockwise rotating, at this point, you will also be seeing the middle hepatic vein. Middle hepatic vein is important because most of the portal hypertension studies, where we want to do HUPG, middle hepatic vein is the one which is being targeted. And this separates segment 4 from segment 8, which is a posterior right segment. So segment 5 is relatively easy because as we advance the scope towards the body of the stomach, you will start seeing the gallbladder. Once you start seeing the gallbladder, the area below the gallbladder, which is seen part of the liver, it is a segment 5. Looking at the most difficult ones, the segment 5 and segment 6, 7, they are very most difficult to identify. For this, we have to go into the duodenal bulb. Scope is in long loop, in J type of a position, from where you identify first the portal vein. From portal vein, you start counterclockwise rotation till it reaches to the liver hilum. Identify the right and left branches of the portal vein from there. And the upper part of right portal branch basically gives the right anterior branch, and that is the hallmark for the segment 5. And area away from that area, which is seen from the duodenal bulb, is usually segment 8. 6 and 7 are slightly difficult. 6 is easier to identify because as you are in duodenal bulb and you try to rotate yourself clockwise, you start moving towards the D1-D2 junction and you start seeing the right kidney. The moment you see the right kidney, area adjoining to that is segment 6 of the liver. And if you rotate it completely counterclockwise or clockwise rotation gives you an idea of where the gallbladder is, the area just beneath the gallbladder in B1 is usually the segment 4. So this makes anatomy which is visible by EUS for all the segments of the liver. Segment 2 and 3 are the most important because for those who are planning to do therapeutic EUS, we try to puncture segment 3 that. So segment 2 and 3 that is most important to identify in EUS as far as liver segments are concerned. For biliary anatomy, normally, as everyone knows that these are the 3 prime stations which are looked at, and the position of the scope where it is looking at is shown in this cartoon. The first position is the duodenal bulb, where if you look at the scope position, it is looking at the common hepatic duct, the gallbladder, and the portal veins in an upward direction. Second position which most of us use is the distal duodenum. Here, the scope is very close to the papilla, and from here we start discerning about the common bile duct and subsequently the liver hilum. And the third station, which I think is the most important and is the evaluation usually begins from the cardia. So cardia is the most important station on which all of us should understand and remember that. I will start with the duodenal bulb. How in duodenal bulb, you have to first identify where the portal vein is. And most of the time, the moment you enter from B1 into the pylorus, your scope lands in the duodenal bulb, and the first structure which is seen is usually the portal vein. Bile duct usually just lies in front of the portal vein. From here, if we rotate clockwise, then we are going towards the lower end of the CBD. moving towards the papilla, and if we rotate counterclockwise, we are going towards the upper end, and we can go up to the lower hilum. Well, we can also be evaluated from here, and lower hilum to be evaluated for completion of the station. So this is the picture which I borrowed from Dr. Miller. This shows lower end. This is the portal vein. This is the hepatic bile duct or the common hepatic duct, and in between is the hepatic artery. This is one color of the similar thing, where you can see the gallbladder, you can see the cystic duct, you can see the bile duct, portal vein, and hepatic artery. So this configuration is important. I will just show a bit of lower of the bile duct which you can use. So here you can see this structure is basically the CBD, and just beneath this at the lower end, usually the pancreatic duct is, and if you can appreciate, this is the diurnal airway, and this is the diurnal color, and once you identify these structures at the lower end, your evaluation of the lower end is usually complete. From cardia, two methods are used. One is that you go straight into the cardia, pass the T junction, locate the aorta. From aorta, you take the celiac trunk. For beginner, as a beginner, I thought it was slightly difficult for me. So we go right up to the antrum. From there, we turn right, move the scope up and pull it back. Pull back till you see a vascular structure. Once you have identified a vascular structure, start tracing that particular part. And once you identify the total vein here, you can identify the common bile duct here also. Here you have to remember that in duodenal belt, common bile duct was in front of the portal vein. Here it lies behind the portal vein. So it is slightly difficult to understand the anatomy at this level. So this is from the cardia, these are the structures which are seen. The portal vein you can see, just beneath that is a common hepatic duct, and this is the liver. And if this is the anatomy which was shown just previously for the duodenal belt. So you can differentiate between the two, but here the portal vein is behind, here the portal vein is in front. Another important landmark for the gallbladder neck is usually the portal vein, where the portal vein is becoming third. That area is basically the neck of the gallbladder. This will show you. So what I am doing that this is the antrum. If you can see the endoscopic view, just start pulling from here to look for any vascular identifiable vascular structure. If you can see, if you are unable to see, don't worry, go right up to the kidney. It is very easy to identify the black and white structure. Just in front of the kidney is usually the splenic vein, and splenic vein can be traced right up to the hilum, and at the formation of the portal vein by rotating it to the counterclockwise. And if you go clockwise, you can trace the whole of the pancreas. So coming to the last station, which is the papilla and distal duodenum. Here the landmark structure is the aorta. The first thing you have to identify is the aorta. The moment you have identified the aorta, things are pretty simple. The area in front of that is usually the pancreas. If you place that area towards the papilla, you will find the CBD, which is a thick structure. If you instead of going towards the clockwise, turn counterclockwise, you will see the upper part of the CBD going right up to the hilum, and from here you can also evaluate the gallbladder. So this is the station. This is the main landmark structure, aorta, and in front of this is the pancreatic head, the inferior part, and the ansemic process. So this I will just show a very short video because it's a pretty longish video. You can identify the aorta out here, and once you identify the aorta, the area here is the pancreatic head region, and in the pancreatic head region, you have to identify the upper end is the CBD here. This is the pancreatic duct here. In this particular case, there is a small tumor, but this is how you delineate the anatomy at the distal duodenum. This is just one picture which I wanted to show. This is a painful collaterals which are shown, especially in the front of the total venous obstruction. This is the case where you should not put in a needle because it leads to bleeding every time. So to summarize, EUS is one of the best tools for the hepatic biliary region. We are the closest to the CVD by any other methods, and we can do sampling very easily from here. Detailed anatomy can very well be delineated. Small lesions which are missed by other modalities can usually be picked up, and understanding basic anatomy is essential for starting an EUS. Thank you.
The session is open for any questions. I will start by asking a very basic question which day-to-day we have. This question is towards Dr. Harwani and Dr. Shivas Gupta, who is there. Especially in cholangiocarcinoma, the most important is pre-operative diagnosis. How much you want and what is the current status? Do you require a pre-operative diagnosis before operating a cholangiocarcinoma? The question is open.
I think I did touch on that in my presentation. And I said that, you know, in periampullary carcinoma, would you want the exact diagnosis before proceeding? No, I'm first asking counter question. In periampullary carcinoma, would you want, is it essential to have a tissue diagnosis prior to proceeding? If the philosophy there is that you have to have a tissue diagnosis, then yes, in cholangiocarcinoma also you should have a tissue diagnosis. But you must remember that liver surgery is actually become very safe. Results of cholangiocarcinoma dissection are actually far better than dissection for pancreatic lesion, provided the lymph nodes are free. Therefore, you would deny many patients chance of curative surgery by trying to get for preoperative diagnosis. And that's a point I made in my presentation. But yes, the conventional answer is that, you know, it's a very morbid surgery and therefore you must have a preoperative diagnosis. Some cases are tuberculosis. So you would therefore, you know, surgery, preoperative diagnosis would save them from mutilating. So we have both the viewpoints are there.
So you will prefer a preoperative diagnosis?
I would not. I would just look at whether the vessels are free or not. And if the lymph nodes are from cholangitis or lymph nodes are from disease, that's the only important thing I would like.
Dr. Harwani, just there.
For periampullary, we usually don't, but for cholangio, we take that.
You take a biopsy. And second question is that what level of jaundice you like I know I'm stepping on a slippery, but I think we have balance of surgery that we should have. So, what is there any level of jaundice? All patients require after a level you want the pre-operative biliary stent in cholangio?
So I'll go first again. We do not insist on biliary decompression, but by the time many of them come to us, they've had biliary decompression done. I think as far as literature is concerned, experience of others are concerned, for left hepatectomy, clearly there is no need for biliary decompression. If you're doing a left hepatectomy, you can go ahead and safely do it. For right hepatectomy, yes, if the biliary is more than 5, and you know you have other issues of remnant and all, then of course you would want biliary decompression. We as a group have tended to avoid left-right hepatectomy by quite often the resectability is not from the cholangiocarcinoma not going into the liver. The reason is the vascular involvement is such that you're forced to do a right hepatectomy. That you can correct by reconstruction of the artery. So we have tended to do much less biliary decompression than other groups. But the Japanese who have sort of been very aggressive in this, they've said that you do ipsilateral drainage, the side that you want to preserve, you do portal vein embolization and then go ahead with resection. But whenever we try to do this here, I don't know what is the experience of others, the patient has never reached the surgery stage.
Okay, let's take a comment on
I don't have my experience because
This is generally looked after by surgeons and they do a protein embolization sites which have to be removed. I just had a quick comment. So I think a lot of these patients end up having jaundice for extended period of time. They end up developing sort of post-obstructive cirrhosis. And I think the issue with decompression is your surgical take when the patient has developed cirrhosis in such patients. Yeah.
I think, yes, there's a group of patients we worry about because, alcoholic liver disease is very common. So that's where we would worry about. But long-standing malignant obstruction leading to cirrhosis, we've seen a few cases from neuroendocrine tumors, which is slow growing, lower and lower endocrine tumors, and they have resulted because they've been there for a long time. That's the group where we face this problem, where you have sort of slow growing tumor blips. But malignant Klatskin tumors are not a good thing to have. You do not, last that long enough to go into cirrhosis.
I have one answer to this. Any mechanism function that more than 6 months, people can have chance of birth in 60 minutes. Part of that, I don't think any patient will be doing cirrhosis. I have to take it off in the feedback. That is very unpleasant task for me. Very unpleasant task for me. That we see a long it may not be ulcerated. The question is, no. This could be the adenoma. This could be an adenocarcinoma. Adenoma, it should suffice to the epilepsy. But if it's an adenocarcinoma, then you have to go and do a visit. So the first area of the house is, do we go ahead and do an epilepsy? What have you do the lesion? Yes.
Can you change the mic, please?
Ulcerated lesion. See, this situation over here is not submucosal or ulcerated. Ulcerated, fine, we won't touch it. But when you do an epileptomy, you can provide orifice. And we are doing an epileptomy for these patients. What happens is on the histopathology, not that small the surrounding areas are free of carcinoma, the surrounding areas. But the tumor has gone in that particular portion into the muscularis propria. Now that has not gone into the walls of the radiculum or into the bile duct or into the pancreatic duct. So on what basis are you going to label saying that this has gone into the submucosa? Well, it has gone through the submucosa into the muscularis propria. But it is into a total orifice which is hardly about 3 or 4 millimeters. That's where the opinion of the surgeon are aware that is not what do we do?
I think I'll answer that.
Which is, look, ampulectomy is both diagnostic as well as therapeutic. So that specimen has to go for histology. If you have malignancy in it, it goes for Whipple's. If it's adenoma and the margins are free, then you follow him up. As simple as that. Any patient who has an ambulatory or an obstructive jaundice, it is almost always malignant, don't touch it, send them to surgeons.
Thank you. I think we had a good discussion and the session is on.
Thank you so much, everyone. Now we'll head for lunch. Lunch has been organized at 2 venues. I require your attention for just 10 seconds more, please. Outside the auditorium, as well as on the service floor in the East Block Doctor's Lounge. We will meet back sharp at 2:45 for the next session. Thank you so much.
So, by and large, when somebody
Sure. Hello. Hello. Sure. Sure. Hello. Sure. 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 Sure.
ना मतलब जो मैं एक बार पकड़ूंगा वही मैं
All right, welcome back, ladies and gentlemen. We are ready to start the next session, which will be a live demonstration. May I request the chair to kindly come on the stage, please. I invite Dr. Varun Mehta, if you were. Dr. Ramesh Garg, if you are around, kindly come on the stage, please. Dr. Rajiv Shandal. Thank you. Dr. Devesh Yadav. Dr. Ayush Chhilwa. And Dr. Suraj, if you are around, kindly come on the stage, please. Over to the live demo. Thank you.
So this just anesthetic the patient. So can't
The relative showed proliferative pattern with a television of 22. The imaging has showed a higher mass due to different separation, and there is a metastasis in the liver. I am suspect from the net and transfer to adenocarcinoma. So in summary, we have case of a malignant melanoma in the liver net. We have Dr. Flavin Graf, who will take this case and show the art of doing hepatic gastrostomy. So over to you.
It's not audible. Your voice not audible in the hall.
Yeah, good afternoon. So, are you able to listen?
Yes, we can see the pictures.
Okay. Okay. So, we have a 42-year male, and he is basically based on functioning of gallbladder iron loss. Along with that, he has got secondary to the liver. FNA has been done from the liver, and that is positive for malignancy. So, unresectable carcinoma gallbladder with islet block. So, we have reviewed the MRCT images, and the MRCT shows block at the confluence. The right anti-right posterior ducts are patent, uniting with each other. Segment 2 and segment 3 are uniting.
Right and left is the one that is blocked. So the confluence is blocked. So basically what we intend to do is a EUS guided hepatogastrophy. So here primarily we will be targeting the segment 3 duct. So on the screen right now, can you see the screen?
Yes.
Yeah, so on the screen right now, we are able to see the liver. And if you see, this is the segment 2, this is the segment 3 duct. So if I just rotate this, they will come together, and join here. So this is segment 2 and segment 3 are joining. So what I'll do, first, we need to be sure that we are not getting a trans-esophageal excess. And for that, I have seen that the G junction is around 42 centimeters. My scope as of now is around 46. So we are below the G junction. And then I'll apply Doppler just to be sure that there is no vessel in the path where my needle is supposed to go. So we have applied Doppler and the ducts are significantly dilated. Once again, segment 2 and 3, how to differentiate? Yeah, so I think you just heard in the lecture from Siddharth that to differentiate segment 2 and segment 3, we need to see the LHV, left hepatic vein. So if you see very cautiously, there is a vessel running here, which is the hepatic vein. So if I show you this, you can see the hepatic vein. Once you have seen the hepatic vein, this is segment 2, above is segment 2, below is segment 3. Is that okay? So this is the radial part, this is the caudal part. So I think we'll just go ahead with the procedure. And so first we need to be sure the duct, the segment we are puncturing. Along with that, I need a fluoro. Can we have the fluoro? The position of the scope. So that's very important. Whether the scope is positioned and your needle is going towards, it is towards the hilum. You want to go towards the hilum. So can we have the fluoro, please? Fluoro. No. So is the right leg, is this to the shoulder up? To the side here. So no, I need something there. So the shoulder up. So is the right leg उधर हुआ है? Flip करो जरा. हाँ. Yes. This side of the screen. So yes. Yeah. So can we just bring this down, fluoro, slightly down. Scope tip. With scope tip in place. Yes. Slightly up, slightly more up. So more here, like this. Because we'll need to see the duct going towards the hilum. So that should be okay. Fluoro. So this positioning is very, very important. You need to select the duct right. Otherwise, you will need to 90 degrees. You will need to change the puncture size if you have punctured say segment 2, or you think you are going some towards not towards the hilum. So then you will need to change the puncture size. So you should take some time to position the adequate duct. You are able to see the V3 segment, and then position your scope correctly. So correctly means right now my scope is towards the hilum. So So if you see very cautiously, we can see the liver secondary is also in place, and you can take an FNA also if you want. So this is the liver secondary. This lesion is the liver secondary, and you can easily take an FNA under US guidance.
Okay. So I'll apply Doppler. Doppler looks okay. Yes. Fluoro. So I need to have a dilated duct, and then I need to have at least 1 to 3 centimeters of the liver parenchyma to be in place. That's the duct I will choose. So right now, the duct that I'm going ahead with is this duct. So if you see this duct, this segment B3 duct, this is around 3 centimeters or so. There is no vascular area, vascular vessel here in this part. I think we are ready to go. So we'll puncture this. Let's see. So as in all FNA procedure, you need to take the sheet out, fix this, and then so here the problem that happens is that once you puncture, sometimes what can happen is the assistant, once he passes the wire, that goes towards the peripheral duct and not towards the hilum. So that is a real problem that can happen. So we are good to go, I guess. So we can see fluoro again once. So that's okay. And then so I just saw a vessel there. So not a vessel, that's okay. So I'm okay to go, and then we are in the duct. So now I'll ask my assistant to take out this fillet, aspirate bile, be sure that we are in a duct, not in a vessel. Then inject contrast to be sure of the anatomy, and then pass the wire. So we have aspirated bile. Are we getting bile? Okay, that's okay. So we just stop at it, inject contrast.
You can't have fluoro, give me the fluoro in this place.
Fluoro, please. Inject contrast. Yeah, please. Yeah. More, we need more contrast. We need more contrast. We need more contrast. That's perfect. You can stop at that because I don't want to specify the right duct. So the confluence is not patent. I don't think the contrast should go. But right now, as you are able to see, the contrast is limited to the left duct. You pass the guide wire. So here, as I mentioned, we want the wire to go up towards the hilum.
Doctor, what needle are you using here?
So we are using a 19 gauge FNA needle by Boston.
So what dilatation of this duct are you comfortable with?
Fluoro. It has to go up. That's what I was saying. Doing the peripheral duct. Hold on again. I'll just pull this back.
Doctor, any tips to prevent shearing of wire in this situation?
So I think it's all the expertise, the technician. I don't think there is any specific thing. You have a wire, obviously, an excess needle that is in place. Somehow we don't use that. Yeah, we can try it here because again, ultimately we'll have to change that with the. Okay, that's good. Excellent. Excellent. So just be there in place.
Can you focus on the fluoro image, please?
Put the one.
Zoom in on the fluoro image.
That's okay. That's okay. So I think now see it's a very, very important for the technician.
Can you make the fluoro image bigger, please?
Technician to do the job well.
So I'm just putting on the needle. Okay? Secure that wire. Secure that wire. Gradually.
A question, how much length of liver parenchyma traversing would you be comfortable with in terms of the length of the skin? 3 centimeters.
3 centimeters length of the liver parenchyma. Okay. So this is the first step that is critical, because sometimes what can happen is the wire repeatedly goes into the peripheral duct, and then you can't do anything about it, and then you have a difficult time there. The next important step is primarily the creation of the fistulous tract. For that, usually we use a 6-French cystotome, which I would say in more than 90% does the job. However, in 10% you may again struggle with cystotome that may not go, and in that case you have non-cautery modalities to take use of. So we'll just see what really happens, because these rare things happen during the conference only. Okay, so we will use a 6-French cystotome. Yes.
Yeah.
So for cystotome in hepatogastroscopy, usually we do endocut, similar to that of the ERCP. If we fail, we can choose to use a pure cut under setting of 4 and 100. Problem with that is the fear of bleed with a pure cut current. So whether that really is the case or not, I am not clear. What usually we do is we try with this endocut mode. If we fail or we are not, the cystotome doesn't go in, we try with a pure cut. So the technician is doing a brilliant job actually. So you see what happened actually is I was trying to focus on the technician job, and at that time what has happened is my scope is now a bit back. So this is not good. One should try to maintain the position of the scope, and I may really struggle to achieve that position again. So this is a real problem. Therefore, one should be focusing on his job alone rather than trying to see what other is doing. Okay, so we'll just try to see how the cystotome goes in. I'm not adjusting right now. When the cystotome is out, I'll try to adjust the position of the scope, which is now a bit backwards compared to the initial position I was in. Okay. Gaurav. Biometry fraction. Okay. So you can see my tip of the cystotome. Tip of the cystotome now at the stomach side of this fistulous tract, and then we try to go in. Please tension on the wire, please. And just seeing that the wire doesn't come out because we don't have a very good length of wire inside. So we just see whether this goes. So fortunately it has gone in, and then we'll just adjust it slightly. So this is a 6-French cystotome, and you can see this going inside. I'll just adjust the position, because what can go wrong is that your cystotome goes in easily, but the stent you struggle to deploy that stent. So what I've done is I have went inside with the cystotome. Position again is not an excellent one, but okay to do the job. And then I'm just trying to keep the wire in place, please, and sort of. Okay, and then I'm moving this cystotome out. I'll again pass it. So we need to make 2-3 movements so that we have a good track. Is that okay? Okay.
The reason I want to make a good practice, the delivery of the stent that I will be using is a 8.5 French. And what we are using here now is a 6 French cystoscope. So that's the reason I want a good excess. And the reason why I'm not doing further dilatation is twofold. One, I want to save up on the time a bit, and then I think that after doing this, the stent goes inside, usually without a problem. So let's see. So I have gone in once. Okay, I'm just trying to adjust the position, which is very important. So I'll just go again. I'm coming back. I'll again go. Come back again totally. Then read no. Wire taut, please. Wire taut.
Dr. Praveer, can I ask a question right now? Hello?
Yeah, let me just do this step.
Okay.
I think it's a bit important here that I create an adequate fissural tract. We can go ahead and do a CRE also if needed. Usually the problem is that it creates bile leak, some amount of bile leak, which usually is not worrying. Okay. So, we can actually, if this, after this also, if you want, we can use this 7 French Sohendra biliary dilator. So we can try that. Yeah. So we can give maybe 8.5. Laura? So usually I don't do a dilatation after this, but the position is such that what I'm anticipating is that with this position I'm struggling even after dilatation with cystoscope. I'm having some problem in not an easy flow movement of the cystoscope. That's the reason we will just dilate it one more step and then we can deploy the stent. So this is an additional step which, as I mentioned, usually I don't do. But here, as I mentioned, there's some resistance for this even after 2-3 passes. And that's the reason we'll take 2 more minutes to pass this dilator and only then deploy a stent. Because once the stent doesn't go, then again you'll have to repeat all these steps again. So that becomes the problem. Did any user using 8 French? Just ensure the wire is in place and the wire is a bit taut. No. Wire is not taut, please. Yes, that's okay. So wire is, ensure the wire is in place.
Can't see the person.
That's okay. So I think I'll just do one more movement and that should be fine. Why, please. Yes, that's okay. So I think right now the important thing is yes. Wire taut, please. Chloro. Sorry? That's okay, that's okay. I'm okay with it. Gaurav. एक बार मैं और कर रहा हूँ बस last time. Just keep the wire in place a bit on. That's it. Gaurav. This is okay. Gaurav. Okay, well, very good. Sorry.
Ravi, I think you are good to go. Ravi,
Yeah.
please go with the stent, I think.
Yes.
Otherwise, there will be bile leak if it be many times over, and that will cause some pain.
I think 2 or 3 times usually suffices. We have done around 3 times with 6 and then this was 8.5. Right now, what I thought that the end is in the scope, while it was at the level of Hyla. So we'll just deploy the stent. Right, please. Fluoro, please. Okay, we are ready with the stent. The stent that we are using is a Henaro stent. This is by MI Tech. This is a 10 centimeter long stent having 7 centimeter covered and 3 centimeter uncovered portion. The advantage here is that you have the distal flange, that is the flange towards the stomach, around 20 millimeter in diameter, and that's the reason it prevents migration of the stent, which, if happens, it's something that you can't do anything for. So now we are going ahead with a stent that is the last and the very crucial step. Fluoro, please. I just want to ensure that the position of the stent is okay. That's okay.
You happy with the wire?
Stop the fluoro, please. Okay. So we are all set for the deployment of the stent. Fluoro, please. Wire mid traction, please. Yeah. Wire won't come over here. Let me just be safe. Keep traction on the wire, please. So here the problem is, I would have wanted my wire to go towards the right side or go towards the bile duct, have a long segment of the wire inside, so that it becomes safe to do the procedure. However, this is what we could achieve here, and I think we'll try with this. Wire dot, please take it down. Fluoro. So my stent position is now at the level of close to the hilum, and that's okay to me. So what we'll do now is, Fluoro, please. So what has happened now? I'll try to deploy the distal end first. Open up the distal end, please. Please. Can we have a zoom in this image? Can we have an image bigger? Yeah, please. So can we just shift this so that just wait. Fluoro. Like this. Yeah. Yeah. Please open up slowly. Slowly. Can we see it opening up? Yes. Deploying. Just wait. Just show me this image, please. Freeze and show. I want to see whether this stent has opened up or not. So we are not seeing it clearly, possibly because the contrast that is in, that's not making the boundaries of the stent clear. Yeah, whole of the stent we are not able to appreciate properly. That's okay. Fluoro, please. Yeah, so now you can see the stent. Is the stent visible in the hall?
No, not
No,
very clear.
that's okay. So I think we are probably able to see the stent and that's okay to me. So we will go ahead with now with the endoscopic image. So endoscopic image, bigger. Yes. So now, yes, I don't know. Fluoro, please. Fluoro, yeah. So the stent is to me is positioned okay. What we'll do is now we have CO2 on. Okay. So now I'll see this position of the stent in the stomach. Okay. Something here, we'll just clean it. Can you use air, please? So can you see this? So we have some blood there, that's okay. It's just below the G junction. So I think because of the, please don't touch the scope. So there is something which is above that, and that's the reason we are struggling to visualize this adequately. So that's okay. So here in the endoscopic image, this is the distal part. This is the end of the stent, the yellow marker, and this stent right now is too much in. So what you want ideally is around 3 to 4 centimeters in the stomach. So what I'll do now, I'll just pull this stent back down to the scope. So we have consistently towards the G junction, but that's okay. We are below the G junction. Can it be a bit quieter? Okay. So now can you see the state? Okay. So now, Fluoro. Yes, we open up the stent now. Slowly, very slowly, please. Just wait. Just wait. So I just want to be sure that actually we have something. Can you flush this? Do this. Can we flush? Okay. Fluoro.
So clot is stuck to the stent. You can't see the stent properly.
Stent को
start हो गया.
Fluoro.
अंदर तो हो गया इंट्राहेपेटिक
Yeah, I got that. So I think we can do many things to open up the stent. I'm just trying to do what usually I do. And that's really difficult to do because there's something stuck to the scope there. I can't see much. So that's okay. So what we'll do, we'll just back down here. Yes. Yes. Okay. This is now better. That's okay. So we have the D junction and we can see the stent. Now my the proximal end is in this esophagus right now. And I'm just able to feebly see the part of the stent. Unfortunately, now I can see that. So you please go ahead and deploy. Please. Slowly. No rush, please. Nora, please. That's okay. Please. Slowly. Just wait. Nora, please. Okay. Deploy, please. Yes. Stop. Floro, please. Floro. Yes. Deploy, please. Yes. 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 Deploy. Okay. Floro. Actually some technical glitches here, but what I'll tell you is that normally I want a 3 centimeter segment here, which we are not having, but we have a bar access. I'll deploy a 7 DPT stent across it just to prevent migration. Though here you can see at least 1.5 centimeters, slowly. 1.5 centimeters is in the stomach. With a flared 20 millimeter diameter, this should be okay. But just to be very sure, I'll place a double pigtail, 7 French double pigtail stent so that we don't have any problem of. Okay. I think I'm just pulling it out because the anesthetist has advised me to do that. He needs to do suction and we can then deploy the stent. So if there is any questions, I can take up now. Please.
To start with, what diameter of the duct you are comfortable with?
Sorry?
When you are puncturing, what diameter of the duct you are comfortable with?
So diameter, at least you need to have around 5 millimeter diameter.
And does the direction of the stent in which it is going, like it was going cranially, it was positioned cranially when you started deploying, does it matter? Because then it
I didn't get that question, please.
when you deployed the stent,
Yes.
the proximal end or rather the distal end of the stent was positioned proximally, it was facing towards the head of the patient. So does it matter?
So I'm not able to understand it.
I'm just saying when it is positioned in the intrahepatic ducts,
Yes.
does the position of the stent, whether it is facing towards the hilum or it is moving facing upwards, does it matter?
No. So it doesn't matter. So you have this 3 centimeters of the stent which is uncovered.
Yeah.
If you deploy this stent, if it's going towards the hilum or just before that, it doesn't matter. It will do the job. It will drain the segment 2 and segment 3 down.
Especially in this case, because this very little stent which is there in the stomach,
Yes.
and most of it is facing cranially when it is there inside.
Yes.
So would it matter?
No, not at all.
Okay.
So as I mentioned, what you are keen is you want to drain the segment 2 and segment 3 ducts.
Yeah.
And that job will be done with the position in which the stent is right now. So you're able to get a complete drainage.
Hi, Dr. I had a question.
Yeah.
So what's your preferred patient position? I see the patient was prone.
Yes.
That's what you prefer every time you bring this?
So usually I do all my procedures in a semi-prone position, and that's just I'm used to do in this position rather than any specific reason for that.
Well, sir, Sandeep here.
Yes.
This dilatation of the tract, like after puncturing its cystotome, so we can use this hurricane balloon also instead of repeatedly doing this, which might have caused this clot on tissue plugging onto the stent. So do you routinely do this, or you use a hurricane balloon?
No, I just do it. Here, as I mentioned, I use an additional 7 French SPDC 8.5 French. Otherwise, you just do with a 6 French cystotome, the stent will go in. You don't need a balloon also.
Yeah. Role of plastic stent. Role of plastic stent in it.
So there's an audience question.
Yes.
What is the role of the plastic stent in HGS?
So the plastic, so you mean doing an HGS with a plastic stent?
Yeah.
I don't think now anyone does that. The risk is primarily by leak. So I think they tend to get dropped very early. So I don't think no one is using plastic stent for doing an HGS.
The Japanese are doing it, and there's some special stent for it also.
Sorry?
There is a special stent for it by Dr. Ekoi, and they're using it, they're using the plastic stent for GS.
So what I'm not sure is, I read that paper, that whether that paper is primarily meant for benign disease or for malignant disease. I'm not sure of that.
So basically you are concerned about the duration the stent is in.
I think Vikas is instructing to shift to the other group and we'll do that.
Okay, thank you very much. Very good show.
Moving to the another case, they have this 39-year-old gentleman who was a former alcoholic. He had a recurrent acute pancreatitis in 2018, had a recurrent episodes of pain despite of analgesics. We have Dr. Siddharth Srivastava. The plan is to do an endo ultrasound and plan for T-Rex axis block. So over to you.
No, your voice is not audible.
Hello, now?
Yes, sure. Go ahead.
So Dr. Siddharth is there.
Yeah. It could be a bit louder actually.
What I'm going to do, I've just into the I will turn right and keep pulling the stroke. Keep pulling the stroke till I see a visible.
Dr. Siddharth, can you adjust your mic?
Yeah, can you hear now? Is it better?
It's not very good.
Now is it better?
Yes.
Okay, that is the master effect. Okay. So as I'm pulling back, I'm just trying to identify the vessel. This is the first vessel I have seen, and then I will try to see where this vessel is going. I'm just trying to track it down. So area in front of this vessel is the pancreas. Pancreas, as you can see, is just hyperechoic transfer in this pancreas. So you can see these hyperechoic strands of hair. So once you have seen that there is a formation of total range here, this is the aesthetic range. I'm just trying to focus on the aesthetic range and try to see the whole of the body and tail of the pancreas. And just try to rotate it towards the spleen. And as I'm turning around, now we are heading towards the spleen. I am going to the lateral surface. There are multiple collaterals around here. Possibly is chronic pancreatitis. Also, I won't see the full feature of the chronic pancreatitis, although they do qualify for what is called as chronic pancreatitis. And then we go down, here you see is the formation of total
See if there is anything. There is nothing which is to worry me. See you left, there is a photo right here. You can see the straight line. This one is the GPD and now we turn 180 degrees towards back side to identify the aorta. Here is my aorta. And I'm just pulling back from the aorta. I'm trying to locate where the celiac plexus is. Celiac artery is taking out. Here you can identify the celiac artery takeout. The thing is of the engage muscle is of Fortis program. And you can identify now this is very clearly this is the diaphragm to the down. This is the celiac axis going on, and this is the area of you can also identify there are multiple small lymph nodes. This is basically the adrenal gland, one of the limbs of the adrenal gland, and this is the area which possibly is trying to damage. There are multiple letters which are available. I think we had a word about those in the morning session also. And I prefer 19 mostly because it is more easy to push through a 19 page news rather than through a 22 or 25 page news. And
Dr. Siddharth, your voice is, like somehow it's not very good. The audio quality is very poor.
yeah.
Yeah. Yes, definitely. Yes. Good to go.
Always. So here is the area of my interest, which I am looking at is this area, which possibly we are going to puncture. I am using 19 gauge needle because I feel that pushing through 19 gauge needle is much easier as compared to 22.
Yes.
Here is my drill.
In between the adrenaline is coming. Are you comfortable?
Yeah. It's a bit bulky adrenal. Trying to avoid it. Trying to avoid the adrenal, I will poke in directly here and into that area. This can someone estimate for me?
I'm doing the pipivacaine injection right now. You can see the things flowing around. 0.25% and 10 ml in volume. Pipivacaine. 5 ml. we are going to push the triamcinolone. And we are aspirating and then we'll inject. So one point I would like to make is that we should look at this area. This is basically a very small artery, which is usually supplying to adrenal. That should always be avoided. So here we go. This is the area which we have injected upon. Okay, you can see the moving fluid a bit around here, and this is procedure is done. Yeah. So any questions? मुझे लग रहा है अब we are cut off.
Hello. Yes, yes.
Any question?
I think there are no more questions. Well done, executed procedure, though it was like technically difficult because of admiral on the way. Congratulations, Dr. Siddharth.
Thank you.
We're still continuing with the line.
Yes, so we are moving to the next room for next procedure.
Hello. Okay. Moving to the next case, we have this 50-year-old gentleman. Just a second. Moving to the another case, we have this 50-year-old gentleman who is alcoholic. He had the first episode of acute pancreatitis 2 months back, and now he has come with a recurrent non-bilious vomiting and a pain abdomen. His endoscopy was done, which showed D1, D2 obstruction with a millimeters glucosa, and scope was not negotiated. CT scan showed the bulky head of pancreas with a thickening of second part of duodenum, likely to be groove pancreatitis. So we have for this session Dr. B.S. Ravindra for the demonstration of this case. Sir, you are live.
What is our learning objective in this?
Yeah, I think basically this patient, I'm audible there?
Yeah.
See, basically in this, you're audible?
Yeah, definitely.
See, the learning objective here is there is a gastric outlet obstruction. One is whether it is due to an ulcer, or second thing is it because of an inflammatory mass. Third is whether it is a groove pancreatitis, which is the reason for the duodenal obstruction. And fourth being whether it's a malignancy.
So you're planning an FNA also?
If there is a need, then we will plan an FNAC based on that.
Okay.
But if it is more of a body and tail of the pancreas, if it is all bulky, edematous, and then we find more of a inflammatory thing, then probably not. Otherwise, we are planning to do an FNAC in this case.
Okay.
Because the way to differentiate an inflammatory pancreatic head mass and a malignant pancreatic head mass is usually lot of inflammation and entire pancreas will have telltale signs of acute pancreatitis. Whereas if it's a pancreatic head mass, usually by and large, you will have a dilated pancreatic duct and with a mass in the head, and they can cause an duodenal obstruction as well. Attach the scope.
Does he have a NG feeding tube in situ?
No, I think maybe the patient had a gastric outlet obstruction, they have put a right tube, and they are going to remove the right tube now. Just aspirate it before, if there is any fluid inside, we will have to check. And one more thing, you should always be careful is do an upper J before you do these cases, because many times there may be a lot of food bags which may be there. Yeah, puncture, that will be better. But first thing is, you see in these particular cases, better to start if there is any lot of fluids inside, then better to do an upper J, remove the fluid and then aspirate and then take the patient for the procedure.
So, Dr. Ravindra, there's still some time for you to start. Can I ask a question?
Yeah, please.
In your clinical practice, how many times before EUS you would like to do a routine EGD?
Yeah, I think there you have to remember 2-3 cases. One is if you are suspecting a gastric outlet obstruction, definitely yes. See, lot of fluid is coming out in this particular case, definitely yes. Other thing is, in case you want to do a CA esophagus, that is one scenario where you should always do an upper J, routine upper J and then do. That is number 2. Number 3, anytime you will find you passing a scope is difficult, then you do an upper J and then go, and then that is better. I think these are the 3 scenarios. You should do an upper J before putting an EO scope. Because we are seeing a lot of fluid inside.
So when was the last upper J done in this case? Any information?
1 week back, they have done an upper J, I think in another hospital, wherein they have found a lot of fluid. Only with an upper J scope, they were able to go inside, but any other therapeutic scope, they were not able to pass. Okay, done. I think now we just do the upper J because we saw a lot of fluids in the stomach. That's why we just do an upper J, routine upper J, and then if we find anything inside, we aspirate it out. See, as we expected, lot of fluid in the stomach. I think this is one learning point as an endocrinologist, we should always look into this. Lot of fluid, then most of the time if they vomit, then we will have an aspiration and the diagnostic procedure will end into any complication. That's why better to suck, especially when you are suspecting a gastric outlet obstruction. I think you can see this is a very characteristic picture. Even on an endoscopy, we can see lot of inflammation at the D1, D2 junction, which is characteristic of a group pancreatitis. And even the upper GI scope now is difficult to pass. You can see this entire inflammation along the entire duodenum. And let us see with the EUS scope. But I think the EUS scope may be difficult to enter into the D2. But let us just see a brief examination of the body and tail of the pancreas, and then I will also look at the head of the pancreas, whatever is possible from the D1. Right leg, you make it to this side. Yeah. In this particular case, our whole aim should be looking at the origin, looking at the body and tail of the pancreas, pancreatic duct, telltale sign of acute pancreatitis, wherein you will have an enlargement or a telltale sign of chronic pancreatitis. That is what we should be looking at. And then we will go to the D1 and then look at the head of the pancreas.
Do you usually expect normal appearing pancreas?
Very, very unusual. If it is a acute pancreatitis or even a chronic pancreatitis, we have diffuse enlargement. It is more of an acute pancreatitis. Chronic pancreatitis will have some telltale sign of chronic pancreatitis. But of course, if it's an autoimmune pancreatitis, then you can only have a head pancreatitis, something similar to that. That is the three variants you can see. But if it is a pancreatic cancer, usually very rarely even pancreatic cancer can present, that is pancreatic cancer presenting like a pancreatitis. Then it will be very difficult to differentiate a pancreatic cancer from this because we get few percentage, at least 2 to 3 points, less than 5% of the pancreatic cancer can present with pancreatitis.
Another thing would be a patient who has group pancreatitis presents with an acute attack. So in that scenario, you will have findings of both actually.
Yes. That's why it is very difficult. But usually pancreatic cancer, by and large, if it is not presented with an acute pancreatitis, then it will not be like that. That is the only. I think this will be a quick procedure. What my whole aim is, just make the EUS bigger. I think this is better, right? Because I usually keep the cranial line to the left. I think this is the left lobe of the pancreas. You can see. Just rotate, and then this is the celiac axis. Make it little bigger. Image bigger. Yeah, I think this is the very structure.
I see that you're using an opposite orientation that was
familiar with. Yeah. See, this is the celiac artery SMA, and then just push it down. See, now you can see the pancreas here. This is the portal vein which is entering inside. This is the pancreatic duct. Let us measure the pancreatic duct. Measurement here.
नहीं
The pancreas looks quite okay.
Yeah, here it looks okay, but let us go down. Yeah, see this, the one more sign that this is the pancreas. As usually you won't see a dilated pancreas because its age is, what is the age?
50.
Yeah, 49. See, you won't see the one of the thing, but you should always observe is you will never see this. Where is the cursor? Yeah. You will never see a dilated duct up to here. See, I am at the body of the pancreas. I am going towards the tail of the pancreas. You won't see such a dilated duct with a the margins being hyperactive.
Yeah.
It indicates that there is some amount of
Chronic pancreas.
obstruction or chronicity. This is one of the features. Though he is not having any other signs, maybe some hyperechoic pupae and strands. Other than that, I don't see anything. And then I am going towards the tail of the pancreas. This is the spleen. And I am going towards the tail of the pancreas. See, till the tail, the duct, you can usually at the tail, you can never see the duct up to the tail. But if you see anything like that, that indicates, see, I am now coming back, and then we have seen the entire pancreas from up to the down. And even here we can see, from the stomach body itself, we can see the head of the pancreas here. And this is the neck of the pancreas where the portal vein assembly joins. This is exactly the neck, and then below we see head and the antennae. And now let me go to the, see, another thing which is important is, see, you are seeing the, probably this is the gallbladder which we are seeing. The fact that the pancreatic duct is not that, yeah, it makes you wonder less that it's cancer and more it's chronicity with pancreatitis. Yeah. We just go to the, see, one more thing what we should always observe is, here I see the GB is very much enlarged, which indicates that maybe the CBD is blocked. I think that's one more inference what we can have. See, this is the GB also appears to GB also appears with full of stone. But the only thing is we now I think the duodenum is completely obstructed here. Let me see the portal and the CBD, but the whole duodenum, as you see here, which is endoscopy vision. See this, the whole duodenum D1 is obstructed. Let us see. See, I think this is the only view I can get. See, this is the only view. This is the. See, yeah. See, this is the thickening of the wall. What we are seeing. See, this is the wall which is very much thickened. You can see here, and the audience appreciates.
Yeah.
This is the thick diurnal wall which we are seeing, and this is the portal vein probably. Yeah. I think this is what we are able to see, and then this is the only part of the pancreas we are able to see here, this one, and then this is a very hugely dilated gallbladder. Sometimes there can be sort of cystic changes in the wall. Is that? Have you seen something similar? Yeah. I think that's very characteristic of group pancreatitis. The way we should see the differentiation between a malignancy and a group pancreatitis is this: the wall, when you see of this wall, particularly when you see this sort of a wall, which is showing a lot of inflammation. Most of the time there may be a hypertension, thick duodenal wall, and then an enlarged pancreas. What you are seeing here. See, this is very characteristic of a inflammatory pathology what you are seeing. See the thick duodenal wall here, and then the inflammatory part of the pancreas what we are seeing. That is very characteristic of a inflammatory pancreatic pathology, which we label them as group pancreatitis or an inflammatory mass. See, this is, now you can see this. This all inflammation, that's likely a malignancy. But only concern for me is this dilated gallbladder, which probably indicates there is some amount of CBD narrowing may be there. That is the only thing what I am worried about.
You see a dilated found by the jaundice sensation, group pancreatitis?
Yeah, sometimes we can see, but most of the time, any inflammation in the pancreas which compresses the CBD, we can have it. I think this is the inflammation what we are seeing in the head. Can they appreciate there in the audience there?
Yes, we can see that, but we don't see any typical cystic dystrophy kind of a picture.
Yes. See, this is the thick wall of the duodenum, and then this is the pancreas, which is inflamed pancreas in the head. That is what we are seeing.
So is it acute pancreatitis, acute and chronic pancreatitis or group pancreatitis?
See, both of them, see, just a group pancreatitis indicates an inflammation in the duodenum group, which happens in acute or chronic, but most of the time that is what the term group pancreatitis indicates. That need not have all the cystic structures and all. On EOS, what you can see is an enlarged with the pancreas enlarged, lot of inflammation, hyperpagenicity of the duodenum. These are the characteristic features. But you can also have cyst, that is because of the fluid collection which happens between the duodenum, first part, and the pancreas. I think now let me just see the CBD from the xylem. That will tell me what is happening to the bile duct. See, there is a hugely dilated gallbladder. See, from here itself, I can just see this is the CBD which I am seeing now from the body of from the stomach itself. This is the dilated CBD here. This is the cystic duct joining the CBD here, and then I can see them just entering into the pancreatic head. This is all I can see from the body, from the stomach body, what we can see, and this is all inflamed pancreas. That's what I am seeing. That's why probably even the GB is hugely distended GB. And then this is the cystic duct which I am seeing, common bile duct and the cystic duct, and then it ends here at the inflammatory end of the pancreas. I think final impression on the EOS in this particular case is body and tail of the pancreas, there is a pancreatic duct enlarged, D1, D2 is blocked. Third point, what we are seeing is head of the pancreas, inflammation is there, duodenum is inflammation is there, CBD is blocked at the entry of the pancreas. These are the findings what we have. And finally, on endoscopic ultrasound, the diagnosis is this is probably a pancreatic inflammatory mass with a CBD obstruction and even D2 block. I think that's all from this particular case.
Thank you very much. Thank you very much, Dr. Ravindra. So we will be instructed to move to the next room.
Thank you for moving to next room. Our next case is ready.
Moving to the next case, we have 54-year-old lady. She is a case of decompensated cirrhosis with portal hypertension. She presented with acute GI bleeds. Endoscopy showed large gastric varices. US guided coil and glue was done 5 days back. And we have Dr. Kapil Chamba to demonstrate US demonstration of gastric varices. Sir, over to you.
A bit louder, please. Not exactly.
Are you audible?
Yes.
No.
Now it's audible.
Who is demonstrating?
Kapil Jamal.
Is the screen visible?
Yes.
Yeah. And you can see globular structure there. What I will try to see is what is the mucosal component of the gastric varices. So I will pull back my scope a little bit and see where is the gastric tumor. So we are seeing spleen and a vessel I'm seeing here. I'll just push it back, push it a little bit. Can get rid of water.
So, Dr. Kapil, when you start looking at the gastric varices, do you start from the splenic hilum and then trace the intramucosal part of the gastric varices? Is it the norm, or you straight away jump at the varix itself?
So basically, but when we plan to intervene or inject, then we have to assess all the vessels starting from splenic hilum. But first I will see when so I'm seeing the spleen here, you can see the spleen is coming down, this is the spleen here. And we can see ascites also is there, is below the diaphragm. And I will try to show, this is a splenic vein here, you can see the splenic vein. This is splenic vein coming in this area. And when you see a part of the splenic vein there. Okay. And then I will just try to localize where the gastric comes. So we can see that quickly here and there. Pull back a little bit. Now, we see now that flow of paper, but so you can see something is here coming in this area.
That's coiled.
Okay, so looks like some glue has been injected in this area. So you can see there is no blood flow. And some cast also is coming. You can see that cast. So most likely the coil or glue is somewhere here.
Yeah, so the cast shadow is already seen,
Yeah.
and there's no Doppler flow is hardly.
No blood flow. And we can see that there is no mucosal component which is seen here.
Can you make
if some blood is there,
Can you make the picture a bit bigger?
Yeah. Just do it. This is the leftover liver. This is the here the cast, we can see a shadow behind it here. This area. You can see that the cast is shadow is coming there. So most likely cast has been injected somewhere here. The glue and the cast is coming like this. And coil I'm not able to see, maybe coil is here. You can see the coil.
Yeah, probably that's the coil.
The coil, and there is no blood flow. So almost diminished blood flow in the gastric varices.
Can you inject some water so that it can be better delineated?
You can see that the coil is here. This is the mucosal component. Here we can see the water, the ribbon. This is the gastric ribbon here. Just suction because the
Kapil, can we see the perigastric collaterals? I think, can we see the perigastric collaterals in this
yes,
case?
sir, try to see because the patient is little bit.
Okay. I think there in the left lobe there is some lesion there actually, hyperechoic lesion. This one, yeah, this vein, yeah, there's something there. Hemangioma? Maybe.
Yeah, we are seeing something because there's ascites around the liver, both sides, this side and the other side of the liver.
I think there
We
is.
are seeing a hyperechoic lesion in the liver.
Yeah.
That type of liver.
Yeah, I think we have to upload HEC in this.
I will try to find whether I have been able to see any collaterals around the perigastric area. Patient is stable. I'm just trying. So we start from the spleen and see whether we are able to trace any collateral from the spleen itself. Mostly what collaterals do we see is in a gastric varices, one is the efferent, which drains the gastric varices, which is purely glenorenal shunt. And the afferent vessels are the left gastric vein, the short gastric vein, posterior gastric vein. Mostly what we see around the gastric varices are the afferent vessels. Rarely we see a collateral which is efferent, which goes directly from this. So what we see normally around the gastric varices is around the stomach wall are the upright vessels. In this condition, I think due to recent intervention and the collapse of the gastric varices, there are not much big collaterals are seen. Normally, what we see is such a large gastric varices.
So-
Typically, the gastric varices is large. It is more than 15 to 20 millimeter. But when we see here, the collaterals have disappeared. Most likely, the blood flow has gone. You can see the cast is here. You can see that the shadow is coming. So, and the blood flow has totally disappeared in this area.
So what is better in your opinion, injecting the afferent vessel or the varix itself?
So depends upon, suppose the varix is very large, you have to inject too much, like 3 or 4 coils and too many of glue. So it's better to try to identify a afferent. So that is better, but the only thing is you have to have a pre-procedure imaging. Because if the patient has too much of shunt, so in those conditions, it's not better to do a glue injection, only coils should be done. But suppose had 80% of cases, it's basically a purely 1 to 2 shunts, then in those conditions, you must guided glue and coil can be attempted.
How easy is it to identify the afferent vessel?
That's why, so in this case, normally it's such a large gastric vessel should be able to identify, but I think in this case, because of the recent intervention, the blood flow has stopped. We are not seeing any large collaterals around the gastric vessel area. So this is from where you can see that this is the tip of the screen here. So this is the
Kapil, we can see some round lesion there in the center of the.
lesion is there. That's why I'm trying to see, but there is no color flow over it.
Is it a thrombosed collateral or?
Yeah, something like that. So the thing has gone up. The thrombosis has gone up from the. So normally we see blood flow into this.
Yes.
This becomes thrombosed.
Uh,
This is thrombosed after injection. So normally it should be a big collateral which should have blood flow. But in this condition, this has blood has disappeared. And this is going forward.
This is coming from the spleen, so it should be an afferent or is it efferent?
Not from the place, separate from it. It's separate. You can see there's a gap between it and here. The gap between it. So it's not from the spleen. So most likely this would have been continued downwards toward the gastric vessels. You can see that the gastric vessels here somewhere. Okay, just to also it'd be nice to illustrate. Yeah, it's the extra luminal dilated collateral versus gastric varices. Differentiation. So it looks like it was looks like a vessel only, but it's just thrombosed now. There's no blood flow.
So probably because of the intervention, your job is becoming difficult.
Yeah. So there you can see there's no collateral normally what we see around gastric varices. This is the blue bar there. There is no varices, no collateral there. You can see the shadow like this, the shadow here. That shows that the coil of blue is somewhere here.
I think Kapil, the arrow is just on the thrombosed collateral only.
Yeah.
I think it's outside the gastric wall. What do you say?
This is the collateral which has thrombosed. This is outside.
Yeah.
And when we go and push it downward, here we see the collateral and there's a gastric lumen which will come here. I'm not separated because of the patient started coming. So this is the gastric lumen here. And this is the most likely the mucosal component. You can see the blue cast here. When we pull back a little bit and we see that the cast is coming, so that means most likely coil will be here. And when we pull back a little bit more, there's a large collateral which has thrombosed. So this is a collateral which is suprasplenic. It is also thrombosed. So there is no blood. And but the splenic vessels are faded, which we can see. That means sometimes when we target Dr. Rajiv, you are asking, so sometimes what happens is they are so much large vessels, we are not able to distinguish between the splenic vessels and the collateral. So we have to see that way. You have to trace first the splenic vessels and then inject into paragastric collateral. That's why directly injecting the gastric vessels is easier and associated less complicated.
Kapil, can we fill the lumen with the water and see the submucosal layer? Because in that layer, it's a gastric varices are seen. Can we use the?
This looks like the gastric coil here. You can see this is a coil here. This is a coil you can see. This is a coil here.
Yeah.
And this is a vessel which is submucosal which has thrombosed. So this is a vessel which is thrombosed now.
Yeah.
This is the vessel which is this is the submucosal vessel. So this is far away. You can see all the layers beyond the scope and this is thrombosed. There is no blood flow.
Is it extramural or submucosal?
Extramural now. Mucosal is somewhere here.
Yeah.
So this is somewhere submucosal component. This is extramural. This is outside. Most likely of paragastric collateral.
Yeah.
You could see the gastric wall. Yeah. Between the thrombus and the coil. Yeah. You could see the gastric wall. So it's an extra luminal vessel which is occluded.
Kapil,
Yeah, I reviewed this before. You could see the gastric wall there.
Kapil, can we fill the liver with the water? That will help us.
That's the gastric wall. You see the muscle there. On the left of it is the occluded varices, and on the right you can see the. Here the water is there.
Yeah, now it's making things more clear.
This is a
Yes.
the luminal component of the gastric varices.
Yes,
You
sir.
can see the coil and this one is there. And when we pull back a little bit, so this is extraluminal. This component
Yes.
is extraluminal.
Absolutely. Beautiful.
And this is clean here. So this is also thrombus. So the thrombus are extended from the gastric part into the submucosal component also.
Kindly give us some tips of maintaining the scope during glue injection, how to prevent impaction.
That's why the best is trans-esophageal function is better because the scope is more straight. You can keep it for a longer time. If you are in trans-gastric function, the thing is you have to keep the scope in a position and bend it. And that makes it more difficult. Sometimes the accessories of the needle doesn't come out. So better is to, if they are not large varices, try to do a trans-esophageal function. That will keep the scope in a more straighter position. And accessories will come out easily. Only thing is the gap between the coil and the glue. Suppose the gap is more, so that time because of the negative suction applied of the needle extruder, so the blood may go inside and that it will circulate when we inject glue into it. So that's why. So this, the transformation will be very faster when we deploy the coil and then inject the.
Dr. Vikas, can you hear me?
Yeah, Dr. Rajiv,
Yeah, so
I'm here only.
yes, okay. So I heard you once that you used to put the coil through US and then you used to go with the upper GI scope and put the
for the large varices, they have the capacity of around 4 to 5 ml. They need around 4 to 5 ml glue. Even after you push the coil inside the varix, still they require 4 to 5 ml glue. So what we do, we go by the transgastric approach. We go across the G junction, then fill the lumen with the water. Then we see the varices in the third layer. So first we fill the varix with the multiple coils. We pack it with the coils. Then with the same needle, we inject 1 to 2 ml. If there is still some flow left, then the needle are very expensive actually. So we change to the forward wing scope and we keep on probing the varix. So the softer part we inject with the glue.
So that is not always.
No, not always. If it's small varix requiring only 1 to 2 ml of glue, we use the same 19G needle. It's just to save the cost of the needle.
I think better is to put more coils rather than less glue, because the glue only does the solidifying component.
Kapil, I will disagree on that. Now the data has shown that the most essential part is the glue. So whatever US guided endotherapy you do, so the glue is the most essential part because when you use the coil or the thrombin, it will form a physiological clot which may rise later on. So the glue will give you a more solid and the permanent space occupying thing. So the glue.
But it will add on to cost because most likely you can't be injected more than once or twice per injection. So if you inject 5 times, then ml of glue, it will require 5 liters.
But now there are 3 meta which have shown that glue has to be an essential part of the US guided angiotherapy of the gastric varices.
Yeah. So either you use more coils and less amount of glue last injection of glue because it will solidify and bind all the coils. Or you use more 50-50 of coils and glue. But I think if the coil, the vessel is big, better is to put more coils and then at the last put glue. So
Yes.
But they are not all the data which is I have done a meta-analysis also I am bringing it. So 2 to 10 ml they are used, but in the US guided they use less coil, less glue as compared to the conventional method of endoscopic glue injection.
Yeah.
So that we have to see what is the actual, but only thing is, I think the better is to use less glue, chances of embolization also.
Yeah, glue is must, the amount may vary.
Yeah. Glue is must, we can't do only simple injections. All data has shown that combination is better and superior to a single modality. Either it is coil or glue.
Yeah, what's your take on
how
that?
much amount of glue, that is still under question.
Yeah, I think everyone is doing in a different way. And I think literature is not very clear about the amount of glue that we inject when once we are doing an US guided procedure. So what, as I think Kapil mentioned, what we tend to do is to deploy coils maybe 1, 2, 3, and then use around 1 to 1.5, not more than 2 ml of glue. In all these patients, even if we have very large varix. So more of coils and then maybe just 1 to 2 ml of glue, not more than that. See, the primary reason why we are doing a US guided procedure is to prevent embolization of the coil, of the glue. That's what we are trying to do. If we inject a lot of glue and maybe if you just deploy 1 or 2 coil and then inject a lot of glue, possibly glue will embolize. So that's the concern we have. Then the whole reason why we are doing the procedure it's defeated actually. Yeah, I think the philosophy is making a.
In this case, no, because they were using as a outer region in the flow of liver. The coils that worked and the glue the previous procedure done well. All are even the submucosal component has composed. So I think she will not bleed from this side again.
Thank you, Kapil. That's a wonderful demonstration. Yeah.
Thank you, Chairperson. So we have one more live case left, sister gastrostomy. But before that, we'd like to I'd like to call upon Dr. Praveen Rai to finish his lecture because I have a flight to catch. So for this session, I would like to invite Dr. Manoj Lahoti and Dr. Ankita to please chair the session. So very good afternoon. I'd like to thank Vikas for this wonderful event. So we're discussing about EVs that is total hypertension, EVs in total hypertension and vascular lesions. So EVs in vascular therapy is again an emerging tool that we have. There is a close proximity of GI tract to vascular structures. EVs provides clinical and anatomical information about appearance, size, and location of the vascular structures. It's minimally invasive. You get a precise intervention, target the vascular site that are less accessible to conventional access. It is an alternative portal of entry to femoral, jugular, or subclavian. And agents that are used are primarily cyanoacrylate, thrombin, and coils delivered during using FNA needle. So these interventions predominantly involve the management of variceal bleed, management of non-variceal bleed, measurement of the portal vein pressure and portal bleed shunting, biopsy of intravascular thrombus for diagnosis, collect circulating tumor cells. So we will be discussing the last two because of paucity of time. So as is shown in the live demo, EVAS is a very important modality for treatment of gastric varix. So as you know, gastric varix occurs in about 20% patients with portal hypertension. It has got a significant mortality from the first variceal bleed to the tune of 20%. The risk of bleed again is high. This is 3 to 90% following initial intervention. So if you talk of endoscopic treatment alone, that is without EVAS guidance, you achieve hemostasis in around 60 to 100%, rebleeding 0 to 40%, which is very high rebleeding rate with endoscopic therapy. And the major and most serious adverse events is pulmonary embolism, cardiac and splenic artery embolism. Unfortunately, you cannot prevent this. Splenic vein thrombosis, renal vein thrombosis can happen, entrapment of the needle in the varix by cyanoacrylate and can damage to the scope. So these are problems that happen with the endoscopic treatment, and that's the reason why EVAS is in picture. So how EVAS helps? Detection rate of gastric varices have increased. Sometimes varices are not picked up. You can pick those up on EVAS. Precise delivery of coil of glue into the varix lumen. Doppler confirms obliteration after treatment, that is prognostic significance for rebleeding risk. Treatment can be done without dependency on direct varix visualization, even in the presence of bleed. So if the patient is actively bleeding, endoscopic therapy becomes very, very difficult, but EVAS guided therapy, if the bleed is because of gastric varix, you can still do that in an actively bleeding patient. So EVAS can identify the main feeding vessel. What I would say, it's very difficult to identify the afferent and efferent, which somehow we are not doing. We are unable to do that. And this, if you are able to see those feeding vessels, you can minimize cyanoacrylate needle needed for the obliteration of gastric varices, and this leads to reduced embolization risk. So injection is the standard treatment. There are studies comparing
coil alone versus glue alone, and what has been shown that this is the way forward. The coils that are used for intravascular embolization can be delivered under US guidance. Coil plus glue injection may reduce or eliminate the risk of glue embolization. This is an advantage. Basically, coil functions as a scaffold to retain the glue within the varix and decrease the amount of glue required for variceal obliteration. This is what it does. So if you talk of technique, so prophylactic IV antibiotics is mandatory. Usually you fill the lumen with water. As you just saw, what happens when you fill the lumen with water, you are better able to delineate the submucosal gastric varices. And again, it's very, very important to see whether you are puncturing the submucosal gastric varix or you are trying to inject the paragastric collaterals. So you should not be injecting the paragastric collaterals. So it becomes very important that you are convinced on EUS that these varices are the submucosal varices, gastric varices, and not paragastric collaterals. So primarily you use a 19 gauge or 22 gauge FNA needle. Needle is primed with sterile water, very important. Transesophageal transcurate puncture is the initial technique that was described by Ben Moeller. However, we usually do it transgastric and it is not all a problem. So coil is deployed through the FNA needle and can be visualized on EUS. Cyanoacrylate again injected through the FNA needle. EUS Doppler confirms Doppler is done to confirm that there is no flow in the varix after obliteration. So as you can see, this is the varix that you see. So this is the gastric varix which you usually see, and this is again you see the size of the varix. How big the varix is, you can measure the size of the varix. The size of the coil is usually 1.3 to 4 times the size of the column that you are seeing. Normally we have the maximum size of the coil that is available is a 2 centimeter coil with diameter, and the length is 14 to 20 centimeters the length. So usually it is what we do is use a 19 gauge FNA needle. As you will just see, this is the 19 gauge FNA needle. Puncture the gastric varix, and once you puncture, first you will flush this with sterile water, inject coil first. After injecting the coil, again flush this, and then use glue to obliterate this. So you can use the number of coils, again you decide on the table. Once you obliterate the varix, and it's not a complete obliteration, you can choose to inject 2-3 coils, and after the last coil that you are deploying, only then you inject the glue, because once you inject the glue, your needle is gone. So this is the study, I think shows a very high success rate, technical success to the tune of 99%. The clinical success, again, very high, very low risk of rebleed in these patients, monitored over a long-term follow-up. So this study convincingly shows that you can use EUS-guided coil and therapy, coil and glue, for the obliteration of the gastric varix. So recently we again have a paper from the same group which had done EUS-guided coil and glue as a primary therapy for non-bleeders, again with a good long-term results. So for the management of a non-variceal bleed, again, there are just case reports of this subgroup of patients. So it's done using epinephrine in Bullous lesion. Again, there was a publication of 5 patients with non-variceal bleed using EUS-guided therapy, Haemosuccus pancreaticus, during ulcer and stromal tumor. Alcohol or cyanoacrylate was used in the different cases using a 22 gauge FNA needle, and over a period of follow-up of around 12 months, there was no complication in the form of rebleed. So this is what the data is. This is a large retrospective analysis of all these studies, which shows that these are just case reports. Different settings, Bullous lesion, GI stromal tumor, dural metastasis from colon cancer, dural ulcer, dural Brunner's gland hematoma, esophageal cancer, arterial anomaly of gastric fundus, and GDA bleeding caused by pancreatic tumors. So here, what is the EUS-guided therapies was performed using sclerosing agents in the form of polidocanal, cyanoacrylate, combined thermal contact and alcohol, hyaluronate in 3. So these are different modalities that have been used in these different cases.
So this is interesting large ulcer because of a GIST in which they have done an EUS guided therapy with good results. So as you can see, this is a large ulcer here in the antral region. And this was an underlying GIST here. And on EUS, what they found was a large vessel running through this, causing the bleed which this patient had. So what they did here was injected EUS guided cyanoacrylate injection, and the bleed stopped after this procedure. So this was the vessel that they identified, and then they did EUS guided therapy here. So you can see this 19 gauge FNA needle, and then on this they injected cyanoacrylate glue. So again, they reported follow-up, long follow-up with no rebleed in this particular patient. So after this, there was a reduction in the size of the ulcer and healing of this ulcer. So EUS therapy outcome here in this study was complete cessation of bleeding in around 80%, decrease in blood flow in around 10, bleeding hours stopped in all the patients, and the favorable, very favorable clinical outcome with rebleed only in few patients. So for non-varicose GI bleed, EUS guided therapy is safe and effective just based on few case series. Advantage, simultaneously visualizing, treating and checking the effectiveness of the treatment. Literature again, as I mentioned, is scarce, and we definitely need large studies, preferably randomized one, to do the job. So the aneurysm, we are using this EUS guided coil and glue for treatment of aneurysms. So as you see in visceral artery aneurysms, the most commonly that we see is the splenic artery aneurysms in gastroenterology. These are usually asymptomatic. The problem here is the high risk of rupture to the tune of around 20%. And if it ruptures, the mortality is very high to the tune of 25 to 100%. So that's the reason you need to treat this aneurysm, and treatment modalities traditionally is surgery and the endovascular approach. Why EUS guided therapy when you already have surgery and the radiological approach? The reason is it avoids percutaneous puncture complications. It's a daycare procedure, done in conscious sedation, precise targeting of the aneurysm and precise injection, lesser expensive than radiological treatment, and can be repeated safely. So how do you do this? With propofol sedation in these patients, we use the linear EUS puncture with a 19 gauge FNA needle, usually a transgastric puncture. After puncturing the ground, the slope is withdrawn. Coils are pushed down, similar to what you do in gastric varus, followed by injection of glue. So this is again an old case that we have done, which this is a large splenic artery aneurysm. As you can see, blood flowing this aneurysm, and on Doppler you will find that this is the neck of the aneurysm. This is again from the splenic artery. So these are the coils that you must have seen that we place to obliterate this aneurysm. This is a large aneurysm, was around 4.5 centimeters aneurysm, and we used here multiple coils along with just 1 ml of glue to obliterate this aneurysm. So this patient still is on follow-up. I think 3-4 years down the line, this aneurysm has not opened up. So this is 19 gauge FNA needle. You inject coil. So this is the coil which is coming out. You can see the coil coming out, and then you inject further coils, and followed by the injection of glue. And as you can see, after application, after injection of coil and glue, if you apply Doppler here, you see there is no flow in this aneurysm. So these are again CT images which shows that there is complete obliteration of the aneurysm. So this is again an interesting case which we did just before coming to this conference. We did this. This is second. So you can see there are 2 aneurysms. Actually, this patient has got 3 aneurysms, 1 in the GDA, 2 in the splenic artery. So this is one of the aneurysm in the splenic artery. This is the second aneurysm. So what we did on Thursday, this Thursday, we injected coil and glue in these 2 aneurysms, and then he's planned for embolization of the GDA also under EUS guidance. So as you can see, we inject again same procedure, 19 gauge FNA needle. So very interesting in the sense, first time also, I'm seeing this for the first time, the 3 aneurysm in the same patient, and this is a patient that established chronic pancreatitis. So this is the first we have obliterated, and the second aneurysm again you inject,
and then complete obliteration achieved on the table itself. We'll obviously do a next procedure maybe after 3 days to achieve the results. So this is again a whole case report that we published. We'll use thrombin here. Then again in this patient we used, this was again the first report of this splenic artery, large splenic artery embolism using coagulant glue. Again, complete obliteration. This is the case series that we have published. After this, as I mentioned, we have done around total of 15 cases, very high technical success and no complication whatsoever. So to summarize, ES guided coagulant glue is feasible, high technical success rate, no significant adverse events, can be repeated safely if required. So coming to the last part, this is portal vein interventions, portal hypertension. We have human studies of portal vein pressure measurements. We have been trying to get this manometry device, but somehow it's not available. It has recently come in Hong Kong. They're doing some studies on this. Animal studies on US guided intrahepatic portosplenic shunting has been done. This is again for hepatic and pancreatic biliary malignancy, FNA of portal vein tumor thrombus, and sampling of circulating tumor cells in the portal vein. So portal vein measurement is definitely needed. Those who work in hepatology know the importance of measuring this HVPG or the portal vein pressure. So I'll just demonstrate the technique that was published in this GI. So what basically is done is you have a 19 gauge FNA needle. This is the manometry catheter. This is the rubber tubing. So one end of the rubber tubing is connected with the needle, and this is the manometry catheter manometry device. And one end is fixed with this catheter. So very simple to do. And then the other end is on the back of the needle. You will just see that. This is a needle is attached with sterile water here, saline here, and then the other end of this tubing goes in this, and you just go in the portal vein, and this is at the level of the arms, and then you punch a little hepatic vein here, and after puncture, you connect this, you can see this reading coming in the hepatic veins. You can do similarly in the portal vein and calculate the portal vein pressure gradient as well. So this is how it is done. So I think right now what you do is a transjugular approach. I think once this comes, that would possibly take a back seat. So again, the portal vein pressure measurement, first human pilot study, around 28 patients with a history of liver disease or suspected thrombosis, and measured portal pressure gradient correlated well with the clinical parameters of portal hypertension. So I think what people have done is used US guided intrahepatic portosystemic shunting. This was the first study which was published, where this is the portal vein, this is the hepatic vein, and they created an anastomosis here. This was in animals. And another study, again in animals, they have used a biflanged stent similar to the Nagy stent or the Plumber stent or the hot axial stent. In this animal studies also with good results. In necropsy, they did not find any evidence of bleed as is expected in these animals. So to summarize, the role of EOS in vascular therapy is still evolving, effective and less invasive than surgery or percutaneous option. Despite technical success, there are limitations, small number of enrolled subjects and poor methodology, varied procedural techniques and lack of large randomized controlled trial. Indication should be clearly stated and patients should be carefully selected. Radiological and surgical backup is must. Thank you.
We have a question after. Next, we are talking on US guided
Anira. As we are running short of time, the director, Vikas, as we are running short of time, only must rush through the slides.
I'll be talking about the US guided liver biopsy. So liver biopsy is a necessary evil for all hepatologists. It is necessary because it tells us about the activity within the liver. It tells us the etiology of liver disease, and it tells us the prognosis of the fibrosis which is present within the liver. This leads to us making a diagnosis of liver disease, prognosticating disease, and managing liver disease. Another addition to this would be for research purposes. And it is evil because it is associated with a large number of complications. So data on complications in liver disease is heterogeneous. However, if you look at the studies which have been published, severe complications up to 5% and mortality up to 0.5% have been reported in various studies. This is data from the HALT-C studies. These are studies conducted on patients of hepatitis C to see progression of cirrhosis in these patients. And complication reported was 1% and a mortality of 0.2%. The complications being bleeding and severe pain. In fact, various studies have shown that up to 84% of patients who undergo a percutaneous liver biopsy can actually have pain, and this pain can persist for weeks or months together. So the next step after development of percutaneous liver biopsy, and after we realized that percutaneous liver biopsy was associated with complications, was the development of transjugular liver biopsy. As data on transjugular liver biopsy kept on gathering, we have also realized that transjugular liver biopsy is also not all that safe. And in this large study from India, 2.5% complication rates have been reported. The minor complication being neck hematoma, supraventricular tachycardia, and pneumothorax. And the major complication being fever, cutaneous pseudoaneurysm, hemophilia with intraperitoneal bleed, and massive hemoperitoneum. Another problem with liver biopsy is the sampling variability. So there have been numerous studies, including this often quoted study on NASH, which have shown that if you do either bilobar biopsies or you do biopsies on the same patient on different days, there is a large degree of discordance. Discordance up to 41% for this stage of the liver disease. Yet another problem with standard liver biopsy is the presence of contraindications to liver biopsy. And these contraindications can be like extrahepatic biliary obstruction, presence of morbid obesity where you are not even able to assess the intercostal space, presence of ascites, apart from the standard complications like coagulopathy and thrombocytopenia. So any new method of liver biopsy which came up had to address all these complications. So a high complication rate, sampling variability, and contraindication. US guided liver biopsy is the newest kid on the block. The indications for US guided liver biopsy are the same as percutaneous liver biopsy. The additional indications of the advantages of US guided liver biopsy could be that it could be done in those who are already undergoing an endoscopic procedure, those needing a sedated biopsy, where bilobar sampling is necessary, those who are obese, presence of ascites, mild to moderate ascites, not gross ascites, and those with dilated IHP1. The standard needle which was used first was the two-cut needle, but this was stiff and would hardly enter the liver. So following the two-cut needle, the next needle which came in was the standard 19V non-two-cut needle. And then came in the core type needle, which has a cutting tip, and these are the type of core type needle which are being used. So the pro core needle, which has a reverse bevel out here, which cuts while going in as well as coming out. The sharp core needle, which has a tip like the mouth of a shark, or the fork type needle. The acquired needle, which has a flancid tip. So these are the cutting type needles, and the standard expect needle, which is a bevel shaped Then came the controversy as to which of these needles were better.
This has largely been laid to rest in this 2020 meta-analysis, which included 1,326 patients in 23 studies. And they found on subgroup analysis that core biopsy needle proved to be better in terms of CPT than fine needle aspiration needle, 18.4 versus 10.99%. So, if you have to do a lower biopsy, you should do it with a core biopsy needle. Techniques of tissue acquisition, you can use a standard slope pull technique where you remove the skillet gradually. Dry suction, you could use wet suction with saline, but what has come out now is wet suction with heparin. Why heparin? Heparin, because a lot of blood comes in when you sample the liver, and this heparin prevents the blood from clotting inside the needle. So when you do a US liver biopsy, what are the steps? So pre-procedure, you have to verify the patient, verify appropriate indications, verify that there are no contraindications, confirm INR and confirm platelets, select the needle, that is a 19-week core type needle, and most importantly, select other supplies so that you are not running helter-skelter once the biopsy has been done and you have forgotten to collect the formalin jar. So formalin and tissue filter and timing sedation should not be done. After the desired lobe of the liver, as Dr. Siddharth said, that for the left lobe, you go in and rotate the scope counterclockwise. For the right lobe, you go into the Goodman and then you rotate the scope 180 degrees. Identify a 2.5 to 5 centimeter trajectory for needle pass, which does not have any vascular structure. So apply a Doppler and see that there are no major vessels there. You prime the needle with heparin plus SNA. You set the vacuum in the suction syringe 5 to 20 ml as desired, and then you introduce the needle into the channel of the endoscope. After introducing the channel, you recheck the trajectory for the needle, lock the endoscope knobs, and have the assistant holding the scope. Enter the liver with a quick short jab, open the stopcock, and then the steps are as with a standard biopsy. The only change is that you do not do more than 3 passes. So this was also controversial with a 1 pass, 2 passes, or 3 passes, but nobody advises going into the liver more than 3 times for 1 biopsy. Once tissue has been obtained, you remove the needle and extrude the specimen for the needle directly into the formalin. This is important because if you put the specimen on gauze, then the specimen can become fragmented. Another thing is that there can be a lot of blood within associated with the specimen, and that is because the liver is quite vascular, and this blood can actually be drained by using a sieve. So these kind of commercial sieves are available abroad, but in India we can use a simple sieve. And if you get these kind of long biopsy pieces, the pathologist is going to be very, very happy. Recovery following the procedure. So same as any other endoscopic ultrasound. The recovery after liver biopsy is almost 1 hour compared to 4 to 7 hours following PCLB and TGLB, and no admission is needed for USLB. Results and complications. So if you look at these studies, the last 4 studies are the ones when USLB was fully established, and tissue acquisition is almost to the tune of 98% with hardly any complications. Surprisingly, 2 studies have reported 0 complications. One has reported 0.9 complication, and this was one patient who actually had a bleed because there was thrombocytopenia. This is one of the largest multi-center studies on USLB. 110 patients, 9 centers.
एयरपोर्ट वाली साइड
length that they got was from 3.2 to 4.9 centimeters, and the median CPTs were from 14 to 17.
तो ऑन द टाइम कट लग गया ना
compared it with transnuclear and percutaneous biopsies done during the same session, same time, and what they got was that they did both blood sampling, then both the tissue sample length as well as the complete total tracts were significantly better than those obtained with either percutaneous or transnuclear biopsies. If they used only the left lobe, then the samples were better, but they did not reach statistical significance. So at least they were equivalent to transjugular and percutaneous biopsies. So therefore, the advantages of EOSLB are that it is safe. The bleeding complication is comparable to TGLB and it is superior to PCLB. Pain is superior to TGLB and PCLB. The recovery time is faster than both PCLB or TGLB. You can do a concomitant endoscopic procedure. You can do concomitant sampling of other tissue, like supposing there is a mass or there are nodes, those can be sampled. It can easily be done in patients with morbid obesity. Bilobar sampling is possible, and it can be done in patients with ascites. The disadvantages obviously are that it is a newer procedure. Most clinicians are still not familiar. In fact, it has still not found its way in hepatology textbooks. You need equipment, while the other two hardly need equipment. It has a learning curve. A right lobe access may be difficult, and it involves a high cost. So what is the current status? I mean, this was all about the theory of liver biopsy. So now the current status of how many people are actually doing it. I did a small survey in which I contacted all high volume centers in the country. The responses were as follows. From AIG, Dr. Sandeep said they did it often, but not always. And the indication was same as PCLB. Dr. Vikas here said that they do it only for selected patients. And the indication were if it was being done for some other indication. Dr. Medanta said that they do it only for selected patients. And if EUS is being done for some other indication or for obesity, ascites, or dilated OFDR. Dr. Rana from PGI Chandigarh, again for selected patients. Otherwise, they routinely do PCLB. The selection being obesity or if both lobe biopsies are needed. The only person who said that they do it routinely was Praveer. Unfortunately, he has left. So Praveer said that they do it in every patient in his unit as a routine. So every liver biopsy in his unit is being done as a ES liver biopsy. Dr. Vikram ILBS, which mind you is a high volume center for hepatology, also said that most biopsies are PCLB and it is only done if ES is being done at the same time for some other indication. Before the time of liver biopsy has come, but probably it could take some more time, some more refinement. And what is going to happen in future is the specialty of endohepatology. So probably when you get a patient who has liver disease, you will subject him to EUS. You will assess the fibrosis by shear wave elastography. You will measure the total hypertension. You will do liver biopsies. You will treat gastric varices, and you will sample ascites all in the same session. So EUS is going to have more application in hepatology than it has in gastroenterology. And one of the things of the future, Praveer already showed you this, is the EcoTip Insight, which has been developed, where you can measure pressure from the portal vein and the hepatic vein, and then calculate the hepatic vein pressure gradient. Thank you so much for a patient listening. I believe that
Thank you, Dr. Yogesh, for excellent presentation. Which needle do you prefer, Dr. Yogesh?
19G acquirement.
What is your take-home message, in the present time? One should go for percutaneous or one should go for EUS carotid?
If facilities are available and the patient can pay, one should go for EUS carotid. Because it is much safer, the patient gets up and just goes on.
Thank you, Yogesh.
Thank you.
Isn't this book inside pressure measurement available in India?
Not as yet. Not as yet.
So we have to choose for the duodenal pathway. In that situation, the size of biopsy like 19 gauge, it is very difficult to.
Yes, it is.
So what is your opinion? How to?
So straighten the scope as much as you can.
Right.
The straighter the scope, the easier it will be for the needle to come in.
Can't we use the Boston 19 gauge next for such a situation?
You can. You can.
It's probably the best solution today.
Even the Olympus standard needle is pretty flexible. That also can be used.
In 19
In 19.
Where do you need the bilinear biopsy? Usually single biopsy will suffice.
That is what I showed you in one of the slides. We need bilateral biopsy because a lot of issues have come up about staging. So if you talk to a hepatologist, if you do a simple liver biopsy, there is a discordance of about 41% in patients of MASH. This is a very famous study published in gastroenterology. So if you're planning strategy based on just one biopsy, it might actually not be adequate because the liver is not diffusely affected by all diseases. It is mostly affected patchily. So if you do a bilateral biopsy, you get a much more representative sample and you can actually be on much more surer footing. So staging of liver disease based on one biopsy might not always be correct.
So how much passes is adequate? How much passes 3?
3 is a maximum limit. You should not go beyond 3. But new needles are being developed. Like there is one paper who said that with Charcot only 1 pass might be sufficient. The lesser the number of passes within the liver, the better it is.
3 means including left lobe and right lobe? Total?
No, 3 at one place.
At one place, because the longer.
Yeah.
Thank you, Dr. English.
So one last case, so we move to the live case as to gastrostomy.
With the case of acute necrotic pancreatitis, week 16, he had a PCD infection from outside, and the drain output is around 800 ml per day for last 2 months. The drain mileage is more than 10,000. The issue with this patient is he is having persistent pain, his oral pain is reduced, and having persistent drain output. CT scan done 10 days back has showed a peripancreatic collection with lot of debris, and there is not well-formed cystic wall. There is calcification in the pancreas parenchyma as well as pancreatic duct. So we have Dr. Saurabh Mukhlevar, who is sure when to intervene and when not to intervene in the case of acute necrotic collection. So over to you.
Hi, good evening, everyone. Can you guys hear me? Hi. Yeah. Can you hear me? Okay, all right. So I think you guys heard the history. There's a picture with an acute necrotic pancreatitis. Because peripancreatic collection has been already. So this patient has undergone spontaneous brain incursion. So what was the CT scan performed, which we are going to show the camera on the scan, which you can see, and couple maybe can help us point out the percutaneous drain that you can see going inside the cavity. So the reason the patient is being taken is because there's felt to be a persistent collection based on the scan at least 10 days ago, which as you would imagine, we would prefer to have internal drainage as having them drain for a long time can lead to a percutaneous fistula. So that's something that can be very annoying and hard to treat in these patients. So therefore, the patient is being considered for a transmural drainage of the collection, which will permit us to hopefully at some point remove this percutaneous drain and eventually not have fistula as a problem. So if you are planning to do this, you can have a transmural option. In this case, and I'll show you what we found as we went inside. I'm going to go towards the gastroesophageal junction, and right here I'm at the G junction, and whenever we evaluate these collections, looking at if you look at the scan, in some way sort of the greater curvature is where you will expect to see the collection in the body tail region of pancreas. Okay. So now as we are here, we just put the scope down and then I'm turning clockwise, counterclockwise, and this is what I'm encountering. Okay. So let me use my cursor to point and show you what we are looking at. So at the outset, as most of us would look at this area and imagine that this whole thing here is probably maybe a collection, although this is not walled off. As you can see, you don't see the distal parts of the collection. What you are able to see is a lot of what may appear as artifacts
And, this is leading to inability for us to visualize the deeper portions. Now, it can be, you can get easily fooled by imagining and thinking that these are the walls or the lateral aspects and this is the necrotic collection. But the reality actually is that this patient has a completely drained collection percutaneously. And what you're looking at the screen as I'm pointing with my cursor is the wall of the stomach. Okay. And right here, you see this liver? I think we are going to focus in a little bit. So this is actually the collection, which, well, unfortunately, to break the bubble, has already been drained with the percutaneous catheter. And the problem that we are encountering is that there's 700-800 ml of pancreatic juices coming out on a daily basis, which has led to the decompression of the collection. So I think this is just sort of highlighting the point that whenever you are evaluating a wall of pancreatic necrosis, what you have seen in textbooks, videos, demonstrations, what we have probably some of you are doing it, is a nice, well-formed collection. So whenever you have doubt, you should not do an intervention until you are comfortable and confident that you know exactly what you are encountering. Because getting fooled into thinking this down here is a collection would can basically create a big perforation in the stomach and you're deploying a stent in line outside the pancreas. What in reality you're looking at is this over here is the pancreatic parenchyma, which is necros. So if ever you put your US in necrotizing pancreatitis patients, remember this is how it looks like. This is all ill-defined heterogeneous back necrosis, which is leading to this appearance. Okay, and as we zoom in, and actually we also confirm this by the way, because we inserted some normal saline through the percutaneous catheter, and we could see a lot of flow in this region between the stomach and the necrosed pancreas. And that sort of confirmed that for us. Yeah. All right. So that's that. And
Saurabh, can we inject more fluid through the PCD? I think maybe 10 or 20 ml.
What we are actually saying. And for all of you beginners, I'm going to use my cursor to point out. For all of you, as you can see, the gastric wall is really, you have to identify the layers of the stomach as well as you are encountering this. Of course, there's edema and swelling in these patients. All right, so now we're going to have injection. Now you see all of you?
Yeah.
The injection is being performed. And let's see. Yeah, there you go. Okay. Yeah. So this is right. So now 20 cc of fluid is being injected, and you see a lot of activity here. So this is actually the collapsed cavity, and that's what we're dealing with. And of course, I think it's I don't need to explain why we are not going to do cystogastrectomy here because of a completely collapsed cavity, and if you really want to measure the thickness, we are dealing with something that is basically 1.8 millimeters of thickness.
So if this patient has PCD in situ, and he may develop the pancreatic fistula later on, and maybe the DPDS also. Right. So do we have any use-guided solution for that in the future?
Right. I think it's a good, interesting point in regards to the state here. Because see, bottom line is this patient needs the drainage of all the necrotic material and pancreatic juices to flow internally, which means this can be transpapillary, this can be transmural. In some way or the other, all of this has to drain internally. Now, a transpapillary stenting with an ERCP can perhaps assist in helping this. But again, now if you really had to do something, again, what we could potentially consider, again, this is not something to demonstrate for beginners by no means, would be in some way or form to distend this cavity enough that we can actually get a plastic stent across the gastric wall into this cavity. Now, we can do it in some patients, but not for demonstration, which may involve us tapping the tube, perhaps putting more normal saline, and then doing this procedure with a plastic stent.
So some patient may develop DPDS actually, and the ERCP may not be feasible. Then the only option we're left with either is the pancreatectomy or the use-guided internalization.
Correct. Yeah, I hear you, and I think the point is to get a pancreatogram to understand what we are dealing with. Is there a pancreatic leak into this collection, or is there a completely disconnected pancreatic duct?
Yeah.
Because if there is a leak, yeah, you can probably go across and plug the leak internally. But in a pancreatic disconnected duct syndrome, it's quite difficult, as most of you do, as you can understand, to get the wire across the proximal part, which is the sort of orphaned area. And therefore, traversing that can be an extremely challenging situation. Ultimately, for doing transmural drainage, you'll need something where you can put a stent in.
Yes.
And that's not this right now. No. What do you think, Kapil? Yeah. I think it's perhaps this is a case we should tell we're not doing it. Yeah, I think it's an important demonstration to understand what is normal, what is abnormal. So very doing international US, you need to spend more time understanding, recognizing structures. And honestly, somebody who's not experienced can really get fooled into thinking that all this is the cavity, which it definitely is not. So you can create a major problem by planning to intervene and putting the stent here.
So this whitish part with the shadow, is it the pancreas or?
Yeah, so because that is a necrosed pancreas, and what you learn from pathology would be the fat necrosis of the pancreas that leads to mesentery and peripheral tissues in the pancreas getting necrosed with the lipase, and therefore this is the appearance that you're getting from a necrosed pancreas, which is causing a lot of shadow and this sort of appearance here. Yeah. Now I guess that hopefully just illustrates the point about drainage of these collections and of course several challenges associated in our country with repeating scans, etc. But yes, what we would ideally prefer is a scan that is done within a 48-hour span that tells us exactly what is going on now. When we decide to intervene. Of course, we do have a lot of practical challenges and that cannot happen in every patient. But yeah, just something worth considering as we look at this patient. Now, what I can also show you is the pancreatic duct, head of pancreas in this patient, and which is a nice chronic pancreatitis illustration. We have the scope in the duodenal bulb, and what we are going to do is look at the head of pancreas. Sorry, Vikas will say something. I'm happy to answer anything that you say. Questions.
Yeah, some patient, I mentioned some patient may form the external pancreatic fistula and the ERCP may not be feasible. So what we do from the PCD side, we pass a ultra-thin scope. Okay. Yes. Then through the ultra-thin scope, fill the cavity, we distend the cavity with the fluid. Right. And with the endosonal, you can see the fluid inside the cavity, and then we pass a guide wire through the needle. Right. And through the ultra-thin scope, we can see the wire, we can grab the wire and take it out from the PCD side. Then over the wire, you can place the stents. So,
yeah, no, I think that's a great point.
And we have done actually, we have done 1 4 5 cases with the technique, double scope technique.
Very nice.
And we found it very useful. Yeah.
Yeah, thank you. That's great. I mean, you made a good point. Certainly, with a posterior axis, we can put endoscope inside to validate the cavity.
Yes.
And I think certainly in this case, to make it even safer, would be a double endoscopy.
Yes, yeah.
Visualized. I think that's a very good point because you made. I suppose we don't have time for that today, and the posterior start is not dilated enough.
No, I don't think right now we have indication. The patient is during the pulse. So I think if he forms a fistula only then we should do it.
Yeah.
Not otherwise.
Right. All right. So anything else? Yeah. I think we can just sort of end it there. Any questions from the audience about this? I'm happy to answer.
So how is the gallbladder? It's a
the gallbladder actually there were some stones and debris in the gallbladder.
Yeah.
This patient may have developed acute pancreatitis. All right, there you go. So what you're looking at is the gallbladder, and there is all this shadowing suggestive of stone in the gallbladder. It's collapsed on this view across the duodenum. Maybe I'm looking at the sort of SIPs in there. Yeah, there you go. The body of gallbladder. Some stones in there. Yeah. So this patient has chronic pancreatitis, but on top of that developed an acute attack I don't know if it was alcoholic or not, but this could possibly be biliary, but I guess you have to look back at the chart to see whether he had any indication, anything that would make us think that this is biliary.
So with the bile duct clear.
Yeah, so the bile duct is actually very thin. It's like about 1 millimeter earlier.
Okay.
It's completely collapsed. A little hard to visualize, but I could show you the pancreatic duct, which actually has parenchymal calcification as well as a small intraductal calcification. Yeah. Very,
द्वारका जो टप्पे सी कल
yeah.
तो लंके गया
Right. So you see there, like that's
Yeah.
all calcification.
Yes.
Right there. That's all parenchymal calcification. That's the duct right at the bottom. And then there is a calcification, which is, in my opinion, coming outside from the parenchyma, getting inside the pancreatic duct and causing a slight obstruction there. That's what we see. That's the pancreatic duct. Probably, maybe here, maybe won't see. Yeah. All right. Yeah. That's,
I think it's a very tiny duct.
yeah, the bile duct is
Wonderful. Yeah. You can see the collateral also actually.
yeah.
I think the patient had thrombosis of the portal assembly.
Right. Okay, great. That's that. Anyway, so yeah, because happy to answer any questions. Because I think we demonstrated what we should.
Yeah, I think that's a wonderful demonstration. And thanks for teaching us when not to intervene. When not, you can harm the patient otherwise.
Yeah, I think this is a case that nobody would plan to keep in the live demonstration.
Yeah.
There is something to learn from.
Actually, we were misled.
Learn something.
Yeah, we were misled by the CT scan actually. The CT showing the large collection 6 centimeter.
Yeah, exactly.
Yeah.
And two things to learn from it, that, how it should look, and yeah. But I think it's important, very, very important learning point for anyone beginning to do the cystogastrophy. This is what you should not do.
Yeah.
Okay. All right.
Yeah. Thank you, sir.
So I think we'll just pull out the scope. Thank you so much.
Thank you. So with that, we've come to the end of US Update 2021. Thank you all for making this a grand success. Thank you. He's been served, church. So tonight.
हाँ बंद करो अरे 2 मिनट लाइट ही नहीं मिल रही ना अभी मिलेगा